Good morning, ladies and gentlemen. Welcome back to the 17th Annual Academic Sessions hosted by the College of Otorhinolaryngologists and Head and Neck Surgeons of Sri Lanka. We would like to begin our annual academic sessions by a welcome address from our President, Dr. Yasat Weerakkodi. Sir, over to you.
Very good morning to all of you. It's my pleasure to welcome all of you to the scientific program of the 17th Annual Academic Sessions of the College of Otorhinolaryngologists and Head and Neck Surgeons. On behalf of the college, I also welcome all the eminent speakers who would be sharing their knowledge and experience with us during this session. At the outset, I would like to thank the resource persons for their contributions in making this event a success. This is the first time since COVID-19 pandemic began, we have managed to organize a physical event of this magnitude. A total physical program was not possible due to obvious reasons. Some of the OC speakers had to join the event virtually due to the COVID-19 travel restrictions. The theme of this year's sessions, as you know, is Precision Tools in ENT, the Way Forward. Professor Ramandeep Quirk, Professor Prathamesh Pai, and Professor Suren Krishnan, Professor Nirmal Kumar are the OC's resource persons of this event, while Dr. Chandana Arampanawa and Dr. Daminda Domingarachchi will join the event as local resource faculty. As the theme suggests, resource faculty would be delivering their presentations with surgical demonstrations on modern tools used in ENT practice. Coblation, laser, and robotics are the selected topics for the presentations. Coblation and laser are tools which have been in use for some time, but only a very few major hospitals have these facilities. Robotics is yet to be introduced to Sri Lanka. The program consists of presentations by the resource persons, a panel discussion, a free paper session in which interesting research papers should be presented by the PG trainees. I hope this session would provide the participants the opportunity of updating their knowledge on the use of the modern tools, which should be the future of ENT. Thank you.
Thank you, Dr. Yasat Weerakkodi. We have a very interesting first session coming up ahead. The session will be chaired by consultant ENT surgeons, Dr. Yasat Weerakkodi and Dr. A.D. K.S.N. Yasawardana. I would like to invite both of them to the head table to begin the session.
Good morning. Welcome to the first session of the annual sessions today. And we begin with a very interesting lecture that is robotics setting up a service and way forward. And the speaker does not need any introduction right now because he's none other than Professor Nirmal Kumar, who is the current president of the ENT UK, which is the British Association of ENT Surgeons. And he's a professor in the Edgehill University in UK. And he has been our foreign examiner for our PGM for past several years. And I must congratulate him because he recently won an award for the from UK body which recognizes his effort looking after the membership of the ENT UK, especially in the COVID pandemic. So congratulations, Nirma. So now can I invite Professor Nirmal Kumar to deliver his address.
Sorry, I'm limping after last night's dancing. Ayubowan, good morning. It is a real pleasure to be here this morning. I begin before my presentation with a little tribute. Yesterday was a really momentous day for me personally, and for those who don't know, it began with a very royal visit to the sacred shrines of Kadragama Devalya. It was a pleasure, but also more importantly, to be receiving the honorary fellowship of the college. So again, thank you all. It was a real honor. I have something as a small token in return. This is called Jaan. Jaan means life and love in Hindi. And as a token of my appreciation from British Indian heritage to the president of the college, I would like to thank you. Jaan is actually a drink made from the pan that we eat as a digestive. Perhaps after all the hard work, you all can join and have a drink of pan, which is made by a family in Canada, a British Indian family. I also had the honor of giving that drink to Her Excellency, the High Commissioner of India, only the second High Commissioner who's a lady in Britain after, I think, Vijayalakshmi Pandit, I think, one of the very famous, eminent Indian personnel. What I would like to begin by talking about is about robotics, setting up a service and the way forward. I have personally bring to you greetings from the community of robotic surgeons in the United Kingdom, and I will mention the names as we go along. I also have an international training fellow who has helped bring together the material for this talk, because we put a lot of effort. We recognize that there's no point in coming and saying, you should do this, this is the fancy equipment. How do we do it in a cost-effective way is what matters really, isn't it? And we have to utilize the benefits of research and the National Institute of Health Research, of which I'm one of the leads in the Greater Manchester region. And finally, the ENT UK Foundation, which I mentioned about yesterday. Professor Vin Pellery is a colleague and friend. He is a consultant head and neck surgeon at the Royal Marsden Hospital. He was previously in Newcastle. And he actually was mentored by one of your resource persons, Professor Suren Krishnan, who remembers Vin with great fondness. He helped to put this presentation together, so it's a joint presentation because we want to convey how training in transoral robotic surgery and the establishment of a service can be done. Training is important. In Britain, you know the two communities that have the highest educational attainment. One is, anyone who wants to shout out? The highest educational attainments in the United Kingdom. Which ethnic community? India. And number two? Sri Lanka. So Sri Lankans and Indians occupy the highest pedigree in education in the British system. So we should emphasize the importance of training, because if we set up a service without the appropriate infrastructure, but most importantly training, we will not succeed. So we'll go through how to set it up, what are the applications. I'm sure your other resource persons will give you more details in the clinical applications, but how we assess the impacts of such a service. So the robot comes from the word robota, which means forced labor or activity. The trainees may say they have forced labor, but that's part of your training and how you improve and learn. The first robotic procedure was performed not many years ago, and first in ENT was in early 2000s. Obviously, the applications have increased significantly in this period of time. When I was starting out in ENT, when I was like the trainees here, the newest forms of endoscopic surgery I trained under Heinz Stamberger, and then with Hugo Fisch and others in Europe, they were pioneering endoscopic surgery. Now you are at the threshold of the other surgeries that you may have to work with in future, whether it is sinus navigation systems or robotics. It is apt for ENT. Why? Because we work in small orifices, natural orifices, and these specially wristed instruments can allow for preservation of the surrounding critical anatomical structures. But as I keep saying, education and training is the key for broad use. And finally, the benefit for the patients, the outcomes for the patients is what matters. And the initial work in ENT emanated from the University of Pennsylvania and later gained momentum. Actually, my anesthetist, who I mentioned yesterday, who had COVID and suffers from nightmares, his friend in the Jipmer Institute in Pondicherry, a very famous institute, they were classmates together, he's a bit senior to me, Mr. Menon, established robotic surgery in urology in the United States. The first robotic surgeon in the Henry Field Institute in Denver. And that is an example of how pioneering some people could be. And he spent hours, Mr. Menon, learning robotic surgery. It took a long time initially when he was doing it for prostate. And now you know for prostate surgery, it is accepted. So the next few slides are actually from Prof. Suren Krishnan. I have collaborated with him in trying to bring you what the best academic input for your session, because he was going to talk about the clinical applications. So he said we must always justify when we use it. Just because we have a new toy, sometimes in the United States and in India, they get these big fancy toys and they just use it willy-nilly. We need to learn to use it appropriately, design a program, maintain it, and successfully continue. And the sustainability is what matters. And the clinical justification is quite immense, even in the COVID era, because of all these surgeries that can be done in small confined areas. When I was a trainee, our big commando operations were the big things we used to undertake, but no longer needed. You can get by with much better precision. And some of the things, when I was speaking to Win Pallery, Prof. Pallery and Professor Suren Krishnan, I realized that the innovations that are coming at great pace. And even cochlear implants can be done very soon with robotics. But anyway, sticking to the business plan one has to undertake before you can justify it to your hospital managers is the cost, of course, of the robot. And don't forget the cost of the consumables that will be required. Training, it's a multidisciplinary training. You can't just be a surgeon starting out on a robotics program. You have to have good anesthetists, good training for nurses and support. The which surgeons, you must identify the surgeons, have a mentoring scheme. And one of the collaborations that the UK is willing to offer is to mentor and support. Again, I can mention Dr. Yasavardina telling me about how Professor Mohan Kameshwan helped set up the implant service here. Similarly, for the robotics, there will be some system of mentoring which we can offer. And of course, at the end of the day, there must be good pathways for care. This is very good in the United Kingdom. We have good pathways for patient care, which will allow good justification and multidisciplinary assessment of the patient needs and then what they will benefit from. Of course, we in ENT are used to a lot of equipment, isn't it? Even if we do endoscopic sinus surgery, the kind of equipment, the ergonomics of the team to protect your neck, your back, the safety of the patient, and the configuration of the operating room is going to be important. And the lead surgeon, you're the champion of cause. You have to be able to coordinate the team and training. And some of the aspects of training, which is perhaps not as clearly emphasized, is about the non-technical skills. It's not just the surgical skill that matters, and we'll talk about that more. So for trainees, we have implemented a very planned system, and there were some early results from this, where we first had some online modules. So something good in COVID, you can do some of the early learning, you can plan some of the tasks that you undertake, and the mean time to completion can be assessed. And everyone has a learning curve. I wasn't the fastest learning curve for surgery, but sometimes if you learn the hard way, like I did, you learn to respect the patient, and their outcomes can be improved. Some of this has come out in a very small lettering, but hopefully you can still see. So it's important that we identify our mentor who is able to support us. Early on, apart from the training modules, you must have hands-on sessions which will allow one to practice, first of all, in a virtual setting and perhaps in a cadaver lab. And sometimes it's good to work in teams. In COVID, we learned that a lot. It is initially useful to see how other teams work. You may have a urology team that is doing it already. You must, and we'll talk about getting the robot, it must be multi-speciality use. Only then we will gain from each other and the cost effectiveness improves. How the assistant or the co-surgeons work together, and what we call proctoring. I'm sure you've heard of this term in training. Proctoring is when senior consultants starting off on a new procedure are proctored by established consultants in that field. And we have a very good system of that. So we developed a module called the Fundamentals of Robotic Surgery, which allows people to, over a period of time, develop certain defined outcomes that we can then say we have completed this and we are ready for the next stage. This has been supported by many, many bodies and official organizations, including the Royal College of Surgeons, the Society for Robotic Surgery, the US Department of Defense, which is a group that really has pioneered robotics in other aspects. So what are the curriculum principles? I'm going to concentrate on what we need to, as trainees and as surgeons who are starting out on a new skill, learn. There are three types of skills that we all have to develop. We need to have the knowledge base, the cognition, the cognitive skill, which is important. We need to have tactile skills, the psychomotor development. But not to forget, and most important in my opinion, even a monkey can be trained to operate with tactile skills, but it's the decision-making, the non-technical skills, the communication, how the plane landed on the Hudson River when there was a problem was not because of luck, because the pilot had practiced simulation of that. So it's about really good following of the principles of practice, the Erickson's principles of getting 10,000 hours in what you do. I'm aiming for 10,000 steps in my walking every day. I don't achieve that all the time, but it's an important example of consistently improving your skills. The delivery of the curriculum by surgeons who are appropriately qualified to deliver this, and then the measurement of outcomes, the competence-based outcomes. You must have a standard operating procedure or pathway of care for the delivery of surgical care for these patients, so that there is a cost effectiveness that can be enshrined in showing your managers that the outcome. The next couple of slides are most important in my opinion. We must talk about cost effectiveness. We must talk about the ability in a lower resource setting to be able to deliver advanced care. We should know the concept of purchasing power parity. In purchasing power parity, what we talk about in dollar terms should be adjusted for that particular economy. In the United States, they may say that for a certain threshold to be achieved for cost effectiveness, we need $30,000. And actually in the UK, National Institute of Health and Care Excellence, of which I'm a specialist advisor, have determined that it's £13,000. But you should not worry about that. The cost effectiveness threshold adjusted for purchasing power parity, which is a term you have to understand, is lower for India, for Sri Lanka, and for countries such as this. South Africa. South Africa is another. I have a lot of international trainees who come from South Africa. And along with Sri Lanka, I say South African training is of a very good standard because they follow, even they don't have huge amount of resources, but they allow their trainees to get the appropriate. So this 12,000 figure, which I put there, is for the United Kingdom, but it should be adjusted. And unfortunately, healthcare is becoming very, very costly. I'm researching biologics, as I say, and each monoclonal antibody that we use will be several £100 in its estimated costs. But remembering the revision costs for surgery, for nasal polyps, for example, and the morbidity of repeated surgery, don't forget that. So always you must factor in the overall cost for the patient. So if a robotics can do something with minimal morbidity and allow the patient to go home earlier, return to socioeconomic productivity, that is well worthwhile. And that's part of what we need to use to justify the case for setting up a service. And I hope in a few years' time when I come, you are able to showcase and develop this kind of service. Of course, in a teaching hospital where you must have this to begin with, you will have a hub and spoke model, and you may have some donors or academic funding pathways. You must have a good relationship with your fellow colleagues, and they have that in the United Kingdom. We have only 3 or 4 main robotic centers in ENT. And it's important that we concentrate our efforts so that we allow the next generation of surgeons. So I go on a little bit about this clinical and cost effectiveness. It is a game of two halves. We need to be able to justify to our economist. I remember when I introduced balloon sinuplasty in my practice about 15 years ago, I was one of the first to publish the outcomes from it. Excellent outcomes because the patients were low morbidity. But what I could not justify, I had an excellent manager at the time, she said to me, show me the cost effectiveness. And I could not show it for generally unselected cases. Now I select and do it in a very small, precise number of patients. And this is again, unlike the American and Indian systems where they use it widely without proper justification. We must be able to justify what we do, whether in the NHS in the UK or here in Sri Lanka. So you need to be able to show in Lankan rupees, Sri Lankan rupees, I believe the acronym is LKR, if I'm not mistaken, what we understand by the term quality adjusted life year. And that is the most important thing that you will take away, hopefully, from this talk today. And you can convert it on the basis of PPP, purchasing power parity. India's GDP per capita is low, but if you do per purchasing power parity, it is quite high, and I'm sure that's the case in Sri Lanka too. And there are many procedures you can think of. If you think of an implant that you do, how the cost may be quite high. You were telling me, Dr. Yasavardena, that you can get this sometimes in bulk, and you can, per implant, the cost can be reduced. The socioeconomic benefits for the patient, the improvement in their quality of life. So we talk about cost effectiveness ratios. So the initial cost may be high, but the benefits for that child becoming a productive human being, that's the example. And similarly for robotic surgery, you do a commando operation that I used to take pride in doing 30 years ago, and you leave the person as a completely dependent person who is a drain on society. Whereas if you make them a completely normal, functioning human being, the benefits for society are immense. So please always remember quality-adjusted life years. When the trainees do audit, do understand about thinking about the subjective well-being of patients. Yesterday I gave an example of the loss of sense of smell. What an impact. Could we all enjoy the food and drink that we have? It's an impact. So you must always remember that in your outcomes for patients. We should not practice like our predecessors, where we inflicted the most horrendous operations on the patients and then allowed them to just get on with it. We need to understand about functional ability and subjective well-being. So the business planning must include requesting and developing good data about your patients. What type of patients you will include? How will it reduce the length of stay? And a simple example I gave, we were asking in the exams the other day about using drains in thyroid surgery. And I remember 25 years ago, I used to drain every patient, and then the length of stay is high. So similarly, when we are able to do a procedure that reduces length of stay, faster recovery, it is important. And of course, part of the calculation will be about the recurring costs, the disposables in the instruments that we use. And we should show non-clinical administrators that robotics will benefit patient care. Of course, it is a nice toy to have, and you may think curiosity will be enough. It is only a group of very enthusiastic, pioneering surgeons. But really, it should develop purposefully, sometimes slowly. My brother-in-law is a colorectal surgeon, and he's taking a long time to develop a robotics program. But each step requires audit, assessment of the benefits for patients. The team leaders in the operating room should be empowered to give feedback, and your trainees should be the leaders of this. So some of the examples that Win shared with us was the management of pharyngeal and laryngeal cancers, where it has now passed the test of time. It is a widely accepted modality, and we can really justify its use. And slowly, it is also coming into in play for the oropharyngeal cancers. And the less number of complications that are noted, especially in salvage surgery and the post-op requirements. It's increasingly a field. I had the pleasure of going to your pediatric children's hospital and seeing the ENT unit there. It's a wonderful unit. The best thing I liked was the ventilation of the wards, which I must go back and tell my staff in the hospital. This is what I talk about, learning from each other. It is about designing and using it appropriately. It may be useful in the airway work that you do. And of course, the limitations being the surgical access for robotic arms. So be a little careful before going into pediatrics. The justification can be very clear. You must have an algorithm. Just because you have a robot does not mean we do every case with it. Initially, the surgeon well experienced in robotics may decide on the certain type of patients, the younger patients for whom cosmesis is more important, and you may do a robotic neck dissection as opposed to an older patient, where discussion may allow you to do the traditional surgery. We must use technology-enhanced learning, by which I mean the use in the simplest forms of IT and the benefits of that. Of course, in the advanced forms, we have virtual reality training. But really, technical, non-technical training can be done in a team spirit. and using standard learning tools to improve our non-technical skills. That's where you make the most gain in your setting up of a service. And most teams learn, they enjoy working together and the leadership of the team. And the training programs are cross-specialty. I run an airway clinic with my chest physician. The best clinic, my trainees enjoy working with a chest specialist. So similarly, for our training in robotics, remember learning from other specialties. And I've already said to you about the non-technical skills. Just wondering about the time. Are we okay on time at the moment? You okay on time? Yeah. So the non-technical skills are important. We can use web-based mentoring to allow international involvement. I mentioned this yesterday. We have this ENT UK intersurgeon, which links up trainees, whether it's a pediatric specialist in Royal Manchester Children's Hospital with a pediatric specialist here, or similarly for robotic surgeons that we can link up with colleagues around the United Kingdom. One concept I'd like to get across to trainees is about patient-reported outcomes. Again, to emphasize that the measurement tools that we use to harness information must be used to record real-time changes in the health status and assess against the patient's progress. I'm not saying we have this for all patients in the United Kingdom, but we have it in certain groups of patients, and we certainly should have it when we are developing a new service. We must put it in the outset in the business plan. And research and analysis on validating the type of questions you ask for the patient. As Albert Einstein said, you need to spend 55 minutes out of the hour to decide the type of question, the specifics of the question, and spend only 5 minutes on deciding what the answer should be, because we need to be precise in asking. You must measure outcomes in absolute terms. Death, survival is an absolute thing. You're either dead or alive, isn't it? But you must also be able to measure morbidity. You must measure outcomes in softer terms and measure the change, the extent of the symptom improving. My simple example of a smell improvement, was there improvement in the time after the smell training was done? The simplest example. And cover the range of factors, not just their ability to carry on with their day-to-day activities, their own perception of their health status, their social functioning, the psychological welfare. We should never, ever forget that. Our patients deserve that. And one of the things, again, I see across healthcare systems, you as doctors are occupying a very respected position in society. In Sri Lanka, you still have that. So please preserve that at great cost. Because in some countries, and again I'm referring to some countries, the positive we have in America and India, but in the opposite end of the spectrum, there are some places where they think they are only doing it for monetary gain. And the United Kingdom is like Sri Lanka. We should remember that our psychological welfare, the satisfaction of our patients with what we do for them is important, and to maintain the respect. So using a composite score on all those criteria for progression and assessment for the patient will be useful. And again, do it in a small cohort of patients, assess the differences over a period of time, 6 months, 12 months to begin with, and you will notice the difference. And you can start off with the online educational modules, the virtual reality skills training, and then go through. And even doing a tonsillectomy on a pig porcine model, and then do post-training performance assessment feedback. It's a loop to try and improve our skills. This is taken from the urology curriculum and using a similar system, recording how the person has done. Nowadays you have such simple methods of assessing outputs by video recording, and you must use that. A nod and an acknowledgement of the vast number of people who take part in a team. Win Pellery is in the center of that team, but you can see the whole host of specialists, nurses, and again, one great thing about seeing on the pediatric ward when I visited the hospital day before yesterday was the excellent nursing care that is offered to your patients, and that's important. And it's the team that is most important. There are one or two other colleagues who gave me some examples. One of your own, Dr. Bibantha Pereira, is starting as a year in a position in Birmingham, and he's working with a colleague called Mr. Mriganka Day, who is set up more recently a robotic program. And he shared a few slides. He said it's most important that any robotic program is set up in a multidisciplinary way, but you must have regular access. You can't have the general surgeons, and there are no general surgeons here, hopefully, who will say, or colorectal surgeon says, oh, ENT can have it only for half a day a week. That's not enough. You need to be able to use it for a good length of time. You must be able to have a staggered approach, one surgeon per training so that you can concentrate the cases, and you must have a minimum volume. When I set off in ENT UK more than 10 years ago in certain positions, I mentioned the importance of volume in surgical practice, and we set it up for thyroid surgery, for example, because thyroid surgery was done partly by ENT, partly by general surgery, partly by endocrine, and we set a minimum number of 20 cases per annum. So I would recommend a similar volume-driven. And at the end of the day, he says the same things. It's about the reputation of the hospital, improving outcomes, attractiveness to patients and to surgeons. For trainees, optimize the strategy of emphasizing to your managers about length of stay, bed turnover, and reimbursements. So the health economics are part of what Mr. Day set up in Birmingham when he set up the robotics program a few years ago. And one lady who I should mention in Birmingham, who's a robotics lead, is Somaya Siddiq. She did part of her training in Tata Memorial Hospital. Of course, she's a UK trainee and went back and is a robotic surgeon. Another is Nasreen Uza, who's a female surgeon who has set up a robotics program in the northeast of the country. So it is available to all of us, and there's no limitation, whether it's a female or male, or it's about the proper training that we have. Conversion rate, complications, readmissions, you must monitor all of that. And this is a slide that he gave. I won't go over it because it's fairly similar in saying where you go through a stepwise progression to advanced training. I leave you with a video which draws tears to some people's eyes. It is a charity that I'm a patron of called Shout at Cancer. This is a Northwest charity for head and neck cancer patients who, of course, in the past had their larynx removed for laryngeal cancer. But this charity is so close to my heart. I'm a patron. We are also proud that they won the Queen's Voluntary Service Award. And I will try and play this if I can. If I can come off that and I go on to the, yeah. Sorry. I hope the volume comes up. We did check it. Sorry, I'll just leave it on. It's okay.
Ain't got no cause, ain't got no smell. My brain and tongue, it don't talk too well. Ain't got no love, and that's hard to swallow. Can't have a meal without a fight. Got my hands, got my tongue, got my breath, got my hands, got my eyes, got my nose, got my mouth. I've got my poems, got my friends, got my songs, got my lips, got my heart, got my soul, got my pride. I've got my goal. We found our voice. Yeah.
Thank you. That was the kind of ovation that I got in South Africa too, with such a moving performance. And the conductor of the orchestra is a young ENT surgeon called Thomas Moores, who dedicates his life to, he's obviously musically inclined. If you ask me to sing, people will escape from the room. But he really allows these people to have that voice. Our patients need the voice. Your patients need the voice. We are here to deliver good quality health care. Why have I lost my presentation screen? Because I want to put up to say thank you. Bohoma Shtuti. Thank you for your attention. Do I take any questions? Or?
Yeah, if anybody, thank you very much for your excellent presentation, Nirma. And we really enjoyed it, and hope your programs will do in England. Anybody wants to ask any questions from Nirma? You mentioned about the pediatric airway surgery. So was it a successful outcome with the?
At the moment, I don't think we have used it in pediatric airway robotics in a large way. It is very, very nascent, so I cannot give you details about that because both Win and others are adult surgeons. We're getting only small, sporadic reports about pediatric, little difficulties in the pediatric population, but I'm sure in the years to come that will improve. I saw some trainees' hand there, no? Yeah. I like to put them on the spot. That lady there was a trainee there. What do you think about learning in robotic surgery? The back. Yourself, yeah. You're getting a mic, so you can.
Well, I think I've seen robotics being used in urology when I worked in London, but I've not seen it in ENT. So I think that's the step forward. But from my point of view, as a trainee, what I feel is first, we should get the hands on the manual techniques that we've been using for trainees, but maybe one day look forward to learn robotics.
Yes, that is correct. Absolutely right. And as a very senior colleagues here, trainers will say to you, you must learn traditional techniques. And one thing I learned yesterday, which I was asking the examiner a little bit, I was worried about, I was asking about endoscopic decompression of orbital abscess versus external. We must know the landmarks for the external approach before we go endoscopic. Similarly, we must know about the traditional surgical hands-on training before we think about robotics. So it is very important. One of the things that you all still learn is the indirect laryngoscopy. My trainees, I don't think they can do that anymore in the United Kingdom. And that's sad. What a skill that is important to have. So you're absolutely right. But we must learn from the urologists. As I said, Mr. Manny Menon, when he pioneered it, he's a close friend of my anesthetist, personal friend from JIPMA days, from Pondicherry. He used to spend 10, 12 hours learning and then converting to laparoscopic surgery. But this was the first step.
Any more questions?
Rather than whereas in our country, our system is mostly dependent on the government funding, and as we must say, we are not all that concerned about the health economic aspect when it comes to purchasing things and
I understand that, but it is important. Yeah. Because for your conscience, for your own purpose, yes, you can get a robot, but you must be able to use it in the cost-effective way. So I have a joke, I think it's a joke anyway. National Institute of Clinical Excellence is now called National Institute of Healthcare Excellence, and I'm a specialist advisor, so I'll declare the conflict of interest. But we used to joke, it's National Institute for Containment of Expenses. So it is important that we contain expenses. Because you cannot go. One thing we should not learn, Seneca knows that the Indian system, sometimes we were talking about this, they sometimes use robotics, or they bought in Apollo Hospital in Chennai when I was there recently, 1,000 crore Indian rupees for a proton beam therapy. 1,000 crores, 100 million pounds. That's a lot of money, and then they may use it a little bit inadvertently. So we have to be careful about cost economics, even if it is centrally funded. It's good if you're centrally funded, that's fine. You don't have to then worry about the recoupment of the money, not like in Apollo Hospital, but it is important for us. I hope I answered that question.
Yeah, I think India, whereas it comes to the population-wise, and there are very rich people as well. So when it comes here, so even the private sector, they find sometimes, but is the outcome they get, so our caseload is somewhat lower.
Yes, that is important to understand. Your population size, you may have a robotic, but if you go cross-speciality and you then learn from each other and you have access, then your patients will benefit.
Even in the area where I work, there's a private hospital, leading hospital. Now I wanted to get a microdebrider there. So they were asking me, sir, what is the turnover of the patient?
Justification.
Justify the, so I said I can't really predict the certain number of cases and that I'm going to do.
Yeah. That is an important example, but I told you the same example where Mary Fleming, who was our manager, my wife knows her, she's now one of the big bosses in my hospital, chief executive, deputy chief executive. She asked me this question when I opened the microdebrider, balloon sinuplasty, everything for the same patient. But I was wrong. You don't need to do both of that for a patient who has polyps. You need one or the other. Be cost effective. One of my trainees showed me that even the little Surgicel swabs we use, the cost for that. We must remember costs, yes.
This, you said this cost-effective threshold, earlier known as willingness to pay threshold, in UK was about £30,000 some time back, and now it is 13,000.
I have thought long and hard about this. You're a very astute man. In my previous presentation, £30,000 was the quali figure I have used. But in my discussions with Win Pellery and others, and adjusting for purchasing power parity, I believe that this figure is 13,000 now. But I am a little worried. I'm trying to say to you that don't worry too much about this headline cost. That 30,000 figure for quali year, even the UK cannot afford. So we need to...
That's how the bilateral cochlear implantation was effective. It was some £29,999, something like that. So they...
Yes, and that figure is $50,000. But in all these currency exchanges, and my recent edition, I've changed those figures recently to make it this 13. I don't know the answer, true answer for that, because I'm not an economist.
Any more questions? Then, of course, without any questions, I must thank Professor Nirmal Kumar for his presence in our academic session. And you also contributed to our exam, and you're a true friend of Sri Lanka. So thank you very much, and wish you all the best. I know you want to make a flight quickly, the flight, yes. So thank you very much. Thank you.
You have to announce the certificate before you leave. Yes, sir.
Yeah. May I invite Professor Nirmal Kumar to come onto the stage to receive the certificate from the chairpersons, please?
Yes, our next speaker will be Dr. W.M.C. Narampanawa. I think all of you know about Dr. Narampanawa. Dr. Narampanawa is the consultant, senior consultant ENT surgeon, ENT and head and neck surgeon attached to National Hospital, Kandy. He completed his MBBS in 1991 and was board certified in 2001. He has done his foreign training in Sunderland Royal Hospital, and he has been a pioneer laser surgeon in National Hospital Kandy for the past 4 years. He will be talking on principles on coblation and laser. Narampana, over to you.
Good morning, everyone. Thank you, Ranjit and the scientific team for asking me to talk something related to physics. So this will take you a bit away from the excellent presentation by Professor Nirmal Kumar. And I have to say that I was not a good physics student even in my student days. Somehow I tried to do something. So this using rays and the light is not a recent invention. In the ancient world, Egypt and Romans, they knew that there is something other than light in sun rays. So they used that for various therapeutic purposes. That was called phototherapy. In addition to that, they understood if you apply some special things on the skin, the action of the sun rays get enhanced. So it was called photochemotherapy. So these carvings in Egyptian temples and pyramids more than 5,000 years old. So if we come back to a bit of a recent past, in 1900, a German physicist, Mr. Max Planck, he is the first one to deduce that there is a relationship between energy and the frequency of radiation. And the energy could be, according to him, the energy could be emitted or absorbed only in discrete chunks. And he called it a quanta. So that was a real turning point in physics. His turning point, it inspired some up-and-coming physicists like great Albert Einstein. Not very long after, Albert Einstein, in one of his papers about photoelectric effect, he proposed that the light also delivers its energy in chunks. A discrete quantum particle, now he called photons, not protons, photons. And in 1917, again, Einstein proposed the process that makes the nowadays laser possible, what's called stimulated emission. And for these works, he won the prestigious Nobel Prize in 1921. And to understand a bit about laser, you have to know a few words. One is absorption and emission. So I try to understand, and I could not. I'll give you the definition, see whether you can understand it. According to this Einstein theory, beside absorbing and emitting energy, emitting light spontaneously, electron could be stimulated to emit light of the particular wavelength. That was his theory, and to become it practice, it took about 40 years. So this is the theory of absorption and emission. The electron in discrete energy levels of the atom that make up the optical medium absorb radioactive photons and are pushed to a semi-stable higher level of energy. So this absorb energy and go to a higher level. And after that, it emits its photon spontaneously and drop back to the lower energy level. That was called spontaneous emission. And once this electron is excited, it can be stimulated to emit in a way we want. So we can get a output of a beam, some kind of our necessity. So that's called stimulated emission. So that is the principle of laser, the way of laser production, stimulated emission. So what's the difference between stimulated and spontaneous emission? In spontaneous emission, the photon emitted is in a random direction and random phase. But it's not like that in stimulated emission. The photon released will have the same frequency, the direction, phase, and state of polarization as the incident photon. Incident photon means the stimulus you have given. So, people do various things when they have a free time. Some people watch various things, some go and sit somewhere without doing anything. This fellow, Mr. Charles Howard, he used to go to a park and just sit and wait near his university. While he was sitting in that park, he got this idea. What's the idea? The MASER, microwave amplification by stimulated emission of radiation. It was his theory, but he couldn't do it in practice. In 1954, Herbert J. Sager and graduate student James P. Gordon, they are the first one to demonstrate this MASER technology. It was an ammonia MASER, and incidentally that was the first device based on Einstein's prediction of stimulated emission. However, in 1959, a Gordon Gould, a Columbia University graduate student, he published a paper, the laser. That was the first time the laser name came. Laser, the light amplification by stimulated emission of radiation. So, ladies and gentlemen, now we have what is called laser. You all know what is laser. Lasers are devices that produce intense beam of light which are monochromatic, coherent, and highly collimated. The wavelength of the laser is extremely pure, and all of the photons that make up the laser beam have a fixed phase relationship, and the light from the laser typically has very low divergence, no divergence at all. So it can travel for a long distance, and you can focus them on a very tiny spots. Because of these properties, nowadays, lasers are used for various purposes all over the world. Like everything, you need a machine to get the thing out. For laser also, you need a machine. The laser machine is basically composed of three components. One is the amplifying medium, the optical resonator, and what's called optical pump. In the amplifying medium, you have a collection of atoms, molecules, and ions which act as amplifiers of the light. The optical resonator is a set of mirrors. It provides optical feedback to the amplifiers so that it can act as a source of radiation. The optical pump is the energy source to the machine. So, machine gives the laser beam. It has several characteristics. The performance of the laser depends on two main things, the power output and mode of emission. The mode of emission could be of different types. It could be continuous wave laser or pulse laser, quick switch laser, and mode lock laser. I'm not going to go into details of these things. That difference in length and various things and frequency. And this is important, the physical properties of laser. Again, there are four main physical properties of laser you have to understand. One is energy. Energy is the amount of work accomplished by the laser. And then the power. Power is the rate of energy expenditure. The rate of energy expenditure. The irradiance is the power density. That means the power of the laser per unit area. The last one is the fluence. That's the energy density. This is the amount of energy delivered per unit area. That is the most important thing in laser. It determines the effect of laser on the tissue, the fluence. That means the energy density. So, we'll move into the different categories now. Lasers are categorized into 5 main groups. That categorization based on the lasing or gain medium used in the machine. So there are either gas discharge laser, solid state laser, semiconductor diode laser, liquid laser, and fiber laser. Fiber laser is also kind of a solid state type. If I go bit details into each of them, gas discharge laser, one of the very old laser. First one was helium neon, invented in 1960s, and there are a lot of gas discharge laser, helium, cadmium, argon, krypton, and carbon dioxide. Much of the very important laser in medical practice, and excimer laser. So, we'll go into details of little bit of carbon dioxide laser, which is in practice in most of the places, and we use it yesterday also. One of the earliest gas laser to be developed, and it was in 1964 by Kumar Patel. And it's still the most useful type of laser. Carbon dioxide laser are the highest power continuous wave laser that are currently available. As somebody said yesterday, CO2 laser beam is of infrared light with principal wavelength band centering 9.6 and 10.6 micrometer. Micrometer means it has a fairly big wavelength. So the wavelength decides a lot of things. It's extremely useful in surgical practice because it has a very good affinity to water, and water absorbs it very well. If you see the chart, this is the wavelength of the CO2 laser. So the absorption amount, there is absorption in millimeter, of CO2 laser is very effective in precise cutting and ablation of the soft tissue. If the absorption length is very short, if you look at this one, you can cut, but is it insufficient for hemostasis? But CO2 laser has the ideal wavelength and the ideal absorption depth for cutting and hemostasis purposes. So the 10.6 micrometer CO2 laser remains the best surgical laser for soft tissues where both cutting and hemostasis are achieved, as I showed earlier. It can replace the scalpel for most of the procedures and are even used in places a scalpel would not be used. The advantages include less bleeding, shorter surgical time, less risk of infection, and less post-op swelling. And it is used in various fields in medicine. The CO2 laser at 9.25 and 9.6 micrometer wavelength sometimes used in dentistry for hard tissue ablation because you can achieve very high temperature at the target point with that. So we'll move on to solid-state laser. In the solid-state laser, as a medium, they use crystal whose atoms are rigidly bonded, unlike in gas. The crystal produces laser light after the light is pumped into it either by a lamp or another laser. So it modifies the light or the laser which is given into the pump. Since the laser light travels in the same direction as an intense beam, the laser produces a very bright light here. And generally, the active medium in solid-state laser consists of glass and crystalline host material into which added what's called dopant. Dopant is very rare earth minerals like neodymium, chromium, erbium, like things, so on. So that modify the effect of the light rays within the medium. So KTP is one of the well-known solid-state laser. KTP is really Nd:YAG laser whose beam is directed through a non-linear KTP crystal to produce a beam in a green visible spectrum, not like CO2 laser. It is in visible spectrum, it is green, so it's sometimes called green laser. Potassium titanyl phosphate, KTP, is an inorganic compound. The KTP laser works on principle of selective photothermolysis, not like CO2. It has a very poor affinity to water, but it has an excellent affinity to hemoglobin and colored stuff like melanin. KTP crystals double the frequency of pulsed Nd:YAG laser energy to 532 nanometer wavelength, which is in the green electromagnetic spectrum and is selectively absorbed by hemoglobin and not at all by water. So that is the principle we use when using KTP laser. Because of that, it's extremely suitable for any lesion in the vocal cord, including dysplasia, papilloma, and carcinoma in situ, because the vocal ligament does not have blood in it. So you can carefully remove things on the vocal cord without damaging the underlying vocal ligament. The energy from the laser is absorbed more easily by blood vessels than the other tissue. Therefore, targeting the blood supply of the lesion causes the lesion to slough off, leaving the surrounding tissues undamaged. So, another fairly common type of laser is a diode laser or laser diode. It is actually a semiconductor device similar to a light-emitting diode, in which a diode pumped directly with the electrical current can create lasing condition at the diode's junction. If I define semiconductor, semiconductor is a substance that has a conductivity between that of an insulator and that of most metals, either due to addition of an impurity or because of the temperature effect. Diode is an electrical component that allows flow of current only in one direction. Right. So the choice of semiconductor material in diode laser determines the wavelength of the emitted beam. Today, the laser diode range from infrared to the UV spectrum, so a fairly large range. The laser diodes are most common type of laser produced with a wide range of users that include fiber optic communication, barcode reading, and blah blah, lot of users, because it's fairly small in size and the cost is minimal, and the user friendliness. It makes them very attractive to most of the clinicians for most of the minor soft tissue procedures. There are some disadvantages also. The diode wavelength range from 810 to 1100 nanometer, not micrometer like carbon dioxide, this nanometer. So the water does not absorb this frequency very well. And so they don't have a good cutting ability like CO2 laser. But still you can use it to cut soft tissue. The soft tissue is not cut by laser beam here, but is instead cut by the contact with the hot charred tip. So it's different from CO2 laser. Because the tip is so hot, it can be used to cut soft tissue and can cause hemostasis through cauterization and carbonization. Diode laser, when they use for soft tissue, can cause extensive collateral thermal damage to the surrounding tissue. So that is some disadvantage, not like CO2 laser. So a bit about dye laser. We don't use much in our practice. It is an organic dye as a lasing medium, usually in a liquid solution. The compared to gas and most of solid-state laser, lasing media, a dye can usually be used for much wider range of wavelength, often spanning from 50 to 100 nanometers or more. It's a bigger range. The wider bandwidth make them particularly suitable for tunable lasers and pulse lasers. So a bit for users, it's used for various purposes here. And in medicine, sometimes it's used in dermatology for cosmetic things, cardiology, for vascular lesion, angioplasty, lithotripsy, and some cancer treatment as well. So the quality and the effect of laser is basically depend on the wavelength. So if you look at this carefully, what we commonly use is KTP laser. It's a fairly low wavelength. And CO2 laser, it's at the other end. So if you see the affinity and the absorption here, wavelength, so this is hemoglobin. If you see the hemoglobin, KTP laser has a very big affinity to hemoglobin. If you see CO2 laser, it is minimal. And melanin, again, KTP laser has a higher affinity. It's none with CO2 laser. If you see water, CO2 has a very good affinity, but nothing in the KTP range. That's the same slide I put earlier. So, ladies and gentlemen, we'll move on to the next one, the coblation. Coblation is kind of short form, control ablation. Like in laser, coblation, though it's a new one, is something to do with radio frequency. Radio frequency have been in practice over a long period of time. We still use that in the form of diathermy machines and various things. The radio frequency generators are also widely used to ablate tissues in minimally invasive mode in cardiology, oncology, neurosurgery, and various other surgical practices. When you come to coblation, it's the use of radio frequency energy in a novel manner by volumetrically removing tissues with non-heat driven process. Most of the other radio frequency act by heat, but this is not by heat-driven process. So you have to know what is plasma before understand coagulation. Plasma we talk here is not plasma in medicine, it is plasma in physics. Plasma in physics is an electrically conducting medium in which there are roughly equal number of positive and negatively charged particles produced when the atom in a gas become ionized. It's sometimes called fourth state of matter. Matter, you know, is either gas, liquid or solid. So plasma, now some says, is the fourth state. So it can be generated by a continuous supply of energy to the atom molecule of a natural gas until an excited status is achieved. The energy required may be provided separately by different ways: thermal, chemical, electrical, and radioactive, or combination of all together. So plasma has several biological effects. We use some in coagulation technique. Other than that, it can effectively inactivate broad spectrum of microorganisms, including multi-drug resistant pathogens. It can stimulate of cell proliferation and angiogenesis with a lower treatment intensity and time. And it can initialize cell death when we use in higher intensity and for a long period of time. So it has many effects. And the generation of plasma, these are the ones you use in coagulation. The tip has the gadget to produce plasma. Plasma are generated by electrical discharge in direct contact with the liquid. Electric underwater discharge, when you put the wand in the tissue with saline, it creates following phenomena: strong electrical field, shock mechanical wave, free radical production, strong UV radiation, production of ozone if oxygen is present in the system. Those things happen with the wand. And the effect on tissues, the plasma effect. So it's purely chemical and not thermal. Plasma generates H and hydroxyl ion. In these ions, it's these ions that make plasma destructive. OH radical causes protein degradation. When coagulation is being used to perform surgery, when the interface between plasma and the dissected tissue acts as a gate for particles. So it dissects and the plasma goes in and it further dissects the tissues. So in coagulation, technology is based on non-heat driven process, as I said earlier, of soft tissue dissolution, which make use of bipolar radio frequency energy. This energy is made to flow through a conductive medium like normal saline. When the current from the radio frequency probe passes through the saline medium, it breaks saline into sodium and chloride ion. This highly energized ion from plasma fields strong enough to break organic molecular bonds within soft tissue, causing dissolution of the tissue. So that is how the coagulator works. So in summary about coagulation causes low temperature molecular disintegration, and it causes volumetric removal of tissue with minimal damage to adjacent tissues. Collateral damage is low. The coagulation during coagulation is by bipolar cautery, because all coagulation man has been designed to operate in coagulation mode for hemostasis during surgery. It has inbuilt bipolar probe. So ladies and gentlemen, I'm coming to the end of my presentation, and I want to remind you one thing: light rays not only used in medicine, and it can be used for various other purposes as well. Thank you very much.
Thank you, Dr. Narampana. Yes, any questions?
Yes.
Property of killing organisms, like even
Not coagulation, it's plasma actually.
Yeah, plasma. So it's used, no. So what I'm thinking is actually in chronic rhinosinusitis, mainly the biofilms. So organisms are the main problem for us. So we are using microdebrider most of the time. So what do you think about usage of coagulation? Any your experience?
No, I don't have much experience in using coagulation because I don't have a coagulator there. So I think our next lecturer may be able to answer that question. I don't have much experience in using.
Okay,
I have used the coagulator for various things, but for these purposes, really I don't know. I have to check it.
Okay, so thank you.
Just give my thoughts. I think we haven't used coagulators in sinus surgeries that much. Now, when it comes to biofilms, yes, we are talking about sort of pansinusitis. Basically, you have all the sinuses affected by, they are real difficult cases. So now, I think it's going to be a bit conflicting when you use a coagulator and when you manage sinusitis, because in the sinusitis we try to preserve mucosa as much as possible, and that's the basis of our functional endoscopic sinus surgery. We try to preserve mucosa and then we try to somehow get it remodeled. So if you use coagulator, it's going to be, I think we'll have to remove all the mucosa. We'll have to remove, we'll have to ablate the mucosa basically to get rid of whatever the biofilms or this thing. And we'll need to let it re-epithelialize, which is going to be a difficult task, I guess. That's what I feel. I don't know.
I also think the same.
Yeah, it's going to be a difficult task to use coagulator to, ablate all the mucosa or most of the mucosa and get rid of these biofilms.
Yeah, what's now KTP and CO2 is, I think we have in our setup. What's the difference between when you use?
Yeah.
The advantages and disadvantages?
So KTP, as I said earlier, it mainly worked because its affinity to hemoglobin and blood vessels. That's the way it works. So it doesn't, the beam will not really cut through tissue, not like carbon dioxide. So if you want to cut, you have to touch the tip onto the tissue. Then the carbon dioxide is not like that. You can focus the laser beam, and that laser beam itself cut and coagulate. So it is good, very good in cutting, giving a very sharp cut of the soft tissue, and at the same time it does the hemostasis. KTP, yes, you can cut, but you have to touch the tissue with the tip of the fiber.
Thank you. Thank you, Dr. Narampana. It was a good, excellent presentation, although the physics part was very difficult to grab. Yeah, I think. Thank you.
Next, I would like to invite Dr. Chansiri Narampana to come on the stage to receive the certificate of appreciation from our chairpersons. So, dear ladies and gentlemen, we had a wonderful morning session in today's annual academic session 2022. So, I would like to thank Dr. Yasat Veerakkodi as well as Dr. Yasavardhana for chairing this wonderful session. So, that concludes the session number 1 for today. So, we shall now have a short break for tea of 15 minutes and with a short message from our sponsors, and you can also pay a visit to outside stalls at the Orchid Extension. Thank you.
Of Mohammed. Please come and take your seats in the front table.
Good morning, everybody, and welcome you all for the second session for the day. The first speaker for the second session is Professor Prathamesh Pai. He is connecting us from Bombay today via Zoom, and actually he's already familiar with this audience because he has conducted the pre-Congress session yesterday. And today also he is going to talk about laser on ENT. Professor Prathamesh Pai is a consultant surgeon, chief of the unit Department of Head and Neck Oncology, Tata Memorial Hospital. He was a UICC fellow in 2002, Klinikum Fulda, Germany, and he has got Haagbein Fellowship in University of Petersburg, United States of America. He is a former convener, Head and Neck Disease Management Group, Tata Memorial Hospital. Currently, he is president. He was a founded president for Head and Neck Oncology Society in India, founding secretary in Indian Society of Thyroid Surgeon. His special interests are endoscopic and open skull-based surgery, conservative laryngeal surgery, and transoral surgery. So he will be joining us from Mumbai today via Zoom technology. Professor Pai, over to you.
Thank you very much, Dr. Ranjit, for the kind introduction. I shall share my screen. I would like to thank the College of Otolaryngology and for the annual academic sessions. Today I'll be speaking to you on the minimal access surgery in head and neck surgery. This is in keeping with the theme of precision tools in ENT, the way forward. Why minimal access? In head and neck cancer surgery, survival has reached a plateau. We have a better understanding of the biology, and our focus now is shifting towards improving the quality of life. We were very much happy with chemoradiation protocols, but we have realized that they have immense acute and late toxicities. And over the past 3 decades, technological advances and instrumentation have allowed for refinements in surgery which will preserve form and function. Oropharyngeal cancers, laryngopharyngeal cancers, paranasal sinuses, thyroid tumors, and neck nodes are now all amenable to minimal access surgery. And I shall be focusing today on the oropharynx, laryngopharynx, and the paranasal sinus tumor. In oropharyngeal cancers, these tumors are in vicinity of dysphagia-related structures. And today we are aware of HPV-positive tumors, which are rampant amongst the Western countries. They also have very good long-term survivorship, and they have, however, with chemoradiation, significant long-term morbidity. Way back in the early 1900s and 2000s, people realized that oropharyngeal cancers, when treated with surgery, have severe complications. They have got morbid surgery as well as they need radiation therapy. Along the way, there has been a paradigm shift in the management, and our first-line treatment is now concurrent chemoradiation or radiation. The toxicities are a big concern with these treatments, and late radiation-associated dysphagia is seen 5 to 10 years later. It is devastating and is refractory to all current therapies. We need to understand that these are early cancers and they'll be survivors, and 35% of these patients will have grade 3 or 4 pharyngeal toxicity and even treatment-related deaths within first 3 years. Almost 60% of these patients have late onset dysphagia. We need to reduce toxicity whilst maintaining the outcomes and functional and oncologic safety that we have achieved with concurrent chemoradiation. Towards this, we can do a transoral laser microsurgery, the transoral robotic surgery, and a transoral endoscopic surgery. These all utilize the natural orifice of the oral cavity for accessing these lesions. We are aware of transoral microsurgery. We had a whole workshop yesterday. We know that we can use this to have very precise dissection of these tumors. The experience from Liverpool amongst 153 oropharyngeal cancers suggests that you can avoid radiation in 15% of patients.
Recording in progress.
Avoid chemoradiation. You can avoid chemoradiation in most patients, and the 1-year gastrostomy dependence is about 1.2%. The German experience suggests that the early tumors, the locoregional control is upwards of 75%, and even in the stages 3 and 4, the locoregional control is upwards of 78%. In tongue-based cancers, they have more than 80% survival in all comers, and the gastrostomy dependence rate is extremely low. The American trial that patients had overall survival of 86%, and worst score was the ones which required adjuvant radiation. Their gastrostomy dependence was about 3.4%. So we will hear about the robotic surgery from Professor Suren. Of course, it has extensive advantages, and the results also justify their use, wherein we can avoid radiation in many patients and reduce the radiation and chemoradiation adjuvant treatment. Radiation therapy versus TORS, when compared, give certainly better outcomes when we use with radiation. And the costs of surgery, the tracheostomies and the dependence on gastrostomy are much lesser with the TORS. We need to, however, understand that we cannot do away with adjuvant radiation. Certainly, when you use surgery, you can see that the outcomes are better and the amount of radiation dosage delivered is much lesser. So we are dealing with a cancer that has occult metastasis where the margins are very few. We get around 3 to 4 millimeters margin, and adjuvant therapy is necessary in almost 50%. We need to avoid this cost escalation. And towards that, we have used the transoral video endoscopic surgery for accessing these lesions with the same versatility as a robot. So from Professor Shirtani, we learned the methods of the transoral video endoscopic surgery, wherein you can use laparoscopic instrumentation, which are long and fine to achieve the similar kind of resection that you would do with a robot. So with the video endoscope, which has a flexibility at the tip, it is semi-rigid, you can have a good visualization of the oropharynx, of the base tongue, of the supraglottis, and even of the hypopharynx. So we shall see how we can apply the robot or the transoral video endoscopic surgery to the resection of this tonsillar lesion. We use laparoscopic treatments and devices which will achieve a clear and similar vision is with the flexible endoscope, which will allow us a complete endoscopic exposure. So the surgeon is at the bedside. The advantages are that you get a tactile feedback, and you can use conventional electrocautery surgical instrumentation. So the field of the resection is magnified. It is done operating off the monitor so that you have a complete magnified view of the tumor. You can see within, like an endoscopic surgery, you can get angle vision. You can use your, you are at the patient bedside, so you will be able to manipulate the tumor without having to depend on an assistant surgeon. You get a complete clearance using electrocautery, which is similar to your routine surgery. We saw how BISAC was used yesterday, and that seems to be even more suitable for this kind of a procedure, wherein we can get a complete access with a bipolar device, which will be even better than a unipolar device with lesser thermal damage. So that's how you can actually resect this with impunity. You can do a closed resection to the internal carotid artery. You can see the pulsations in the background. You can preserve nerves. You can preserve structures which you don't with visualization. And this is how you will see at the end of the surgery. That is the parapharyngeal carotid with the fat pad on over it. So this is the patient day 5. Like in a routine tonsillectomy, we will start oral feeds day 2 or day 3, and the patient goes on to have a normal swallow. Now coming to voice preservation. Now in endolaryngeal surgery, our focus is to have a good voice preservation alongside oncologic safety. It all depends on our ability to access the laryngopharynx. The patient should have no trismus, should have normal dentition and no cervical problems. We use a laryngoscope to actually determine whether we can actually go ahead and complete your procedure. There are a lot of instruments which will give us very good access, and we know whether we will be able to complete our surgical resection with these. Again, we can use either the laser or the transoral video endoscopic surgery to achieve our means. We have seen yesterday the use of ultrapulse and superpulse and the scanner technology, which will allow us precise excision of these early glottic cancers with normal cord mobility. Even early supraglottic and hypopharyngeal cancers are amenable to these kind of dissections. So the European Laryngology Society, as we saw yesterday, have divided these into 6 types of resections depending on the mucosa right up to the cartilage. This is an example of a surgery which is extended in its resection across the vocal cord but limited in its depth. So to gain complete access, we do a minimum false cord resection. Once the false cord is dissected, we get a better visualization of the anterior commissure. So we know that this lesion is superficial because once we do the submucosal infiltration test, it is riding above the mucosa. So we go down into the depth, just remaining below the mucosa. So as we proceed in this surgery, we will get to see the ligaments on both the sides and get into the plane between the ligament as well as the mucosa. So you can see now we are coming onto the anterior commissure, and you can see the white ligament and the mucosa being stripped off the ligament. So this is an extended cordectomy. We are resecting a lesion which is like a horseshoe across both the vocal cords, but you can see that the depth is preserved. We are preserving the entire vocal cord as well as the ligament on top. So this is the ligament on the contralateral side, and you can see how with laser you can precisely dissect between the mucosa and the ligament. And at the end of the procedure, you would have preservation of both the vocal cords with only the mucosa stripped off. Of course, we will use mitomycin C, and this patient is called back for repeat scopy at the end of the week to clear the carbonization. The results with TLN are incredible. The larynx preservation for T1 bladder cancer is almost 98%. For T2 cancers, it is upwards of 80%. For T3 cancers, we have a 5-year survival rate, which is around 64%. And the gastrostomy and tracheostomy rates are extremely low. In T4 cancers, you have got the possibility of a 5-year survival rate of 55.8%. And all this, bear in mind, is similar to the ones we achieve with concurrent chemoradiation. The aspiration is minimum, and the permanent gastrostomy rates are extremely low. So this is a case in point for supraglottic resection using the transoral laser surgery. You define the extent of lesion with an endoscopic examination. And then as you proceed with the microscopic transoral laser resection, you first define the lateral borders coming from the pharyngoepiglottic fold, taking control of the bleeders, the superior laryngeal artery using your insulated suction probes, and then using the precise laser beam, you can actually resect this lesion. So this is on the contralateral side, and as we resect the cartilage, you'll come across some bleeders which can be controlled using the suction carotid devices. And at the end of the procedure, you would have both the vocal cords and part of the false cords preserved, and with assuring good voice quality. The TLN in supraglottic cancer, the 5-year overall survival is 76%, and the disease-free survival is 86%. Even in pyriform sinus cancers, the world leaders, Steiner's articles from Göttingen suggest that they have a 5-year overall survival of 71% in stage 1 and 2, and almost 47% in stages 3 and 4. Now, with the video endoscopic surgery, we can achieve similar results and with much faster resection as compared to the laser. You can see how this postcricoid cancer, which is very superficial, can be amenable to a laser resection or a video endoscopic resection. This would have been traditionally dealt with radiation or concurrent chemoradiation. So see the access that you get with the video endoscope. The entire larynx is retracted anteriorly with the help of the FK retractor and a laparoscopic resection. You can actually go wide, keep wide margins. So you achieve 5 to 10 millimeter margins as we would normally do in all hyperphalangeal. Again, bear in mind that this is a superficial disease, so you can actually go between the mucosa and the muscle and achieve a good clearance. Following resection, they use the tissue glue to achieve hemostasis. And at the end of the procedure, they have normal vocal cord mobility and good function. This is what we expect to remain because this patient would not require to go on to have any radiation. Supraglottic, this is our own setup at the Tata Hospital, and we can resect supraglottic diseases such as this using the video endoscope. So you can delineate all around. You can get an angled vision, which is not feasible with a microscope. And the electrocautery allows us to cauterize vessels more than 0.5 millimeters, which is the limitation with laser. So as we resect these, we will be able to, with wide margins coming on to the hyoid. You can see now as we delineate, we'll be able to see the hyoid. The surgery proceeds much quicker because there is controlled resection. You can see the hyoid now. You can use conventional instrumentation for achieving bipolar cautery, and you will be able to resect these much quicker and with an arm block fashion. So these are the advantages that we have like in robotic surgery. You can get a good visualization because of the angled vision with the scope. You can fall around and you can make this in order to complete your surgery in a short duration. So you have a fair bit of ability to resect with the help of the video endoscope. And this is the wide margins that you can achieve. Now, the results of transoral video laryngoscopic surgery are also very encouraging. Shiotani's group has reported from hypopharyngeal and supraglottic cancers, and you can see the astounding results. In hypopharyngeal cancers, the stages 3 and 4, 5-year overall survival 83.9%, and in supraglottic cancers, it's upwards of 77.8%. This is in contrast to the laryngeal and hypopharyngeal cancer data with concurrent chemoradiation. With the RTOG study, we know that around 75% of patients will have larynx preservation at the end of 5 years, and here it is almost 96%. So the transoral surgeries are cost-effective solutions with adequate elimination and magnification and good oncologic safety. Coming to sinonasal tumors, we know that these are rare tumors, but most of them are non-squamous. They are subcranial, free of dura, and node negative. So all in all, a very favorable set for doing an endoscopic resection. So we know that open surgery often entails extensive soft tissue and bone resection. It's blindside as we go down. There are facial deformities to deal with after our surgery. We possibly cannot get arm block resection because we know about the ethmoid SL system. And they are often very close because you cannot remove structures such as the optic nerve, the brain, and the carotid. So the issues are with access, the margins, and the outcomes. So when we look at the sinonasal endoscopic surgery, we realize that arm block resection is a myth, and a multi-block resection is very effective and gives a good complete clearance. So today, when you have a sinonasal or an anterior skull-base tumors, divide it as a subcranial or a transcranial tumor. The approaches are today all possible with endoscope, and the transcranial surgeries are such as the craniofacial and trabeas are also feasible with the endoscopic surgery. So if you have a subcranial disease, you do a complete endonasal endoscopic resection. So case in point is a recurrent SHO involving lateral nasal wall. So you tailor-make the resection to the tumor. So in this case, we go into the middle meatus, like in any endoscopic surgery, clear tissue of the uncinate as well as the anterior ethmoid SL system. As we peek into the maxillary sinus, we realize that the posterior part of the maxillary sinus, orbital floor, are all free of the disease. And when we decide to do a medial maxillectomy, you begin with the access to the frontonasal recess and then visualize the inferior turbinate region. When there is disease close to the piriform aperture, you will then take the anterior cut on piriform aperture. So then your flap is elevated, and then you divide the frontonasal process like you do in routine medial maxillectomy. You elevate now the facial structures, such as the skin and soft tissue from the bone. Then come on to the nasolacrimal duct, divide the nasolacrimal duct. This now frees the medial maxillary lateral wall from the structures of the orbit. So you can see the orbital contents coming onto the maxilla. As we come on to the intraorbital nerve, we can divide the intraorbital nerve. And once you divide the intraorbital nerve, that's the intraorbital nerve seen, you come on to the floor of the maxilla. And a complete resection. It's not necessary to have a complete resection or R block resection, as I said. If it was feasible in this patient, we could get a complete clearance of this tumor. Similar children with lesions on the lateral nasal wall can be cleared with endoscopic clearance. Large tumors such as this spindle cell tumor was cleared with minimal anatomical alteration. For a transcranial tumor, the ones that have minimal paramedian intracranial resection requirements will go ahead with the endonasal endoscopic resection with craniotomy. This is an SHO neuroblastoma with minimum intracranial extension. So we start on in the surgery with the central debulking, septal resection, bilateral ethmoidectomy, and a draft-free frontal exposure. So this is a standardization of this process. So we know we can do this in every case with a standard outcome. So once you have done this, you have the you will have full access right from the full sinus anteriorly, the sphenoid posteriorly, from orbit to orbit. So then you expose the dura laterally after dividing the anterior ethmoid artery and the posterior ethmoid artery. And then you go on to clear the crista from this tumor and by separating the dura. Anteriorly, you separate the fox, and you will now start to see the tumor. The tumor is carefully dissected like you would do in open surgery by going between the arachnoid tissue and the tumor. We use fine dissecting instruments like sickle to separate the tumor. And the tumor is separated, you will come on to the fox cerebri in the middle, which is then separated from the entire specimen by dividing widely. Once the fox is divided, the specimen is now held in place with the two fibers, olfactory fibers, which are then under vision, bipolarized, and then divided. So once you divide this, you have the posterior margin of the dura, which is then resected, and the specimen is free. This specimen now can be oriented like you do, because this is the complete base of the tumor. This is usually a 3 by 3 or a 3 by 4 centimeter defect in the skull base, and you use 2 layers of into the defect and achieve a good field. Like in any repair, your machinist with facial art. How the patient looks at 7 to 8 months, complete in a cranioendoscopic resection, you have which is much more, it's not paramedian, it's involving the brain architecture, and you would need to do it under open resection. So a transcranial frontal craniotomy is done, a transnasal tumor control is achieved, and after the transcranial tumor is removed, you would have this kind of a scenario. So the pericranial flap, the removal of the tumor from the cribriform and with a wide margin on the dura, exposing the cribriform from above. From below, bilateral ethmoidectomy and a septal resection, as we discussed previously, exposing the skull base from the frontal sinus anterior to the ethmoid, posterior ethmoid and sphenoid. Once this is done, the tumor is now free from below and from above, and then you start taking the osteotomy cuts, that's the planum. So lateral to the orbit on both the sides. I beg your pardon, medial to the orbit on both the sides, the frontal sinus anteriorly and the planum posterior. And then the specimen is delivered transcranially. The repair is very robust with the pericranial flap and facial lata repair of the dura. This is how it will be seen post-op with very good functional and cosmetic outcomes. So you do need to do a proper case selection. Anterior skull base should not be involved. It should not involve the palate. And it should not cross the mid-pupillary line in lateral to it. The outcomes are very good. We can see from world literature, this is from the MD Anderson group. They have a local control rate of 85%. Disease-specific survival of 80% at 10 years, and extremely low morbidity. The European data also suggests that they have a local control rate of around 85%. They have a 5-year disease-specific survival upwards of 90% in a subcranial disease, and extremely low morbidity. Our own data of 125 cases which we had analyzed, now we have close to 350 patients. Our local control rate is 81%. Our endoscopic, complete endoscopic resection survival, 5-year survival is 82%. And again, we have extremely low morbidity. This is in contrast to the international collaborative study of open surgery, where the local control rates, the 5-year survival, and the complications are quite severe. Now, what we realize is that the outcomes are determined with the histology. And we know that the adenocarcinomas, estatios, and neuroendocrine tumors will do far better than your squamous cancers, SNUCs, and the melanoma. So sinonasal tumors, when we look at our last 128 cases, those that were subcranial, 94% we could do completely endoscopy. And those that were transcranial, almost 40% we could do either completely endoscopic or endoscopic assisted. So there's a definite shift towards a minimally invasive procedure. So in summary, in head and neck, natural orifice surgery is here to stay with the advancing technology. Minimal access surgery minimizes morbidity and improves the functionality and quality of life. And it is incumbent on us to improvise and reduce costs with similar outcomes. I thank you once again for this invitation, and I'll be happy to answer any questions.
Thank you, Professor Pai, for your excellent presentation on minimal access head and neck surgery. We can allow some, 1 or 2 questions. If there are no questions, we can move to the next lecture.
Yeah, next lecture is Safety in Laser in Practical Setup and Sri Lankan Perspectives of Laser in ENT. Going to be delivered by Dr. Daminda Arachi, who is a consultant ENT head and neck surgeon, currently attached to Apex Hospital. And he was earlier in the Anuradhapura Hospital, who made that ENT department as a tertiary care center. He is one of the laser pioneers, and he is young and dynamic. And he is currently trying to set up a similar unit in Apexa Hospital. We wish him success in that effort. May I invite Dr. Daminda to deliver the lecture.
Thank you, sir, for the kind words. And I thank you very much, the Council, for inviting me for this occasion. I have done this lecture with a bit of modifications in 2013 when Dr. Chandra Yasuri, Madam, invited me to start lasers in National Hospital. That is in 2013 March, about 9 years back. When I went for my foreign training, I didn't have any idea about laser in ENT practice. In fact, this was the hospital I got my training, and then I was fortunate to have this course done. And in fact, they insisted me on doing this course before touching any of those laser patients. And now we see these lasers everywhere in day-to-day practice, in barcode sensors or Blu-ray players, pointers, sensors, and in light shows. However, when it comes to medical lasers, we fear and we are a bit worried about lasers, and we talk about safety. Now, why is this? Now, this is a sign it's posted in National Hospital. KTP laser, wavelength 532, and it says it's a visible laser, and so avoid eye or skin exposure to direct or scattered radiation, and it's a class 4 laser. So what are these things? We'll try to learn about these. Now, as Dr. Narampana said, the irradiance is one important factor when it comes to laser safety. Now, if you compare the 100-watt lamp with a frosted glass and 1 milliwatt point laser, 1 milliwatt point laser, the irradiance that's spotting or falling onto the retina is much higher in the 1 milliwatt laser. That's because the laser beams go parallelly, they are collimated. So that's the problem. So the very high radiation that will easily damage the retina. Now that's there with visible lasers, so not there with invisible lasers. Now, for us to understand this, the danger, we have a way of classification of lasers. Now, lasers are grouped into classes to give an potential, to show the potential of causing harm by the lasers. And the hazard is also related to wavelength, as we saw in the previous lecture. The carbon dioxide laser is less hazardous compared to visible lasers, and also obviously related to power and whether it's pulsed or continuous mode. And so this classification also determines the need to wear the safety or use the safety measures. Now, there are a few terms that we need to know. One is accessible emission limit. So AEL is the maximum level of radiation that can be emitted from the laser machine. So by the AEL, we have a classification system. This is an old classification system, but I just put it to show that class 1 to lasers are it produces less than 1 milliwatt. But when it comes to class 3, 1 to 5, and then class 4, these are milliwatts, right? And more than 500 milliwatts. So that is more than 0.5 watt. Now, the examples are given here, like for example, class 2 lasers, you have barcode sensors, bar readers, 2 here, pen-like pen pointers, but these shows in light shows 3B, and then class 4 is the surgical cutting lasers and also the welding lasers. So now we all know when we get exposed to light, we have a normal aversion response in our eye, which include the blink reflex and some other reflexes. So that will happen in about 0.25 seconds. Now in our newer classification, we have considered the normal aversion response also. This is the proper classification. So now again, when you look at this class 2 lasers, up to about class 2 lasers, the normal aversion response will protect our eye from the laser beam, so the light beam. So therefore, we don't have to really wear any protective glasses unless we use magnify instruments like microscopes or some other lenses. So now 3B, we don't have to know these things, but just to make you to understand. Now 3B, when it comes to 3B, you can view at the reflection. So there's no problem in looking at the reflection, or like you look at your light reflection. So you can look even diffuse or even diffuse reflection. But when it comes to class 4 lasers, like our visible KTP laser, you can't look at even diffuse reflection. So whatever the light wave which falls into one of those surfaces, or maybe the laryngoscope or whatever, that also cannot be viewed by our eye. So that's also hazardous, and it also poses skin hazard damage and the fire risk at the operating room or wherever we use it. Now biological effect, as Dr. Narampana said, depend on the wavelengths. Now when you come to the visible spectrum here, like our KTP laser, it can cause photochemical reaction damage to the retina and the thermal damage to retina. So photochemical and thermal damage to retina, and also of course to the skin, photosensitive reactions and the skin burns. However, when you are there in the non-visible range, that is the carbon dioxide 10,600 nanometer range, it will not penetrate the cornea. So it will be there only for the cornea. So it will can damage cornea. However, it won't damage your retina, and it can also obviously can damage skin because it's a class 4 laser. So the spectrum plays a big role there, or rather the wavelength. So this is the same thing. The visible lasers go all the way to the retina. However, non-visible ones like carbon dioxide doesn't cause retinal damage. However, it can still damage your cornea. This is a retinal burn with KTP like laser. Now we have another term called maximum permissible exposure. So this is the light level at which a person can be exposed without damaging adverse effects. Now there are MPE levels for eyes and skin. So for example, even the KTP laser, if you put it in a sort of a very low transmittance, it's very unlike to get your retina damaged. So now this is what we do by using IVR. So the IVR is used to reduce, once again, incidental laser exposure below MPE, low maximum permissible exposure. So once again, it's not intended to allow you to direct visualization of the laser beam. It's just to prevent you from accidental exposure. So it's designed to provide protection from accidental exposure. Now these laser IVR, now they have standards. Now you need to make sure that they are on standards when you have, now they are written there in a side. So it comes under British standards or European standard or American National ANSI standards. And if you just Google it, you will see these standards and how to calculate these parameters. It's all there. So you need to make sure that your IVR is compatible with your spectrum and the standards. So IVR has to cover wavelength, and it should have the adequate optical density. Now, optical density is the level which by which it reduces the transmittance, and that's called L scale. It's also written there. And exposure conditions, like whether it's okay with the continuous wave and pulse wave or both, and this CE mark and all. And you also need to have side covers, because sometimes this laser exposure can be can happen from the side way. Now, for the eye protection, you have microscope eye filters also. Now, this is again important when it comes to KTP lasers. So there is an automatic eye filter in the microscope, which will be connected between the laser and the microscope. It has to be done when we are using KTP lasers. And for those who use your endoscope with your eye, also should have endoscopic eye filter. Now, there are video camera inserts also to protect the video cameras by continuous laser beams. So in the laser theater, we all know, we don't use reflective instruments, and you cover all the unnecessary metal instruments, cover these glasses and with blinds and all, and then we keep those warning signs and keep the doors locked while the lasers are being operated. Now, this is a skin damage. Now, to prevent that, especially patients or the staff for that matter, we cover all exposed patient skin with double layer of wet gauze, and we wet those gauze pieces intermittently, and we ask not to stand anyone at the foot of the patient, because we might misfire our laser beam in a rush. Now, there are some concerns about laser plumes. Now, this laser, the radiation can, the energy can vaporize tissue and create tiny particles. So they can get deposited in alveoli, causing pneumonia, pneumonitis, or bronchiolitis. And it has a potential chance of being mutagenic, and it has a theoretical chance of spreading viral particles like recurrent respiratory viruses, not like the COVID or airborne viruses. Now, to prevent that, we have a scavenging system. Now, we are supposed to scavenge those plumes with a sucker which is kept close to the laser working place, and at a 1 to 2 centimeter level from the operating field. And we need to have a good operating room ventilation to try and dilute all the plume. And laser masks are also supposed to be worn, and there are proper PFL, that is PFL is a brand laser mask with a tight fit with a 99% filtration for 0.1 micrometer particles. However, when we checked during the COVID pandemic, and we got to know that now even our standard N95 masks are adequate, and it's given in the CDC guidelines for laser protection also. And risk assessment also has to be done for RRP and HPV viruses, because they can be theoretically transmitted, so you need to make precautions when you're operating these patients. Now, you would have seen these laryngoscopes. They have a light source on one side, and there's a laser suction port on another side. So you can use a light source as well as a suction port, so that it will scavenge those plumes from the operative field. You need to have a dedicated suction machine for that with a filter. So nowadays our laser machines come with a dedicated suction machine, so you need to make sure that its filters are working properly, and it's being used other than the normal sucker that we use for suction of secretions of blood. So we used 2 suckers, and as I discussed, we need to have adequate ventilation, and we need to keep less traffic in the operating room. Now, there's a chance of organs or vessels being perforated when you are using lasers. It is because sometimes some lasers go deeper than that we expect. Now, we have sometimes problem when we do laryngeal stenosis. We just don't know the proper direction. So sometimes we might go and hit the esophagus, thinking that we are still recanalizing the trachea. So now this is more with KTP laser, obviously for this reason. The KTP laser has a higher depth of penetrance compared to carbon dioxide laser. So therefore, we tend to use carbon dioxide laser when it comes to larynx and for some other reasons also. Now, heat transfer also can happen. So laser energy can strike anything, causing fire. It can cause airway fires, skin burns or eye burns. Or there are a lot of equipment inside the operating room, so you need to make sure that your heat transfer doesn't cause any operating room fire. Now this is an airway fire. This is how it happens. Basically, if the gas carrying tubes, ET tubes in the patient's throat. Now if you use a lot of oxygen and if you use a lot of nitrous oxide, and if you damage the tube by any chance, it might cause a fire into the lungs, causing disastrous complication, a blowout fire. Now, therefore, we have these laser-safe tubes, which have a metal sort of a wrapper which will reflect laser beams. So it will basically don't transmit laser energy into the tube. However, the reflecting surfaces is also made it sort of a matte, so that the reflection won't come to your eyes again. And then you have two cuffs there, so proximal and distal cuff. Now, normally the proximal cuff will be inflated with methylene blue. So now there are two cuffs, obviously, because if one gets burst, the other one is there, and methylene blue is just to identify the cuff rupture. So we don't use paper drapes to cover the patients, obviously because of this fire risk, and we wet, as we said, gauze. We use wet gauze and we wet them intermittently, and we don't use alcohol drape preparations, and then even iodine we dry it. We test the beam with a wet spatula, not a dry spatula, and then and we make sure that we don't direct beams for the gas with the gas carrying tube. So we need to make sure that your anesthetic machines and things are on a side rather than on the foot end. And we use a wet cotton over the cuff of the tube to make sure, again, the cuff is also not getting damaged. And we don't use nitrous oxide and oxygen concentration. Yesterday we used about 25%, just usually less than 30%, 20%, or sometimes we use air for nitrous oxide. So tubes, as I said, they are non-flammable tubes. Now, there are some concerns about theoretical generating X-ray beams from laser systems. So it's a good practice to check our laser machines with X-ray, these radiation monitors in time to time, to make sure that it doesn't have anything. Now, we rely on these companies, the manufacturers, that they don't produce any radiation, but I think it's a good practice to check once in a while to make sure that it doesn't produce any radiation. Now, there are chances of electrocutions because it uses high powers, and obviously we talked about fire risk. Now, to have a sort of safe laser management system, there are guidance available in the literature here and there. So this is one document that it's been practiced in the UK. So this is from the Medical and Healthcare Regulatory Authority in the UK. That's like an MRA in our country. So this has been updated. When I was having that course, it was 2008. Now it's been updated in 2015. So basically, it covers this area. So you have a laser protection advisor to advise on laser purchasing and things, and then you need to have a supervisor in the local operating theatre. There has to be a set of local rules and laser control area, that is the theatre has to be controlled, and then we need to have authorized users and incident reporting. So the laser advisor or protection advisor is someone who is advising to the organization. So we don't have those practitioners in Sri Lanka, unfortunately. And I just spoke to one of the laser reps from India sometime a few days back, and apparently it's not there in India as well. But this is happening in the UK and probably the US also. Now, they do hazard analysis and these risk assessments. They design facilities. They they are involved in purchasing lasers, and they arrange support training for technical and sometimes even clinical, and they set up local rules. They do audits, safety audits, and they do the testing also. Now, the LPS, or the laser protection supervisor, is a local person who is usually the theatre manager or theatre assister, who is the local support for the laser arrangements. So he or she keeps the laser of the users, clinical users, register, and then they make sure that they adhere to the local rules and keep the records, training and maintenance, and make sure that the equipment, safety equipment are available, and this make sure that the laser environment is maintained and the local point of contact. The clinical users also need to be authorized. Now, basically, as I said, we had to do that course for touching before the patients. So you need to have an authorized set of way of handling users to make sure that the safety is maintained. So and they need to have good knowledge about the lasers, equipment, and the rules. Now, there are a lot of records that has to be done. I just put this laser log that we have been using at NHSL and then in our hospital, and it gives a record of what we have done for each and every patient. So what sort of laser that we have used, whether what's the amount of energy that we have used, what's the power, and what the setting, and everything is there. So it's very easy whether we have used goggles and then what sort of mask that we have used. So when you have a problem, when you have an incident, it's easy to trace back and see. At the same time, it's easy for someone to, if you want to do audit or something, to, get data. So all the incidents has to be reported or investigated, and I don't think we have any incidents in Sri Lanka so far as I know. Now, the most common causes for this medical accidents are like poor control of laser beam by the operator. So the delivery wound has not been managed properly due to fatigue or rushing through the procedure, maybe. So the other reasons are like they are not trained sufficiently, so eye protection sometimes not worn, or the laser area is not properly isolated. So the manufacturer's instructions are not used, or they are bypassed, and sometimes the laser system is not maintained properly, electrical and fire hazard, because they have not been attended to these plugs and all. Those are the reasons for common reasons for accidents. So with that, I'll just finish this safety part. I'll just touch on the Sri Lankan experience, because I have been getting involved in a lot of laser things, and this is the very first day we did laser surgery by our team. You can identify Madam is there, and I'll be again really thankful to Madam to inviting me to start this thing in National Hospital, and she got to know that I had a little bit of training, and then she gave this opportunity, and that's why sort of we came all this way. It was a KTP laser, but later we realized that we need a carbon dioxide laser, so we did something with the ministry and get the combined lasers. So we are now here with I think more data and more experience. So you see the team there, Dr. Ranmali Madam, she had been really helping us, helping a lot and enthusiastically to get a sort of a safe team to operate on these patients. And unfortunately, we see our good friend Dr. Lal also here, and the whole team is there. So we did posterior cortomy to start with, and arytenoidectomies, and then a bit of tracheal work, hemangiomas, and later on hereditary telangiectasias, some tongue lesions, and later on in the other centers, stapedotomies, and even mastoid being done nowadays. Now, laryngotracheal surgeries. So this particular article, I think Dr. Bimantha was then a registrar who wrote this nice article to our journal. But before he presented this data in the 9th SARC Congress, and once again Dr. Jayavira invited me to speak on Sri Lankan experience on that point, and we discussed about using KTP lasers in the larynx, and Prof. Sandhu was there at the audience, he was also presenting on his experience, and then yes, we had a good success rate in decannulating tracheostomy patients with carbon KTP laser. However, his advice was not to touch the larynx, I mean not the vocal cord, the larynx inside with KTP laser, just because it causes more damage to the, causes a bit of collateral damage to the tissues. So then we slowly, I think we got down some combined lasers and carbon dioxide lasers, so we got combined lasers to Kandy, and then Ragama, and then to some other teaching hospital, Anuradhapura and Jaffna, I think. So now we have been doing some of these cases. This is a subtracheal sort of stenosis. So it's quite possible to canalize these lesions completely, even with coblator or maybe with laser. And likewise, you just put a radial incision, and then it takes time, it takes a lot of energy, and energy in the sense the laser energy, and then of course our energy also, and then put this T-tube. It's quite possible, and it's doable, and we do. However, the success rate is the problem. So I don't think all these patients get decannulated. So when it comes to these total grade 4 stenosis, most of those patients go back to tracheal reconstructions. That's what our limited experience says, and I think that Prof will talk about this. I think he will also agree that grade 1-2 stenosis we are okay, but when it comes to 3, 4, especially 4, I don't think we can do much with lasers. But there are certain patients who would respond. I think there are some patient factors also playing there. However, when it comes to these sort of additions, they do quite well. Now this is one addition we got from Kalubowila and operated at Ragama. This patient was, I think she told me that the patient had a keel inserted to prevent additions, and she did well, I think, ultimately. And in otology, so we have been using for stapes surgeries, especially I think this is quite useful when it comes to endoscopic stapes surgery. But I got to know that Indranath that Jaffna is also started using in microscopic surgeries. Now this fiber laser is quite useful when you do endoscopes, because endoscopically also we use angle endoscopes, so sometimes you don't have to drill all the way, so you can look at the angles and corners, and either the fiber can be bent and make the perforation. This is just a way of cutting the tendon. Normally we sometimes struggle to cut the tendon because we don't have proper scissors, so the scissors have gone blunt. So it's quite easy to cut with this non-touch fiber KTP lasers. A few shots it cuts, and then you go to the crura and you cut it nicely, and then still I struggle with the perforation, but I think there are good ways, and Prof will again show, I think, few slides on nice stapedotomies. So it's basically a non-touch technique, and now we have a very limited data. One of our registrars will present data. This is a bit of a comparison between the non-laser and laser, and we have done better with the laser in terms of hearing, as well as with keeping bone conductions, so having less sensible hearing loss. And this is what the data says internationally also. So overall KTP, or not KTP, the laser stapedotomy results are better in terms of hearing preservation and hearing airborne gap closure, as well as in terms of sensorineural hearing loss. I haven't personally used lasers in mastoid surgeries, but I spoke to a few consultants, and I know Dr. Jha at Lanka Hospital, he has been using in mastoid surgeries, and even Bimantha has used a few at Anuradhapura, and they all say that it's quite easy to elevate cholesteatoma or sometimes granulations from the ossicular chain area, especially this stapes area, safely. And the data also says that it's safer, but I think that it's also, I think it's a very good area to use KTP lasers. And we also know sometimes when you do a mastoidectomy, we have some pockets small here and there, small cells, which we can't drill out everything. So you can just, I think there are some surgeons who burns those areas with lasers and get a good outcome. Now, finally, I think this is the place where you need to explore the carbon dioxide laser in transoral laser microsurgery in laryngeal cancers, and it's been now well established in the world that the earliest tumors can be easily treated with laser surgeries. This is one of our case where we did at Ragama involving anti-recurrence. This is the second one is just after the cordectomy, and this is about 2 weeks after we biopsied this granulation tissue, which was which didn't have any recurrence, and this is the video clip after about 2 months. The patient has got anti-recurrence addition, so we had to go and divide that addition. So what I'm saying is sometimes we might have to assess, reassess, and sometimes redo, and sometimes, you know, treat these additions also. You need to have that, you need to be able to follow up those patients very well if you're contemplating of these surgeries. Now, as Professor Nishpai said, it's also well established in supraglottic cancers, early supraglottic cancers. This is a very nice case, a big one, but with a pedunculated one. We did about a month ago, 1.5 months ago, at Ragam again. Doctor, I think Indika has referred this patient to me. Yes. And we managed to remove it completely with negative margins. This is the ulcer after about 2 weeks, and this is I think 1 month after. The ulcer is healed nicely. It's nice vocal cords; they are moving very well. Voice is perfect. So I think it's very good to do these sort of surgeries with they get a very good outcome. So transoral laser surgeries in early laryngeal cancers is well established, and it's they are in multiple guidelines, and in UK guidelines, multidisciplinary guidelines also for glottic and early supraglottic cancers. This is a very small series that we have been doing over the last 6-7 months. So we managed to do well in some cases, but again, once again, as you can see, some we couldn't get out the tumor completely for different reasons, sometimes due to poor exposure, sometimes the tumors are too extensive, so we might have to offer them radiotherapy, or we have offered even laryngectomy in some of the patients. However, I think we are there. This is, I think, good area to explore by ENT surgeons in this country. Thank you very much. And there are big list of acknowledgements starting from my teachers at Portsmouth to our local trainers, and coming down to Prof. Prathamesh Pai, who have been helping me a lot with these cases, and he has been advising each and every case so far. Thank you very much.
I would now like to invite Dr. Ranjit Jayavira to hand over the certificate to Dr. Daminda.
Photo shoot. Any questions in the meantime? According to the Sri Lankan experience, he mentioned that up to now we have had no complications.
What we do is when you remove the tumor, we mark them with threads or sometimes with small pins and then send it to pathology, and we speak to pathologists about our margins, so basically anterior, posterior, superior, inferior and lateral margins. Unfortunately, I think I don't think when it comes to the laser surgeries, they do frozen sections regularly. I think what they do is I think this was discussed sometime back also somewhere. Our visual impression, they take as a very important impression because we do microscopically, so we can see the tumor and normal tissue very well. And then, of course, if you have a sort of a residual, if it becomes positive, we can always resecate it. But we don't normally do frozen section like in sinus tumors. So it's the tissue, the tumor that we send.
Yeah, the thing is now most of the time we use the tactile strength.
It's something like
also,
this, yes.
Yeah.
But,
But,
so what I understood, like it was like now, even the pathologists, they rely on the microscope to find the tumor and sort of no tumor. So in the same manner, we are also using microscope. So if you use high power microscope and if you can see the tumor and normal tissue, I think it's adequate, and we can reduce the margin. We don't have to have 1 centimeter margin. Even 1 millimeter margin of microscopic margin is going to be enough when it comes to those surgeries. Yeah, that's a very good question. Now, that's a very good experience that we got. I think when you put a T tube, if you can put a T tube, you need to keep it for a very long period. I think, I personally believe it's something like 1 year. Now, once you put a T tube, it remains very well. It's a biocompatible thing. It's a Montgomery, this silastic thing. Initially, there might be problems, and there are certain patients who doesn't do well with T tubes. They produce granulations and all. But if you manage to make sure the patient is okay with the tube, and they are very comfortable, they can close the tube, they can speak very well, and they don't have to have these suckers at home. They normally do very well. They just cough out everything. And you can keep the tubes for long periods without any problem. And we have decannulated several patients. This is after coblation, after keeping tubes for years. So probably like more than 1 year. I think it's better to keep it for a long period. You need to make the trachea to reepithelialize and then the fibrosis or whatever to take place, because usually after these surgeries you get a lot of thinning of the trachea or the tracheal walls. They become very flaccid and you get a bit of tracheomalacia, especially after our lasering and coblation.
So your advice would be to keep the T-tube as much as possible? As
much as possible, I would say, for about 1 year. I don't know the others' experience, but I think you need to keep it for a long period.
Thank you.
Don't remove it prematurely if they are okay.
Thank you, Daminda, for the nice presentation and the answers. I was thinking about these hazards of laser. I don't know whether we have been overemphasizing on these hazards. That may be the reasons why people don't want to practice
yeah,
laser.
I think yeah, because I got trained in the UK, so they are really, UK, they are very worried about everything, so they are very systematic in everything. So, but at the same time, I think we don't want to have any incidents. If we had anything, then that will go really bad on us. We are using lasers and it cause, some trouble. So I think we need to make sure that we have to be very particular about these things. And I think we have been successful in training our nurses and doctors and even minor staff. We have done a lot of workshop for them to do these things. Do you have anything, sir?
Yeah, so that has to be followed. Even minor step can cause damage once I had a problem. My trainee started this, and I asked him to put a wet pack into the trachea to cover up the trachea, the part above the cuff. And suddenly he said, "Sir, smoke is coming." When I see that he has inserted a dry pack into the trachea, so
and
that suddenly got burnt. So luckily I had some saline there, and I flushed that part with saline and got the fire off. So even a very minor step can be very dangerous if you don't follow it.
Yeah, I think that's, so your point is very important. I think you need to follow all the steps.
Yeah, all the steps. It's a very minor step. Just put a dry piece of gauze into the trachea. He didn't wet it, but it causes a big trouble. Luckily, we escaped without any problem. Nothing happened to the patient.
I think once you know this, I think it's very safe.
Yeah,
if you
when
know
you
everything,
follow the basic
you feel
precautions, and you take the basic precaution, that should be enough. When
we also had once Dr. Ranmali detected because the methylene blue came out.
Yes,
Yeah.
madam, yes.
You can remember. I
Yeah,
think,
it got burst. Yeah, so they are like near incidents. I think they should be reported really.
Yeah.
Yes.
Yeah, because as Panawa said, I think we have to follow all the guidelines because you know our social media, we have our people like the negative news, and then it will spread like wildfire. So I think we will follow all the instructions, although it's a bit cumbersome and people, as you said, people may not start things because, and I think we can't start this in every hospital, no, because it's not cost effective. As we can have it in major centers and all the, I think that we can invite those doctors also to come and do it.
Come and do it, yes.
Yeah.
Yes, that's, yeah, like
Yeah, I think if every ENT surgeon is trying to purchase a laser, it's not going to work. But people can come and do their cases as Dr. Veerakodi will welcome the other doctors.
Yeah, that's what I'm doing at the moment. Like I went to NHSL and then to Kandy and then now to Ragama. So I think young surgeons can, always take their patients. And I just saw Dr. Vakis was telling about a patient, your patient. So you can take the patient to Kandy and, operate. So I think all the consultants are very good. All the senior consultants are very good. They are all welcoming and they like to help us, and then they like to learn from us also. So it's a very good community that we have in our country.
I think that we can work with OMF surgeons also, because if we purchasing 2 laser machines to one hospital is also a waste. So oral cancers, they deal with a lot of oral cancers. So I think that way also.
Yes, this KTP one is quite useful for tongue, I think. When we remove the tongue once, it comes out very nicely because it's red in color.
Americans use it for office procedures. They pass it through the fiber optic laryngoscope. Now we are going to get a new fiber optic laryngoscope. I want to invite you to do some cases as office procedures.
Okay, thank you.
Thank you, Daminda, for excellent presentation, and we can move to our next presentation. The next presentation is use of coagulation in otolaryngology. Light is easy to love. Show me your darkness. The presentation is done by Professor Ramandeep Work. Professor Ramandeep Work is the professor of Department of ENT, Postgraduate Institute of Medical Education and Research, Chandigarh, India. He did his primary medical education and postgraduate medical education at BMC Medical School, Ludhiana, India, and he did his senior residency at Government Medical College, Chandigarh, India, after which he worked in London at Northwick Park and Central Middlesex Hospitals. Currently, he is working as a professor in the Department of ENT in Postgraduate Institute of Medical Education and Research, Chandigarh, which is a premier tertiary referral center of the country. He is actively involved in research, has numerous publications in national and international journals, has undertaken various research projects. He has been an invited faculty as a surgeon, speaker, and panelist to various conferences around the country and abroad. His areas of interest are mainly endoscopic skull-base surgery, endoscopic sinus surgery, staphytotomy with CO2 laser, and coblation in airway diseases. He has done extensive work in treatment of allergic fungal rhinosinusitis, fungal lesions of sinonasal region, and also use of coblation in the sinuses for juvenile nasal angiofibroma, pituitary surgeries, and CSF leaks. He has held several positions, including member of the skull-base committee of the American Academy of Otolaryngology, member of the otosclerosis study group, the honorary member of East Isle Rhinology Society, associated editor of JPMER Journal of Postgraduate Medicine, Medical Education and Research. He is currently working as editorial board member of Archives of Clinical Otolaryngology and Rhinology. He was founding member of the editorial board of Clinical Rhinology, the official journal of All India Rhinology Society. He is a reviewer of various national and international journals, including the Laryngoscope. He has about 100 publications in national and international journals on his name. I invite Dr. Amandeep Work to come over to the stage to give his presentation on use of coblation in otolaryngology.
Check. Is it okay? Great. Thank you, Dr. Ranjit, for the lovely introduction. I'll be presenting without a laptop. So my American laptop made in China, bought in India and got to Sri Lanka is not working somehow. So we are going to do it the old way, where I'll have to say next slide. So as we demonstrated coblation surgeries yesterday, tonsillectomy and adenoidectomy were just the start of the coblation surgeries. We have moved them on to sinonasal tumors, anterior skull base, and the airway. So I will be speaking on coblation-assisted CSF rhinorrhea repair. So I thank everyone once again, and of course, you know, not the least, Dr. Yasat for inviting me to this prestigious event. Dr. Ranjit for continuously following me up, because I was unable to give him certain papers which he required, but he didn't give up on me. And Dr. Daminda for the lovely operating room experience yesterday. And of course, Jaya Surya ma'am, you remind me of my anatomy teacher, very strict on the outside, but someone with a very soft heart on the inside. It was lovely meeting you. So let's start with the talks. So why do most CSF leaks occur in the anterior cranial fossa? This is just a very basic thing, because dura in this area is tightly adherent to the thin skull base and easily torn with injury. We also know that the thin and fragile cribriform plate is covered only by the arachnoid layer and missing a true dural investment. So this makes this area the weakest area. And delicate arachnoid layer is easily violated by even a small fracture. Next slide. So how do leaks get closed? We often wonder that many patients come to us with CSF leaks, but after some time they are okay without any intervention also. So they probably get covered by a layer of fibrous tissue or regenerated nasal mucosa, since dura mater does not regenerate. So it is probably nasal mucalization. And this is the knowledge which we have used to make our CSF repairs more successful. Next slide. So what are the radiological investigations which we do? Next slide. So the mainstay for us is the high resolution computed tomography, the 0.5 millimeter cuts. Whenever we take classes and we run modules for CSF repair for other surgeons in India, it's a common habit that a surgeon will see just the films. And we know that all the cuts that are taken by the scanner are not printed onto the films. So since these leaks are very small, they are like 1 millimeter or 2 millimeter, they might get missed. And when you order a CT scan or a radiology, make sure you ask for 0.5 millimeter cuts. Many machines are capable of that, but in other machines, even a 0.65 or a 0.75 millimeter will work. So this is our mainstay in the workup of CSF leaks. It helps us to diagnose the site of fracture, diagnose the size of the defect. It is non-invasive. Sensitivity is around 90%, which is pretty good. Accuracy is approximately 87%. And in the literature, it's always mentioned that the defect is not always correlated with presence of leaks, but the newer machines, the findings are consistent. It has changed with the 256 slice that has come. Next slide. So there is also a place of MRI cysternography in CSF leaks. It is again non-invasive. Accuracy is 100% in detecting the site of CSF leak. It helps us distinguish CSF because it shows hyperintense on T2 from perimucosal discharge or any collection of blood that might happen after a trauma. It is also very important to see herniation of brain parenchyma or meninges through the bony defect. Next slide. So we can say that MRI is an effective way in assessing the contents of meningoencephalocelik sacs and of course empty sella syndrome, which we see in all cases of idiopathic intracranial hypertension. We can also see abnormalities of the optic nerve, arachnoid pits, skull base flattening, specifically posterior globe flattening, dural ectasia, etc. are all well visualized. So this is one of the MR films from our institute. So you can see an empty sella on this is a T2. So what does empty sella mean? Empty sella doesn't mean that the pituitary disappears. It is just that because of the excess CSF that collects, the pituitary gets flattened and the place of pituitary is taken by this CSF. So this is a very typical finding on idiopathic intracranial hypertension. Also, look at how the optic nerve becomes. This is called a tortuous optic nerve and perineural enhancement. Do you see the CSF enhancing on the sides? So this happens also typically in IIH. And then, of course, we have flattening of the posterior globe. So these are all cases of CSF leaks in which we had findings of IIH. Next slide. Again, this is a CT scan and an MRI of a same patient. You can see the bony defect on a CT scan and you can see the CSF trickling on a T2 image of MRI. In neurosurgical books, you will read that CT cysternography is considered the gold standard. It was considered the gold standard, but due to its invasive nature, other imaging modalities should be considered first, like a simple HRCT 0.5 millimeter cuts will give us the defect in majority of the cases. In traumatic cases, what happens? The skull base completely fractures and the patient is complaining of CSF. So if you have fractures in 10 places, you would not really know where the actual leak is coming from because the patient is not going to be leaking from 10 places, maximum a single site or 2 sites. So to differentiate, if we just do a HRCT, paranasal sinuses, we will be able to see the defects, but we will not know where the leak is coming from. So in those cases, a CT cysternography is helpful for us. Next slide. Okay. Biochemical tests, quickly, beta-2 transferrin is considered the gold standard, but it is expensive, takes a long time to do. Next slide. So a cheaper test is a beta trace protein. It takes about 15 minutes to do. It's 1/3 the cost of a beta, 2 transferrin. Sensitivity and specificity are similar to beta-2 transferrin. And it's contraindicated diseases like meningitis and renal failure. So if our patient has had meningitis in the past, this might not be the best test. A beta-2 transferrin needs to be done. Next. So now we come to the most important part, surgical approaches. How are we going to approach the defect? Endoscopic repair is the treatment of choice nowadays. It has been proved adequately because there is accurate identification of the site needed for good results, better access to hidden areas, and of course there is no brain retraction. So the morbidity is much less than open surgeries. So this is also, like I said, adequately proved way back in 2000 that transnasal endoscopic repair of CSF fluid, a meta-analysis, and they concluded the endoscopic approach is highly effective and is associated with low morbidity, and the literature supports the endoscopic approach using a variety of techniques and materials for the repair of CSF leaks. So the literature also supports a endoscopic repair. So what are the corridors we will use? How will we approach the defect? Now the corridors for different defects are different. If we are doing a cribiform leak, we will go through a different corridor. If we are operating on a sphenoid defect, we are using a different corridor. If it's the lateral lamella or the fovea ethmoidalis, we are using a different corridor. So corridors are the passages we will go through when we operate endoscopically, and it will depend on the site of the leak. So if it is a purely sphenoid sinus leak, we can take the corridor which is indicated by the blue arrow. This corridor is between the septum and the middle and the superior turbinate. So we go head on, we widen the face of the sphenoid sinus and we reach the defect. We can reach the roof of the sphenoid sinus through this approach and even the lateral wall. But if it is a leak from the lateral recess of the sphenoid sinus, the blue arrow would not be able to get us all around this defect. So we need to go through the maxilla. It's called a transpterygoid approach. We go through the maxilla, open the posterior part of the maxilla, drill out the contents of the pterygopalatine fossa, open the face of the lateral recess, and then we are head on to this defect. If it's a cribiform plate leak, then we can easily go between the septum and the middle turbinate and we will reach directly to the cribiform leak. If it's lateral lamella and fovea ethmoidalis, as shown by the yellow arrow, we have to go by a classical functional endoscopic sinus surgery approach. We remove the uncinate, we uncap the bulla, and once we completely uncap the bulla, we will be able to see the lateral lamella and the fovea ethmoidalis. And the frontal sinus lateral part leaks. It can be external or internal. Many times the anatomy is decent enough in which you can go endoscopically. If not, don't try to struggle. We will end up stenosing the frontal sinus and this leak will not be able to close. Eventually you will have to go through an open approach. So take your decision judiciously depending on the anatomy and our skill level. So I will be showing the videos now. Next slide. Can you play it? Okay, so this is a defect in the cribiform plate, right? I am in the left nasal cavity. This is the middle turbinate, and you can see the meningoencephalocele very clearly. We are using Merocil soaked in adrenaline. I'm using a coblator, and that is the meningoencephalocele. So the advantage of using a coblator is, again, it's a single device. It contains coblation, irrigation, suction, and coagulation. So we take away the meningoencephalocele. Even if there is some brain matter encountered, that brain is glyosed, we don't need to worry about it. Then we use Surgicel and fat. I don't use fat alone because initially I was using fat alone. Fat alone is a little difficult to work with. If you wrap it with Surgicel, it makes it easy to push into the defect. So once that is done, a fascia graft taken from the thigh is kept over it by the overlay technique. Make sure you have adequately removed the mucosa a few millimeters around the defect because the graft needs to seat on it. A small piece of Surgicel can be used or cannot be used, that's personal preference, to support the graft, and a drop of glue, fibrin glue, is kept over the repair. So that is all you need to do, and no nasal packs are used since the nasal cavity is very clear. Next slide. So now we are doing a repair of the lateral lamella. Lateral lamella, like I said, you have to go through the classical functional endoscopic sinus surgery room. So we can see this is the right side, we can see the middle turbinate, we can see the bulla, and we can see the uncinate process. So again, I'm using a coblator. I like to use the coblator in the initial steps because I want the field to be clean. When I reach the meningoencephalocele, I don't want a pool of blood around it because I will not be able to define the limits otherwise. So I'm doing an uncinectomy. It is done by ablation. Any bleeder is taken care of by a coagulation. So you just ablate the mucosa, then you can use a microdebrider or whatever, and that is the bulla ethmoidalis. Notice how clear the cavity is till this point of time. Now we are taking away the mucosa over the bulla ethmoidalis. We don't want this to bleed unnecessarily because I know that once I uncap the bulla, I will be head on onto the defect. Through very thin bone, the coblator can go through. Through very thin cartilage, the coblator can go through. So you have to be a little careful. And then using a J-curate, I am pulling out the coblator. This is personal preference. You can do with a straight microdebrider. You can use a through-cut microdebrider. And the key is to uncap the bulla ethmoidalis completely. If we don't uncap it completely, we will not be able to see that meningoencephalocele. So see how I am removing it from the top and the meningoencephalocele has come into view. So this is the same patient which we are operating. That is the leak in the lateral lamella. There's a spur on the right side. We don't need to address it. Is the video playing? And no, you have to go back. I think it plays, there's a lag in this video. And these are the inferior turbinates. If we need space, like I was showing yesterday, we can in fracture and then out fracture the middle turbinates just to create space. So we have already done the uncinectomy. That's the spur which was visible on the CT scan. And we have just packed it with Meroseal to make the field clear before I even engage the meningoencephalocele. So bulla has been removed, uncinectomy has been done, and I was already shown you the meningoencephalocele right here. So see how it is popping out, but this is not its origin. You need to reduce it. You will be able to see the origin higher up in the lateral lamella. So again, I'm using a ProSize Max wand, and I am just ablating away the meningoencephalocele. If there is any bleeder, you can correct it with a coagulation mode there. And make sure around the defect, you have to make the bed of bone bare for 3 to 4 millimeter. If you don't do that, the graft will not stick to it. And because of the narrow dimension of the coblation, it can work very easily in narrow spaces. So that is a nice circular defect from the lateral lamella. Most of these defects, the shape is round. This I realized after I started using the coblator, because before that, when I could not see very finely around the defect, I would end up fracturing the skull base many times in cribiform repair defects. Now you have to separate the mucosa. It is like ear surgery, where you have to freshen the margin. You have to separate the mucosa from the dura. Because why is this defect not closing? Because the dura has joined with the mucosa on the outside. So see how we are elevating the mucosa. This is what I tell my students also, that it's just like ear surgery. Freshen the margin. Move the mucosa back a few millimeters. Once that is done, then you can start inserting your fat wrapped in Surgicel. This I like to use a dumbbell repair, what I call lateral in cribiform plates. In lateral lamella, the surface is very flat. In a flat surface, you can easily insert a very thin bone taken from one of these ethmoidal labyrinth parts. But in cribiform, I use a dumbbell-shaped defect. Half of the repair goes inside, half remains outside. The pressure of the CSF kind of secures it in place. So in this case, we will completely push it on the inside. We keep a small cottonoid here. If I have to do any suction, I take the cottonoid up to the defect and suck on the cottonoid. You don't want to pull the defect repair which you have just done. and you'll be able to see this bare bone all around. This is what we have created for the bed of the graft. So I just gently take it, I can suction on it like that, and then just pull it down with the suction. And then I take this little bone from the labyrinth. I like working with bone better because it's as pliable as a cartilage, but it's very, very thin. So again, matching the size takes a little experience, but after you have done a few cases, you will realize it's not very difficult. So you insert half part of it inside, right? And then you fracture it from here to create a notch right there, and then you engage your instrument and push it inside. So it has gone in as a underlay, and that will reinforce your defect. Then a small piece of graft, again taken from the thigh, and a spot of glue. Again, no nasal packs are used because the field is quite clear, there is no bleeding. Next slide. This is a sphenoid roof leak. Okay, again the corridor, because this is not the lateral recess, the corridor is again between the septum, this is the right side we are operating, and the middle turbinate. These were our first few initial cases. Again, using a coblator, we are coblating, that's the superior turbinate. So we are coblating part of the superior turbinate to create some space, because you need working space, you don't want to struggle with your instrument. And we are coblating away the face of the sphenoid. You will get a twig of sphenopalatine artery on the lower part. I'm using coagulation mode to coagulate that away. So after that is done, using a ronger or a drill, you can open up the face of the sphenoid sinus. You can already see the meningoencephalocele has come into view there in the back. So when engaging your ronger, be very careful, don't bite into the meningoencephalocele, because meningeal vessels can bleed torrentially and they are a pain to control then. Now you can see this nice meningoencephalocele hanging from the roof. Use the coblator. And look at the flow of CSF. And the best part is, if I was using a bipolar cautery or any other instrument with such a flow of CSF, the instruments don't work. This works even better when there is fluid, because plasma, to form plasma, you need a liquid medium like saline. Now you can see the brain matter. That is again gliose brain, you don't need to worry about it. And you work around it. Like I said, you have to work around it to remove the mucosa and have bare bone over which the graft will be able to seat. We have reduced it completely. Like I said, this is one of my few initial cases. We never used Surgicel during those times, but Surgicel makes plugging the defect much easier. So gently teasing it in. And there. So that should take care of it. It's covered with a graft. Again, all by overlay technique, reinforced with Surgicel. We do not reinforce with Surgicel anymore. And then a spot of glue. Again, no nasal packs are used. And I can support this defect with a piece of gel foam. Next. Can you play it?
Greetings, everybody.
This has my
I am
audio.
Ramandeep Virk, a professor in the Department of ENT at the PGI Chandigarh. I will be demonstrating repair of a CSF defect from the left lateral recess of the sphenoid sinus by the transpterygoid approach. The lateral recess is nothing but a pneumatization of the sphenoid sinus into the pterygoid process as pointed by the green arrow. We have to work between the Vidian canal, labeled by the yellow arrow, and the foramen rotundum, labeled by the black arrow, to be able to get to the defect head-on. This is a case of spontaneous CSF leak from lateral recess of left sphenoid sinus. After the middle and the superior turbinates are lateralized, the face of the sphenoid sinus and the ostia is identified. Using plasma ablation, the mucosa over the interior face of the sphenoid sinus is ablated away.
We are widening the opening with a ronger.
Using a ronger, the natural ostia of the sphenoid sinus is widened. Now we can see an active CSF leak, and the arrow will point towards the meningoencephalocele. Notice how this approach will not let us reach the lateral recess of the sphenoid sinus. Part of the middle turbinate is resected out.
So this is the transpterygoid approach. We would not have...
An uncinectomy is performed in the next step. After that, we do a wide maxillary enterostomy, reaching up till the posterior limit of the maxillary antrum. The tissue is coagulated away around the sphenopalatine foramen, and the sphenopalatine vessel is coagulated. The arrow will point towards the crista ethmoidalis, which is a landmark for the sphenopalatine foramen. Using a ronger, we can remove the posterior wall of the maxillary sinus. A part of this wall has to be removed since the approach we are going to do is a transpterygoid approach. Small vessels can be encountered, which are branches of the sphenopalatine artery, and they can be coagulated away.
Small vessels are taken care of.
Now we can see the contents of the pterygopalatine fossa. Part of the sphenopalatine ganglion is coagulated away, and further bone is removed depending upon the degree of access we need to achieve. We can clearly see the fat and the other contents of the pterygopalatine fossa. Gradually coagulating them away, we can now identify the interior face of the lateral recess coming into view.
This blue area, that's the interior face of the lateral recess. Now you are head on. You have to sacrifice the Vidian nerve. You might get some troublesome bleeding from the Vidian vessel.
Some troublesome bleeding can be encountered, which are the vessels accompanying the Vidian nerve as pointed by the arrow. Now drilling is started between the Vidian canal and the foramen rotundum, and the bone is taken away. We use a mixture of cutting burrs and diamond burrs depending upon what we have to achieve. Now we can easily see the meningoencephalocele, which has come into view. No work on the meningoencephalocele is started till we can completely see around it. At this stage, we shift to a 30 or a 45 degree endoscope, and using a coblation, we gently ablate away the meningoencephalocele.
Again, some brain matter can be seen.
Once the meningoencephalocele is ablated away, we can clearly identify the defect and the bony margins. Using a sharp sickle knife, we remove any mucosa which can be adherent to the meningoencephalocele, making the defect very clear.
Again, you will see the defect is perfectly round.
Now we can see a circular defect in the lateral recess. We have shifted over to fat wrapped in Surgicel rather than fat alone, as the Surgicel makes it easier for us to work in confined spaces. Using a ball probe, we gently push a small pad of fat wrapped in Surgicel into the defect. Then we use a small chip of bone which is taken from the ethmoids to cover the defect. It is inserted inside the defect.
Again by underlay technique.
A small piece of fascia lata which has been harvested from the thigh is used to cover the defect. We use the overlay technique. Care must be taken to make sure that the graft is well spread out over the defect and there is no curling up of the edges. Fibrin glue is applied over the fascia lata.
And a single piece of gel foam to support the repair.
And a small piece of gel foam is kept to apply pressure.
Again, no nasal packs are used.
No nasal packs are used. And a 0-degree endoscope is used for one last time to inspect for any bleed that might be there. This is an endoscopic picture of the same patient at 3 months post-operatively.
3 months post-op.
Our technique and long-term follow-up of the last 10 years was recently published in World Neurosurgery. Thank you.
Next slide. So we published this lateral recess defects and their repair and a 10-year follow-up of all our cases. It got published a year or so ago in World Neurosurgery. Next slide. Okay, so this is another video. In this case, the defect is from the lateral wall, but notice there is no lateral recess. So these cases can easily be approached by a head-on approach, that is between the septum and the turbinate. You don't need to go through this part. No, it was playing, there was a video. It plays after some lag, I think. And that's the, it's playing, I think. Okay, we can come back to it later. So this is another defect. It's called the clivus leak. Honestly, before this case, I had never known that there can be CSF from the clivus. This patient was operated outside. Someone had done a defect from the cribiform repair, because when you can't see a defect, we tend to see defects. It has happened with me in the past, that it must be from here, it must be from here. So someone repaired the cribiform. That cribiform was leaking too. The patient was referred to me for cribiform repair. I repaired the cribiform, the leak still was there. And what was the problem? We were not looking at the scans carefully. And a neurosurgical resident picked this up. He said, sir, there is a bony defect in this part. And the patient had already undergone 2 surgeries for a defect which he never had. So things like this can happen, but that is how we learn. We are constantly learning. That is how we learn. Is the video playing? Yes. So this is a, can you go back? Sir wants to see the defect. Okay, so this is the defect and this is the sagittal view, that's the defect. Okay, so this is the 3rd surgery now the patient is undergoing, and there was a small leak from the clivus. See how the CSF is filling up. I mean, had we seen the scans carefully, we would have corrected this patient in the first time. So we are using the same approach, coblation. We widen away the sphenoid sinus with a ronger. We need more space. And you can see the bony defect here and the pulsations from the basilar artery in the back. So you have to be a little careful. Your instruments will tend to, engage the lower part of the sphenoid sinus because the clivus is way lower. You can drill it out if required. That depends on how much and how much approach you are comfortable with. And I forgot to add, the 3rd surgery which we did, the patient was again being taken up for repair of the cribiform repair defect, not of the clivus. It is only intra-op we found this. So again, using a coblation, we are coblating away the defect and we are bearing a bone around it. And the defect was so tiny, it was a pinhole. I couldn't even put a piece of fat, so I gently had to enlarge the opening. So that's the bony margins of the defect, just kind of freshening them so the graft will be seated comfortably over it. And that is the little tiny defect. So I had to widen it because I was unable to put any fat in it. So a risky maneuver, but I can see the tip of my sickle. So I just widened it a little. And gently made it circular so that I could put a dumbbell piece of fat. And you see how beautifully a dumbbell piece of fat works in this area. So there is so much pressure of the CSF, I try to put it in, it will get thrown out. But once half of it goes inside, then the CSF pressure enlarges the fat which has gone inside into a mushroom kind of shape, and that seals the defect. And that's all you need to do. See, the leak stops immediately. So we waited for some time to make sure that our repair is adequate. And the graft was nice and thick because we had already taken a facial atta graft twice for the previous surgeries. We could not get that thin graft again, other than give an incision on the other thigh. Just covered it up, spot of glue. And that finally stopped the leak in this patient. So this case serves, serves us to teach us, how we can evolve as surgeons and to accept our mistakes, right? Play next week.
Greetings everyone, I am Ramandeep Virk, working in the Department of ENT at the PGI MER Chandigarh. Today I will be demonstrating a CSF leak repair from the fovea ethmodalis. We can see here in the CT scan, as pointed by the green arrow, the defect in the fovea ethmodalis. We start by nasal decongestion. We use Meroseal, which has been soaked in adrenaline, to decongest the nasal cavity. After adequate decongestion has been done, we can identify the middle turbinate, which has been flattened by the meningoencephalocele. We can see the meningoencephalocele protruding out, and we can see an everted uncinate process. Using an upward through-cutting forceps, we take away the uncinate process. Care must be taken not to open up the meningoencephalocele at this point of time because troublesome bleeding can occur.
So the uncinate has gotten pushed out by the meningoencephalocele. So I'm just doing an uncinectomy. That's the meningoencephalocele right in the middle, and the middle turbinate.
Using a ball
out.
probe, the maxillary antrum is identified and opened up. This step is done as a landmark for our surgical procedure. Using a microdebrider, the remnant of the horizontal part of the uncinate process is removed.
So make sure it is pointed downwards, otherwise.
Now we use the coablator to coagulate any superficial blood vessels over the meningoencephalocele. There can be troublesome bleeding from the meningoencephalocele when we handle it. So this step ensures that troublesome bleeding does not take place. Using a sharp scissor, the lower end of the meningoencephalocele is resected to be sent for histopathological examination. Now we use the coablator in the ablation mode and rapidly debulk the meningoencephalocele. We can see the thinned and destroyed bulla ethmodalis, which has just come into view.
So see, the meningoencephalocele has thinned and destroyed the bulla.
Using a 40-degree upward microdebrider blade, we debride away the remnant part of the bulla ethmodalis. This opens up the space and makes it easier for us to work around the meningoencephalocele. If there is any bleeding, we can coagulate using the coagulation mode of the coablator any blood vessel that is there. Some troublesome meningeal bleed can occur, which can be managed by the coagulation mode of the coablator. We can see a nice circular round defect here in the fovea ethmodalis, and we are working around that to remove any mucosa so that the graft can be seated over the bare bone. Many times the mucosa is attached to the dura. Using a sharp sickle knife, the dissection must be done to elevate that mucosa from the dura. This ensures adequate plugging of the defect and adequate healing of the repair.
This step is very important.
Any little mucosal tags are again taken away by the ablation mode of the coablator.
Now you can see the bare bone around.
We can see that hemostasis has been achieved and there is no bleed from the meningeal vessels. Next, the superior part of the bulla ethmodalis is gently teased downwards and cut away with a through cut, exposing the frontal sinus.
So because of the blockade, the frontal sinus had polypoidal changes in it. So you need to open it
Any
up.
bone chips are taken away, and we can now see some polypoidal change in the frontal sinus, which was due to obstruction. Next, using a sharp turbinectomy scissors, we create a flap from the middle turbinate. Now we use fat wrapped in Surgicel to plug the defect. A couple of pieces of fat wrapped in Surgicel are used to plug the defect, and a small piece of cartilage is then harvested from the septum.
So we were forced to use cartilage. I couldn't find an adequate size.
And using a
bone
sharp
piece.
elevator, the cartilage is inserted into the defect by an underlay technique.
But make sure all of it goes inside. Don't leave half of it inside, half of it outside.
Make sure all the edges of the cartilage are well tucked under the bone. Now again, using a small piece of fat wrapped in Surgicel, we keep this over the cartilage and tuck it around the edges to prevent any little leak which can be there. Then we turn our attention to the middle turbinate flap and we gently move it upwards to completely cover the repair site. Many times we have seen that if the flap is a little long, then with gravitation or with the patient sneezing, the flap can move. To prevent that, we put a small piece of fascia lata to support the repair.
And don't block the frontal sinus, because if we do that,
This
patient will
repair
have
is covered with
sinusitis.
fibrin glue and reinforced with gel foam. A couple of stamp size pieces of gel foams are used to just support the repair. No nasal pack is required. Thank you.
Next slide. So this is a pediatric meningoencephalocele. On the CT scan, you could see how large it is. It was completely coming into the anterior part of the nasal cavity. T2, intense. So I'm doing part of this with bipolar cautery. This was to demonstrate versus a cautery. So I will switch to coblator later on, but see the angle with which I have to work high up if I have a bipolar cautery. So I'm just coagulating the surface vessels, and then with a scissor I'm going to cut it out from the neck. As soon as I cut it, there will be of course profuse CSF which is going to come out. There. That's and the defect is still up there. This is just the normal mucosa which fills with CSF and prolapses downwards. So we are going to resect this, send it for histopathology, and then switch over to a coblator. So coblator can do the cutting the scissor is doing, it can do the coagulation the bipolar is doing. And see the field, it gets all smoky, someone has to irrigate, someone has to use suction. And that is the meningoencephalocele on the top. I would not be able to angle my bipolar forceps till there. So we are back to the coblator, nice and easy, single device, irrigation, coagulation, ablation, and suction all in one. So if there is any bleed, that is coagulated away. There, press it for a couple of seconds, the bleed stops. After creating my area, I turn my attention to the meningoencephalocele. There is some brain tissue as expected, debulked it, that like I said, the brain is all glyosed. Work around it, expose the bone for the bed, create the bed for the graft which you are going to use, go around it. And again, it will be a nice round circular defect. I have not seen another shape of defect except in traumatic CSF leaks. That's the brain matter. Again, separating it out from the surrounding mucosa and then rapidly debulking it. And see this bed we have created for the graft. Once that is done, you can see the white dura clearly around the edges. And a nice circular defect is present. I've put in a small piece of Surgicel and fat. Another piece of Surgicel and fat is pushed inside. Many times you have to take the graft in and out multiple times to get the exact size. But that is okay. Again, with experience, you will exactly know the size of the graft you need. So this was probably a larger graft. So do you see the white dura around? That has been separated from the mucosa. And tucked the graft a little bit on the upper end, because the position of the defect is such that with gravity it can tend to displace. Cover it with a spot of glue, a few pieces of gel foam, and that completes the repair. Next slide. So that brings us to the end of my talk. Nasal packs are not used. Bed rest is for 48 hours only, and antibiotics are 72 hours according to the Institute antibiotic policy. Next slide. So what are the take-home messages? Start with simpler cases. Don't go with the extensive, difficult to reach cases. Learn to read the scans like we learned from the Clivus. So as a matter of protocol, all our scans are now read on the DICOM on our laptops. Take a senior colleague's help if needed. There's no shame in doing that. Use coblation if available. It has really changed the way I operate CSFs. I'm telling you, before that, I used to inadvertently fracture the cribiform looking for a defect. And I don't know, maybe I have created another defect and repaired that and thought that I have repaired it. But this gives me a very clean, precise field. Make sure bone is bare a few millimeters all around so that the graft can sit on it well. Release the dura which is attached to the mucosa, and use fat wrapped in Surgicel. It makes working easier. Thank you. I'll be happy to take any questions. Are we okay on time?
We are a little behind time, but we can allow some questions.
From the thigh, sir. Facial atta and the fat from the thigh.
In the thigh?
Yes, sir. A small incision in the thigh.
Right. So do you use lumbar drain anytime?
No, sir. We don't use lumbar drain. If we have a revision leak, that is more for sphenoid pituitary cases. I mean, when we're doing transsphenoidal pituitary cases, and we don't use lumbar drain as routine. But if the patient presents with a CSF leak, then when we repair, we do put in as protocol a lumbar drain.
Do you measure the CSF pressure?
Ma'am, CSF pressures are cannot be measured, because when the patient is leaking, you will always find normal CSF pressures. Literature says to measure CSF pressures after you have plugged the leak. And when we ask the patient to do that, the patient runs away.
Now, do you insert VP shunts also?
VP shunt only if the pressure we have measured after our repair is more than 20 millimeters.
After?
Let's say we repair the defect and the patient, so all these patients are put on a drug called topiramate. Okay, it is like putting the patient on Diamox. The advantage of topiramate is that it causes weight loss. It causes weight loss due to a number of factors. Number one is patient loses some amount of taste. It gives him that metallic taste. Patients don't enjoy food. Secondly, it interferes with the glycogen synthesis. So the patient has a rapid drop. We all know that this is a disease which is majoritarily seen in women and with a high BMI. Now, a patient who has just undergone a so-called brain surgery, and if you tell them now you have to exercise and lose 20 kgs, it's not going to happen. It's not going to happen. Even when we say the patient you can mobilize around, they keep on laying down for a good 4 to 6 weeks, and that weight drop doesn't happen. Topiramate changed that. Your defect repair is only as good as how you manage IIH. If I stop topiramate, the pressures are going to rise again. The patient is either going to leak from the other side or from the ear, or is going to open up the same defect which we have repaired. So topiramate is started at 25 milligram BD. And one thing which we have to tell the patient, after I plug the leak, patient immediately post-operatively has severe headache. That is because nature has given him a vent to leak the CSF, the pressures in the brain are low, and the patient doesn't have headaches. But after you plug, all my patients in the evening, they only complain, they don't complain about the thigh, they don't complain about the nose, it's the severe headache. So we start topiramate a few days before we take the patient out for surgery.
If it doesn't work, you put the VP shunt.
If topiramate doesn't work, then they go back to the neurologist, they measure the pressures, and if above 20 millimeters, then yes, a VP shunt is an indication. Then the neurosurgery people, I mean, it's beyond my limited expertise on this topic. But pressures, they say not to measure when, because ma'am, if the patient is leaking, obviously the pressure taken from the back will be normal. But the MRI really helps us because majority of these patients will have these findings. Empty sella, tortuous nerve, perineural enhancement, flattening of the globe. These findings are there in most of the patients. That is the only indication of doing this MRI. So fluorescein, it's a very valid question. Fluorescein is the dye they used. It can be injected intrathecally. We started use of fluorescein. Initially, we were doing a topical application of fluorescein when we were not able to find defects. This happens early on in your career. I many times would struggle to find defects. These videos are way down my career now. I mean, had you seen my earlier videos, you would have probably never called me back again. Because, I guess that's how it is with everybody. We don't read the scans carefully. We don't understand the corridor we are going to use. It is only after training and retraining that it becomes so easy. So that is why, I always talk about the corridors of surgery. Now, if the defect is in the cribiform and you have gone through uncinectomy and a bulla, you are not going to find that defect. Then eventually you'll end up cutting the middle turbinate, dropping it down, and then you will see the defect where it could have been easily identified going through the septum, between the septum and the middle turbinate. So proper training, that's why we run modules for patients, and even neurosurgeons, attend these modules. We have a very good skill lab where we teach these corridors and the ideal way to approach a patient. So we were using topical fluorescein. What happens once you apply fluorescein on the skull base, the trickle of CSF turns white. So that is called a streaking effect that can be seen. But many times what happens, patient lays down, CSF, anesthesia intubates, CSF, you start working, the leak stops. And that's it, because there's a limited amount, it's continuously. And that's it, because there's a limited amount, it's continuously leaking. Initial 50-20 minutes, CSF will stop. Then you will give Valsalva, nothing, there will be no leak. Then you will plug into XYZ space like the Clivus case. And I repaired the same cribiform defect the previous surgeon has operated. Post-operatively, patient is still leaking. Third time I am taking the patient in, again to repair the cribiform defect. So what was happening? We were probably not finding it. The cribiform is very thin. When you are using a ball probe to look around for a defect, you are going to fracture it. And that's what happens. So fluorescein, if you're unable to find it, go back, read your scan again. I mean, there is no way you will not see the defect. And in the past, they were using 3 mm, 5 millimeter cuts, 3 millimeter cuts. That will not show you the defect. You will miss it 100%. Use 0.5 to 0.65 millimeter. Know beforehand where the defect is going to be. CSF, the key is not to say, okay, let me see where the CSF. The CSF, the key is, the defect is here. I am lateralizing the middle turbinate. There it is. That is the way it should be. And for that, we have to train. There is no other way. And Kublation has made my life a little simpler because the field has become much clearer, demonstration is much better, and I've only found circular defects. And defects are less than 2 millimeter, 3 millimeter. And then it makes you realize that nature is very smart. There was excess pressure in the brain. As soon as a simple small hole is created, the pressures are going to drop down and prevent vision loss and other problems that can take place. We used to report leaks as 1 centimeter, 1.5 centimeter. I've never seen that now.
Did many of your patients presented with recurrent meningitis?
2 patients, no
recurrent.
One patient in the transsphenoidal leak, we could not identify why. There was no leak, MRI, CT, everything was okay, but he had meningitis.
Meningitis?
Yes. Post-operatively.
No, beforehand?
Yes, ma'am. Multiple patients present with meningitis because many times, like this clivus leak, now this can come from this side if the septum in the, this patient didn't have a sphenoid, complete sphenoid septum in the midline. Leak would come from the left side, right side, majority of this patient, when you have a common cold. And many of them develop meningitis. Which subset will develop meningitis, we don't know. Because many have, leaked for 5-6 years, they never seen a doctor, but they never had meningitis. Many first time present only with meningitis. Yes, nature is way smart than us. Absolutely, we are increasing the pressure. That is why the drug comes in. And if you don't give the drug, the patient will leak again. Because the nature wants to save you, it wants you to live. Sir?
This fibrin glue preparation is also a cumbersome procedure.
It is a cumbersome process. Luckily, I have my residents do it, like including taking a graft and all. So there are two methods. There's a quick method and then there's the other method is usually 15 minutes. They have a special tool in which they give us, it's called a fibrinotherm. They spin the vials in that and prepare it. So if you have a few minutes, they wanted to see something on airway. If that is okay. Can you start the other, the Microsoft PowerPoint? Ma'am, any more questions? Yeah. ProSize Max. If they try to sell you a EVAC 70, don't buy it. It's the most worthless wand. I think even Smith and Nephew themselves won't be using it. Fibrin glue? No, ma'am. We don't use. And even with the glue, there are multiple studies that, either you use it or you don't use it. The results are not any different. It depends on your repair. But sometimes it's very difficult to, change. Once something has started giving me results, I'm a little apprehensive in not using glue, though it would save substantial cost to the patient. Glue in our country is about 15,000 rupees, which is quite steep for a poor patient coming to us. But, I have not been able to convince myself of not using it, and I know I'm wrong, because literature says that you can not use glue and still get away with similar results. Oh, 1 second. On the big screen. Right. Bone is easier to handle, and that is per se not going to prevent your recurrence, because like I said, dura mater will not regenerate. It is the mucosa which is growing. So it just acts as a scaffold. After that, even if it reabsorbs, it really doesn't matter. Even if you don't do it, it's absolutely okay. Like in many cases, I have not put, it's just, it's just cool to show how you can work in a confined area. That's about it. Other than that, I don't think so. It's, yeah. So if the defect is very big, you don't want the gravity to lose the defect. Next. Next slide. So I will just speak a bit on coblation. What is plasma ablation? So when liquid vaporizes, it forms gas. When gas ionizes, it forms plasma. Plasma is an ionized gas. It consists of free electrons, ions, and excited radicals. Next slide. So coblation generates a sustained plasma layer used to remove target tissue while minimizing damage to the surrounding areas. What does coblation mean? It is made up of these two words: controlled ablation. So that's why we call it coblation. Next slide. We can skip. I think all of you know how a coblation wand works. I mean, depends. Do you want to see these slides, or is it okay? I can just go on to the videos. You want to? Skip. Okay, just go on to the videos. Skip. Next, 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 next. So these are the airway wands. We have the micro-laryngeal wand and we have the precise wand, the laryngeal wand, which we used yesterday for our cordotomy. Next. 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 So to work on pediatric airways, we use a Miller's blade. Miller's blade has a straight blade with a, a notch. Our endoscope goes through it. One of the residents or one of my junior consultants holds it. I still have an open space on the side to work on it. Next. We already published this technique a few years ago. Next. And that's the anesthesia technique. If someone wants to read, this is what ma'am was asking, what an open airway means. So open airway basically means how much apnea time they are able to give us without putting the tube inside. So they use nasal prongs for oxygenation to increase the time. Next. 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 Play. So this is a valvular cyst we are doing. Again, we can see the valvular cyst in the valvula. It's a pediatric valvular cyst. We are using a Miller's blade. These are a few of our initial cases. So this is an older wand which we are using, the EVAC 70, which I was telling you about. Using coagulation, you can see these leash of blood vessels. Coagulate them away, otherwise your field is going to, get in the way. After that, go through the cyst, suck out all the contents because it has a suction. Then take care of the lining. Make sure you remove the lining or this valvular cyst is going to come back. So we are almost bearing the cartilage on one side where its origin was. You can see the whitish cartilage. It is going to mucoalize very easily. This is it is an unedited video. It takes a few minutes, to complete this procedure. And again, there is no bleeding. If you do see some bleeding, there is a coagulation mold built into it. Just take it there and control it. So that completes the procedure. Next slide. So we have done a multiple of congenital valvular cysts. All have been published in Indian Journal of Pediatrics and JPMER. Next. Tracheal masses or granulation. Yesterday someone was asking how do you remove the granulation tissue when I said you can use the window from the trachea. Play. So we put an endoscope like how me and Dr. Daminder were doing yesterday, and we put the wand from the tracheal side. Again, this is an unedited video. We're using a precise max which we are bent to reach up till the trachea, and that takes it away. No bleeding, nothing, no struggle with instruments, and it gives you a nice field. Next slide. We have done pediatric tracheal tumors also using the same technique. So what we do is we put the endoscope, we create a window in the trachea, the Bjork flap for tracheostomy as it was mentioned. We put the wand through that through the trachea, we remove the tumor and then we close the flap and the patient is extubated. Next slide. Tracheal stenosis, can you play this? Again, now this patient, like yesterday some were asking, are all patients tracheostomized? No. All patients, when they come to you, some are tracheostomized already, some are hoarse, they can't breathe, but they are okay. So we are using a laryngeal wand. I'm using a micro-laryngeal wand. This is a single electrode. I'm just removing the tissue gently. There has been a steep learning curve in this. Previously, we used to remove a large part and that stenosis used to come back. Now we just work minimally, then we gently use a Buji dilatation, then again take away some part of the stenosis, again gently dilate it. And see the spaces gradually open up, and we apply mitomycin C in all cases of tracheal stenosis. And that is the final result. Suction any secretions or saliva or whatever has gone inside. The patient was not tracheostomized, as you can see. Now you can see up till the carina. Check, because multiple times you can have stenosis at 2 segments. And that completes the procedure. Next slide. Cottonoid dipped in mitomycin, 0.4 mg per ml, 2 minutes, 3 applications each. That is the post-operative at 6 weeks. So some part of stenosis has come back, but the tracheal lumen is still adequate for the patient to continue with their daily activities. Next slide. So that's the same patient, and doing well, no tracheostomy. Good healing. You can see some areas of fibrosis, which is understood because it's a surgical trauma that has occurred. Next slide. We published our data on tracheal stenosis in the American Academy. We presented it there. It was published in the Otolaryngology Head and Neck Surgery, which is the official journal of the American Academy of Otolaryngology. Next slide. Then we have also used it successfully for supraglottoplasty for laryngomalacia in children. Next slide. Play. So this is done by our pediatric colleagues. You can see the omega-shaped epiglottis. It is flopping on into the posterior pharyngeal wall. You can barely see the cords and the omega shape. Do you see how it is coiled like that? That happens because of short AE folds. So again, we go in, you can see the short AE folds. There's barely any AE fold. When there's a short AE fold, the epiglottis is going to close the airway. Child will have, you can have stridor, carbon dioxide retention, failure to thrive. Again, using a microlaryngeal wand, we are just nicking it away. And you will see that once both sides of AE fold are nicked away, how the epiglottis goes away from the posterior pharyngeal wall towards the tongue. Any edematous tissue is also taken away. That is also a classification of laryngomalacia. Now to the other side. Again, it doesn't take more than a few minutes, but like I said, there is a steep learning curve to all these procedures. So see how it has moved away from the endotracheal tube, gone away towards the tongue. Don't overdo this or the child can have swallowing difficulties. The child is going to aspirate. When we started it, first case, I was over enthusiastic, went deep down. So the pediatrics people had to manage the child with postural feeding. Now I'm just taking away the lax mucosa, which is there. And that is all classification of laryngomalacia. We will not go into that, just pure theoretical work. And now you will see in the post-operative fiber optic done by our pediatric colleagues how the epiglottis is not touching the posterior pharyngeal wall anymore, and that completes the procedure. Now that's the post-operative. So you can see that opening and see how it has gone away. You can see the larynx now so clearly because the epiglottis kind of becomes erect. Next slide. Next slide. Play. So this was a very tricky case. This is JORP, okay, juvenile onset recurrent papillomatosis, not only of the glottis but also of the trachea going on into the lungs. Now, if I didn't have this tool, I would not be able to operate it. How would you operate on the trachea? Look at the amount of tissue, the disease that is there around the tracheostomy tube also. And look at the chunk. So after we removed that, we thought we are okay. But look, lower down the trachea, we again find the lesion. So what do? We insert the coblation wand bent from the tracheostomy, endoscope from the top, and we take it away. And we thought once we do this, we are good. But human body always has surprises for us. Left main bronchus. Again, we have lesion. We go back, bend the coblation wand a little more, take it to the left main bronchus, and remove the disease. Next slide. And that is the post-operative of the same patient. 6 weeks, you can see some cobblestone appearance. You can see fibrosis at the carina where myoablation had removed the disease. Left main bronchus, right main bronchus, both are okay. I would not have been able to get to this had I used any other instrument. There is no instrument long enough to go through the vocal cords till the carina. I wouldn't have been able to do it. Plus the bleeding, patient would have aspirated the blood into the lungs. Next slide. Supraglottic. Okay, we have also done supraglottic stenosis. That's also been published. Next slide. So this was, I'd never seen something like this. It was a pediatric supraglottic stenosis. Now, the child was not tracheostomized because he could breathe through the hole which is present in the back. So we again go in with a microlaryngeal wand and separate it out. So why I am showing you with this, because this can maybe be done better with a laser because of the precision of the cut, but like Daminda was saying before, laser is something which all centers cannot buy and afford. A coblation is a much cheaper tool compared to that. So we just separate it out, and how do we prevent it in a child from coming back again? We applied a spot of fibrin glue in the interior commissure. Just a drop with a fibrin glue, same which we use for CSF repairs, so that the interior commissure doesn't stick together. Next, pearls we've already spoken about. Yeah, thank you. That's about it.
Thank you, Professor Ramandeep, for excellent and interactive session. I invite Dr. Manab Sirip to hand over the certificate and the token of appreciation to Professor Ramandeep. And that concludes the morning session, and I invite all the resource persons for the panel discussion in the afternoon and 3 o'clock. And now we can break for lunch, and please be here by 1:30.
During the lunch break, and I kindly request all those involved in the poster presentation to position by your poster so that you may field questions from the judges. The judges for the sessions are the consultant ENT surgeons, Dr. MTT Lakshan and Dr. Zafarullah Wazil. And also just a kind reminder for you all to visit the stalls, especially those in the orchid extension as well. Lunch will be provided at the Anthurium extension. Thank you. We shall now begin the session 3. This session will be chaired by consultant ENT surgeons Dr. Chandra Jayasuriya and Dr. Ravindra Kirihena. I would like to invite Dr. Chandra Jayasuriya and Dr. Ravindra Kirihena to take their places at the head table.
President, can we ring the bell again? A lot of people are in the lunchroom.
Good afternoon, ladies and gentlemen. We are about to start the afternoon session now. Next session will be chaired by Dr. Chandra Jayasuriya and myself. And I would like to introduce Professor Suren Krishnan, who will be doing the next lecture. His lecture is on transoral robotic surgery. Professor Suren Krishnan is the current president of the Australian Society of Otolaryngology and Head and Neck Surgery. He is the honorary professor of Deakin University Institute for Intelligent Systems Research and a clinical professor of surgery at the University of Adelaide. He recently retired as the head of the Department of Otolaryngology, Head and Neck Surgery at Royal Adelaide Hospital. He was the first surgeon in the Southern Hemisphere to perform transoral robotic surgery at the Royal Adelaide Hospital in July 2008. He has proctored all Australian head and neck surgeons who have not had the opportunity of robotic fellowships in the USA and has been responsible for the training of the 4 senior TORS surgeons in the United Kingdom. Professor Krishnan is Australia's most experienced transoral robotic surgeon and has been responsible for the introduction of both the intuitive Da Vinci robotic surgical platform as well as the Med Robotics Flex system. He has performed or participated in over 300 TORS cases and conducted Australia's first TORS courses and participated as an invited speaker at many national and international meetings as well, contributing to the international literature on TORS. He has been recognized with Australia Day and Queen's Birthday honours for voluntary medical services to the Pacific Islands, Indonesia and Africa, as well as services as active Rotarian. On a personal note, I must mention I got to know him in Adelaide in the way back in 1999, and he has been a good friend to me ever since. He was kind enough to take me to his father's house for the Diwali festival. I can remember the day, 1999, since I was living alone without my family in Adelaide. So he was a good friend, and he has also helped in training of our 4 of our doctors here, Dr. Premanal Dimel, Dr. M.C. Pera, and Dr. Prasadika as well. Thank you very much, Professor Suren Krishnan. Over to you to start the lecture.
Can you hear me, Ravi?
Yes, I can hear you. Screen, you to share the screen now.
Okay, if you're ready, you just give me the ready sign and I'll start, and you can hear me, then I'll start.
Yeah. Right, yeah, we can hear you and you can see your, still your...
And you can see my screen?
Not yet. Ah, yes, yeah, it's there on the screen, yeah.
Video now?
You can hear me and you can see my screen, Ravi?
Yes, we can hear you, yes. We can hear your. Are you speaking or?
No. Can you see my screen?
Yes, yes, we can see your screen.
Okay then. Sorry, I was waiting for an answer.
Yeah, University of Adelaide. Yeah, slide is there.
Good. Thank you.
Okay.
So, thank you again for your kind introduction, Ravi, and thank you again to Dr. Veerakodi, President of the College of Otorhinolaryngologists, Head and Neck Surgeons of Sri Lanka. Thank you, Ranjit Jayavira and Ravi Kirihena and the organizing team for inviting me to speak to you all, and it's a great pleasure for me to talk on behalf of the team at the Royal Adelaide Hospital on our experiences with transoral surgery, and in particular with transoral robotic surgery. Okay. Now, I am the current president of the Australian Society of Otolaryngology Head and Neck Surgery, and I want to extend a warm invitation to you all to come to Australia. We have the 72nd annual scientific meeting to be held in Adelaide in June this year, and we'd love to see you there. If not, in March next year, we are hosting the 15th Asia Oceania ORL HNS Congress in Brisbane. So plenty of opportunities to travel now that COVID is apparently easing. By way of disclosures, I do receive research grants and educational grants from MedRobotics, Device Technologies, and Intuitive Surgical, who are the industry leaders in robotics. What funds we don't use or have in excess from our educational campaigns, we put into our foundation called the Dreaming Foundation that helps us do our voluntary medical work in the Pacific Islands and in Africa. I want to take time to acknowledge my mentors and my colleagues, and particularly at this poignant time, I want to acknowledge my boss, the late Jeff Rosenbills. At this time when we see the resilience of oppressed people in the Ukraine, let me tell you the story of Jeff Rosenbills. He was one of the oppressed people when the Soviets invaded Latvia, and he migrated to Adelaide. He couldn't speak English, and as a young man, he learned English. He worked as a kitchen hand, and then did medical school, trained in ENT, head and neck surgery, and became the head of our department. I'm very proud of the history and the demonstration of the resilience of the oppressed people of the world. This is the old hospital. If you can see my pointer pointing to the old hospital. These buildings were initially constructed in the 1840s, and this old hospital site is where we were privileged to host colleagues from Sri Lanka, Dr. Ravi Kirihena, Dr. Premalal Demel, Dr. Chaminda Pereira, and Dr. Prasadika Jayasekara. And again, I was very well looked after by them when I visited for the SARC conference about 5 or 6 years ago. The department has now moved to this address on West Terrace. This is a $3 billion hospital with wonderful facilities, both surgically and also for our patients. And I think you all know our faculty, led by Professor Wormold and Professor Saltis, who are internationally renowned for their work in endoscopic sinus surgery, and together with Rowan Valentine, lead an endoscopic anterior skull base team. Sharad Chawla is our lateral skull base surgeon, and Sam Arena, Sam Bose, Andrew Foreman, J.C. Hodge, Michael Swidijewski, and Rowan Valentine all are part of our head and neck service. Andrew Foreman, Sam Bose, and Rowan Valentine also provide us with free flap reconstructive options, and Vikram Padye is our expert on sleep-disordered breathing surgery. So we have a very extensive department, and we would welcome interest from colleagues wanting to train with us in Adelaide. I want to spend a little time thanking my colleagues who are part of the Head and Neck Consultative Clinic at the Royal Adelaide Hospital. The Royal Adelaide Hospital has had a multidisciplinary clinic examining treatment for head and neck for nearly 40 years. And it's really been the leadership of people like Dan Haynes and Andy White who established some of the basic principles that has allowed us to integrate with other surgeons from other specialties, with colleagues in radiation and medical oncology, and most importantly, with our nursing and allied health staff to provide a comprehensive treatment plan for our patients. It's also allowed us to introduce new technologies. We were one of the earliest units to introduce radiation techniques such as IMRT. We were one of the earliest units to introduce immunotherapy for treating our patients. And we are the only unit that will, in the next 12 to 18 months, have a proton beam service for Australia and the southeast of Asia. But it is also the cooperation within this group of people that's allowed us to pursue surgical advances, including transoral laser in the 1990s, and now more recently transoral robotic surgery. And I described to people that when I was introducing this, I felt like this tugboat in front of this superliner. And when you're trying to lead a group of people who are very intelligent, highly motivated to provide good services, then you have to sometimes expect that sometimes when you have a vision that they may share a contrary vision. And really it is your duty to provide evidence and get all your colleagues on board so that you can ensure introduction of good new technology and treatment options to improve the quality of life outcomes for our patients. So in the next 40 minutes, what I'm hoping to do is to give you a personal tour of my experience through the Royal Adelaide Hospital in minimally invasive targeted oropharyngeal resection, and then reflection of concepts of minimally invasive surgery about assessment and evaluating these tumors, understanding surgical anatomy, and understanding the concept of a compartmental resection, having reconstructive considerations for the defects you've created, the importance of liaising with your pathology services and understanding and evaluating tumor pathology, having good postoperative schemes of care, and then give you some examples with videos of robotic supraglottic laryngectomy and robotic transoral resection of parapharyngeal space tumors, and finish off discussing a few controversies and making some conclusions. So transoral surgery for oropharyngeal cancer is an old technique and has been performed for many years for small early tumors with great success. And this is a paper published in the early 2000s showing very good success rate for suitably identified early oropharyngeal cancers. And you can remove these with a headlight, and you can get some better magnification if you use a set of loops. But we found that the problem with these is always the lateral extent of resection and the inferior extent of resection abutting the tongue base. And so we were always on the lookout for better techniques. One of the things that we identified was the use of an Alberon or Fraundorfer cystoscope, which is a urological device which held a cystoscope and had a little deflector. And we described a novel technique using an ND-YAG laser fiber and a telescope and resecting tumors of the supraglottic larynx, hypopharynx, and oropharynx, which was published in 2005 by Vin Polari, who was our fellow at the time. Of course, we've moved on from this, but as you know, Professor Shotani from Japan has written extensively from this initially in 2010, but now has a large series talking about transoral endoscopic video-assisted surgery for the resection of these tumors. We also have used transoral laser microsurgery, which was popularized by Wolfgang Steiner and Petra Ambrosch, and we found this a good technique. However, we did have some problems associated with this. One of the problems we found was the ergonomics of this. We found that to access these tumors, we regularly had to position and reposition our laryngoscope. So the technique involves, suspension laryngoscopy and a microscope coupled with a carbon dioxide laser. And the problem we found was that the suspension laryngoscope, and we usually use a Lindholm laryngoscope, needed to be regularly positioned and repositioned to access the lines of excision. And often we found that these involved counterintuitive motions, that there was a problem sometimes with aligning the hand and the eye. There was instrument tremor because these instruments were 15-centimeter instruments, that these instruments were either straight or angulated but not wristed, as I will demonstrate with the robot. And although you were supposed to get a 3D vision, the view through the optics of a microscope provided you with what was essentially a two-dimensional vision because of the straight line optics. And this also sometimes prevented alignment of the CO2 beam when you were doing lateral resections or resections around the corner, around the tongue base. And the learning curve was slow. In Adelaide, we were lucky that we had a donation by the Pickard Foundation, and in the top picture is Gordon Pickard, who was a generous philanthropist who donated this first standard version of the Da Vinci robot to our hospital, and we were the only hospital in Australia with a Da Vinci robot system in the public sector, and it was mainly introduced for prostate surgery. At about the same time, we had a visit by Greg Weinstein, who's really been the leader in introducing transoral robotic surgery. And he spoke at the Adelaide Annual Scientific Meeting in 2007 and introduced us to the benefits of robotics. And this is the current robot we use, but basically the system that we had was similar to this. So you have what's called the surgical cart, which has arms that hold the telescope and instruments. You then have what's called a vision cart that provides vision for the surgical assistant, the nurse robot assistant, and the anesthetist, so they know what is happening in the operating field. And this cart also contains the diathermy console, as well as the optical console that converts the vision from the telescope into a three-dimensional vision that is presented to the surgeon console. So the surgeon sits here, puts his head in this console and gets a three-dimensional view of the operating field. The surgeon has pinch grip controls here to control the movements of the surgical instruments, and then foot controls here to move the telescope, and here to apply bipolar and monopolar diathermy at the surgical site. So the advantages of the robot are really these telescopes, these 0-degree and 30-degree telescopes, which are dual telescopes, and the vision is synthesized to give you a three-dimensional view when you put your head in the console, and the surgeon has these pinch grip controls, which effects an end organ action. And here are these wristed instruments that the robot deploys. Here are some graspers, here's a spatula diathermy, and here's a needle driver. So the surgeon at the console uses two instruments transorally and drives the telescope into various positions. And the assistant at the bedside then can apply two further instruments, and we use standard laser microlaryngoscopy instruments to deploy an action, including a clip applicator for controlling bleeding. And finally, the nurse assistant can deploy a sucker, so you can have 5 instruments inside the oral cavity whilst you operate. And after the lecture from Greg Weinstein in Adelaide, Guy Rees and myself and Professor Kim Seon from Korea went and visited Greg Weinstein in Philadelphia in February 2008 and did his first pig course, and then came back to Adelaide. And you really do need great support, and I was very lucky to have good support from good nursing staff, and I acknowledge Julie Bowd. And I had a wonderful fellow at the time in the way of Stuart Winter, who's currently Professor of ENT in Oxford. And together in 2008, we started our transoral robotic work. Since then, we've done now some more than 400 cases. Predominantly, they are tonsil and lateral oropharyngeal resections, tongue-based resections, and we have had experience with hypopharyngeal resections, oral cavity resections. We've done supraglottic laryngectomies, vertical partial laryngectomies, and have independently described 9 total laryngectomy cases and experience with parapharyngeal tumors. We've also experimented with neck dissection and surgery for sleep disordered breathing. We've published in the literature and written in textbooks on robotic surgery, and also had the privilege of training. So we now have 4 transoral robotic surgeons in Adelaide. We were privileged to have Vin Pelleri as our transoral laser microsurgery fellow in 004, and Dean Rusk, who's the transoral laser surgeon in New Zealand. But we've trained a number of surgeons, mainly from the United Kingdom, but also Veronica Van Dyke, who's the only fellowship-trained transoral robotic surgeon in New Zealand, and Vidya Sivakumaran, who is a surgeon in Chennai, South India. We also have had the luxury of Gordon Pickard donating several other robots. So we've actually had 3 systems and generations of robots donated by Gordon Pickard. And we've also had the pleasure of using the flexible MedRobotic system. This system, unfortunately, is no longer being manufactured due to the COVID crisis hitting the industry. But this is the current robot we use. It's called the XI system. And it has proven great use to us because these surgical arms and instruments arms are more slender. They are easier for the nurses to deploy, and it therefore makes for a smooth surgical exercise. And as I said, you've got a surgical cart, a vision cart, which also contains the vision control system as well as the diathermy control system. And you've got the surgeon console, and the operating room setup is such that the patient is aligned with the robot moved and docked into position approximately 15 degrees to the bedside. And there is a robot nurse assistant who, together with the surgeon at the bedside, will position the surgical instruments as well as the telescope. There is an instrument nurse who is separate to the robot assistant nurse. This is where the anesthetist sits. And now we have 2 consoles so we can train surgeons as we operate, or provide the opportunity for 2 surgeons to participate in an operation. The first and important thing is to get, after the robot is docked, is to get access. And almost all cases, we get access using the standard tonsillectomy Boyle-Davis gag. For patients who are edentulous, we use the Dingman mouth gag, which is used by craniofacial surgeons for cleft palate repair. And we protect the lips and get further instrument access by using this photographic transparent cheek retractor. For more difficult areas to access in the supraglottis and in the hypopharynx, one can access these areas by using the old Fay-Kastenbauer retractor. There is a new modification known as the Weinstein-O'Malley Fay-Kastenbauer retractor, or WOFK retractor, made by Olympus. And we've also used the MedRobotics Flex retractor, which is unfortunately, again, no longer in production because of the collapse of the company. The first thing you do once you've got the retractor in place, and here's a Dingman retractor in place, is to ensure that you can put the robotic arm in and get visual access. And we talk about 4 T's, trismus to talk about jaw opening and buck teeth or bad occlusion or a narrow jaw avoiding view, tilt to make sure that there is mobility of the neck and to be able to compensate for anterior larynges. And this is sometimes dictated by things like the circumference of the neck, the thyromental distance and sternomental distance. Sometimes neck mobility is limited because of radiation fibrosis. So all of these factors need to be considered, and is usually done at the time of the examination under anesthesia. The size of the tongue is a big issue, and big tongues and narrow transverse diameter jaws make surgery almost impossible. And at that assessment, one needs to consider what sort of view you get of the tonsils, the lingual tonsils, the epiglottis, and the laryngopharynx. And finally, the tumor is important to identify, determine its size, determine its mobility from adjacent structures, in the oral cavity and oropharynx. So these are the endo-wrist instruments. They are loaded onto the robotic arms, and basically they are variations of laparoscopic instruments. So this is called a Maryland grasper. It's a narrow tipped bipolar diathermy grasper. We prefer this, which is a variation of the Pro grasper, and this is called a bipolar fenestrated grasper. And again, the bipolar energy is very useful. Most of the surgical resection is performed either by diathermy dissection or blunt dissection using the spatulated tip. And if you do need to use a suturing technique, and sometimes we use this to inset local flaps or free flaps, then you use a needle driver. The assistant uses instruments from the standard transoral laser microlaryngoscopy set, the Steiner set. So there is an insulated diathermy grasper, and then there is a range of graspers, some with suction, so you can suction out the plume. And the most important are these vascular clip applicators. This is the transoral laser microscopic clip applicator, and this is from the sphenopalatine artery clipping set from the endophase set. Next, we will address the issue of assessment and evaluation. And of course, this always starts from taking a good history and examination. And most of our work that we apply transoral robotics is for oropharyngeal cancer. And you will all be aware that in the West, in particular, there's been an increasing number of cases of HPV-related P16 positive oropharyngeal cancers. And there's been much written about this. And this is an increasing problem for us. And although we have introduced vaccination programs, and this was done early in Australia because Australia, in fact, developed the tetravalent HPV vaccine for cervical cancer. But despite vaccination programs, it is estimated that it's going to be another 20 to 30 years before the risk of oropharyngeal cancer will fall and respond to vaccination programs. And there's been work done by the late Ki Kian Eng that showed that you can stratify the outcomes of treating HPV-related oropharyngeal cancer with regards to smoking status. So the best outcomes come from P16 positive non-smokers. The next best are P16 positive smokers, and the worst outcome are P16 negative smokers. So associated with this is taking a good history. So things like trismus suggest that medial pterygoid muscle and mesenteric space might be involved, as does referred otalgia. It's important to understand about the fixity of neck nodes, because if you have a contiguous tumor from the oral cavity into the neck, there's a high risk of not being able to perform a good resection or a risk of getting an orocutaneous fistula. Imaging is important, and understanding vascular relations to the tumor, so you can predict the relationship of the tumor and the need to clip these vessels. To understand the extent of disease, understand the relationship of the tumor to the styloglossus and the posterior belly of the digastric and the deep lobe of the submandibular gland, as well as the mandible, and in the neck to understand extracapsular spread in the lymphatics. CT PET scans are done just as a baseline assessment of extent of disease, to assess distant metastases, contralateral disease in contralateral primary sites, as well as contralateral neck nodes. And all patients have an EUA pen endoscopy to assess the tumor access, the ability to mobilize the tumor from neck nodes, and to medialize the tumor from the pterygomandibular raphe so that you can get a compartmental resection of the tumor. You need to coordinate with the anesthetics team. Generally speaking, for tumors that in the lateral oropharyngeal space or in the parapharyngeal space, an oral intubation is suitable, and tumors that extend into the tongue base require nasotracheal intubation. And generally, we follow standard anesthetic guidelines that we have applied and developed for the management of good anesthesia for surgery for sleep apnea and for endoscopic sinus surgery with regulated blood pressure and heart rate. And all patients are discussed at a multidisciplinary clinic, and we have both private and public multidisciplinary clinics, and decisions are recorded and patients are informed of the decisions made by the clinic, and generally treatment is in accordance with decisions made at the clinic. I want to spend some time now talking about surgical anatomy and compartmental resection. This is a wonderful paper produced by Chris Olsinger, but it is a resurrection of an old paper by a Belgian surgeon in the 1950s by the name of Hewitt. And in this paper is a very clear description of the anatomy of the oropharynx from an inside-out perspective. We're all familiar with learning anatomy of the neck and the upper air digestive tract from the outside, but to perform this sort of surgery, it does require refreshing your anatomical knowledge, and I recommend this paper published in the archives in 2005. And there are other good descriptions of this anatomy, and here's another publication from Eric Moore, published in Clinical Anatomy in 2012. And here again, it talks about the relationship of the oropharynx to some vessels and nerves. Particularly important in the tongue base is this dorsal lingual artery, which is quite tortuous, and in tongue base resections can be encountered many a time. And particularly deep tongue base resections, one needs to be very cautious about the lingual artery and its major branches. Another good source is an old book, McGregor and McGregor from 1986. And what I like about this diagram is it stresses the importance of the structures of the lateral oropharynx to the stylopharyngeus and palatopharyngeus and the tonsillar branch of the glossopharyngeal nerve, which one will encounter if you look for this. And deep to this, of course, is the external carotid artery and its branches. The internal carotid artery is usually quite a deep relationship, but the external carotid artery is just deep to styloglossus. And if one looks at the article, Chris Holsinger has shown the old paper and the diagram from the old paper, demonstrating how you develop a plane which is lateral to the constrictors and medial to the contents of the parapharyngeal space. And I think this is the concept of a compartmental resection. So when you're resecting these tumors, you're not just doing a tonsillectomy, you're taking out the tonsil and the constrictors and any associated fat that is adherent to the deep surface of the constrictor. And what you're trying to establish macroscopically with magnification provided by the robot is a clear plane of the parapharyngeal space and its muscles, the medial pterygoid and the styloglossus and stylopharyngeus. And again, there are some wonderful color photographs in the article demonstrating this. And here you can see the medial pterygoid. And in the next video, you can see this transoral robotic resection of an oropharyngeal cancer. So this is a T2 cancer in the left tonsil. And basically the incision starts with an incision along the medial pterygoid, the pterygomandibular raphe. And this is, of course, the point of insertion of the buccinator muscle from anteriorly and posteriorly the superior constrictor. And once this mucosa and muscular layer, which is a thin muscular layer, is identified, then it is a superior extension is carried out to the uvula. And then the lateral plane is identified by identifying the medial pterygoid. This is the easiest structure to identify. It has quite a thick perimysium on it. And this loose connective tissue is the plane by which you can develop a clear compartment of tissue free of cancer. And I think that this is a very important concept to consider this a compartment. We look for margins in the mucosa that are measurable, but the deep margins are dictated by the deep relationships of your tumor excision. And we all know of general principles that if you have tumor, for example, abutting the carotid sheath, you wouldn't take the carotid just to get a margin. You would accept that the carotid sheath was the extent or depth of your dissection. So here you can see progress being made in developing that plane. You can see on the left the spatula dissector, and on the right the bipolar diathermy grasper, creating diathermy the small blood vessels. You can see just here the the tonsillar branch of the glossopharyngeal nerve. And if you see that, then you know that the next structure it sits on is the styloglossus muscle. And that really is the depth of your excision. If we suspect at the time of assessment with a CT scan that tumor is involving the styloglossus muscle, then we will dissect this muscle and dissect it off the external carotid artery and make that our compartmental resection. So here we are going through the posterior part of the palate and now defining the depth of our margin, which is the prevertebral fascia. And once we have delineated the inferior and posterior margins, then the tumor is resected. And here you can see the final mucosal incisions to complete the excision. And you can inspect the deficit and make sure there's no bleeding. And finally, we do a superior constrictor pharyngoplasty to prevent velopharyngeal incompetence. So we use a braided barbed suture known as a 3-0 V-lock suture. So you don't have to throw ties. And we suture the nasal surface of the palate to the edge of the superior constrictor defect. And we close off the ipsilateral nasopharyngeal wall, and this prevents velopharyngeal incompetence. Over a period of time, if there is any nasopharyngeal stenosis symptoms, it appears to disappear. It's important to consider your defect and whether it needs to be reconstructed. And for small defects in the lateral pharynx, lateral oropharynx or posterior oropharynx or in the superior part adjacent to the palate, we would leave them to granulate. And there's a good paper by John Dalmeda and Eric Jenden that reports this. For larger defects, particularly defects that cross the midline in the palate and defects that have exposure of the carotid artery, we look to close it by using local flaps, and our preference is to use a buccinator myomucosal flap, which is well described. For those who are interested, we are putting out an atlas of transoral robotic surgery with videos, and in there is a video of reconstruction using a buccinator myomucosal flap. You can, of course, use free flaps, and we've also inset radial forearm free flaps for these defects. It's very important to evaluate the pathology. So once we take out the tumor, we then take margins from the patient, from the resection bed, and that includes both mucosal margins, and if necessary, we will take out styloglossus as a deep margin. And of course, we take the specimen down to our pathologist and discuss how these edges must be unfurled to accurately measure the true margins of resection. Postoperative care is very important and starts from the time of surgery, and most important is the concern for hemostasis. We, as you saw, put Liga clips to clip these blood vessels, and sometimes people look at it and think there's a titanium necklace of clips, but we are very concerned with hemostasis. We also supplement this by using vessel sealing substitutes, including Flow-Seal and Surgiflow or Purostat. We also give patients systemic coverage for hemostasis with tranexamic acid. We've also written our experience with selective arterial ligation, and we ligate the lingual artery, facial artery, and ascending pharyngeal artery in the neck. Other things that may go wrong is a pharyngocutaneous fistula, and more often than not, if you have a lesion involving the tongue base, you will get a defect in communication with the neck, and we use an anterior belly of digastric flap and rotate it to cover this defect and put some Surgiflow or TIS-Seal to create a seal. And finally, as I described, we are concerned for velopharyngeal incompetence, and we perform a posterior pharyngeal wall closure with a V-lock suture. And our main issues with post-op care is, of course, airway management, when we start oral intake, how long we give antibiotics, and our concern of for bleeding and how we can prevent thromboembolism. Be aware, particularly if you are treating patients who are frail, patients who have previous chemotherapy, radiotherapy, or surgery, and be very aware of patients with large defects or defects where the vessel is exposed or where you suspect fistula. In those patients, we have a delayed recovery from surgery and we may not start oral intake for 7 days. But otherwise, most patients will have that, will be extubated on the table. They spend 24 hours in intensive care. We give them dexamethasone. We start off with tranexamic acid for prevention of bleeding. They don't generally start food or fluid intake until day 3, and they usually start oral intake by day 5 and are usually home by day 7. We give antibiotics for a total of 2 weeks, IV for 3 days, and then oral antibiotics for a further 10 days. And similarly, we prevent thromboembolism by using what we call scuds, which are these stockings with devices that create a compression of the calf muscles, and patients go home with advice to use compression stockings for 6 weeks. We put them on tranexamic acid for 10 days. Patients are educated about being warned about bleeding management, and we encourage patients to spend 2 weeks within close range of the Royal Adelaide Hospital and spend about and give them talks about prevention and being worried about sentinel bleeds. And we regularly follow up these patients. We have a TORS clinic every Monday, and we see these patients 1 or 2 weekly until the site has healed. So just to give you some examples of other procedures, this is a patient who had his 3rd cancer. This is a supraglottic cancer. You can see he's had a previous oropharyngectomy. This is his radial forearm free flap here on the left. He's also had a laryngeal cancer radiated and a floor of mouth cancer excised. And so this is the resection we're going to perform, take out his supraglottic larynx. And we begin by making inferior incisions. I think you saw a very good video about transoral laser supraglottic laryngectomy by Prathamesh Pai earlier on this morning. So this is how we do a robotic incision. We go inferiorly right through the aryepiglottic fold, right down against the thyroid cartilage. As you all know, the larynx has anteriorly abuts the thyroid cartilage. We carry out this incision in a horseshoe-shaped fashion to the anterior commissure and then come to the contralateral aryepiglottic fold. And once we've done this inferior incision, then we are quite comfortable to then move on to do the lateral and superior incisions. So this way the specimen doesn't fall on you whilst you're operating. You've done all your inferior incisions as best you can. And now we progress to the lateral incision. So we're making an incision into the vallecula. And you can see the radiation damage and how fibrous these tissues are. And this is done under magnification and done layer by layer. And one must be aware of the vessels deep to this. I think Prathamesh again talked about it this morning. There is a branch from the lingual artery high up here and a branch from the superior thyroid artery lower down here. And here you can see the anterior incision being made, anterior to the tumor and heading towards the hyoid bone. And here you will see that during the dissection, a vessel has been identified and you will see the vessel being clipped. So here you can see the vessel being identified, and now you'll see a clip being applied to control bleeding. And as much as possible, if we identify blood vessels, we apply clips. So this vessel is probably only perhaps a 2 millimeter vessel. And here you can see the silver glistening that occurs when you hit the hyoid with heat energy, whether you use laser or diathermy. And although you don't get haptic feedback, you get a visual sense of haptic feedback that you are rocking a firm structure whilst you're operating. And with release of the tongue muscles, the hyoid collapses down to the thyroid cartilage. And so if you dissect on the periosteum of the hyoid bone, you will then come to the perichondrium of the thyroid cartilage, and that becomes the depth of your excision. And you then continue that and join it up with your previous incision along the area epiglottic fold. Then this then creates a continuous plane, this dissection towards the anterior commissure. And we are now completing the excision. And here you can see the tumor being removed. And at the base, you can see the vocal cords, the subglottic larynx, and the bed, which is the perichondrium of the thyroid cartilage. So another example is parapharyngeal space tumor excision, and here is an example of a excision of a 6 centimeter parapharyngeal space pleomorphic adenoma, and this has a clear plane of dissection. It extends up to the skull base, and the problem when you do these transcervically is that the top of the dissection is usually done by blunt finger dissection. And here you can see the beginning of the surgery. We're making an incision along the mucosa and raising the flap. The incision, as usual, is along this pterygomandibular raphe, the junction of the buccinator muscle anteriorly and the constrictor posteriorly. And we are elevating a flap which is deep to the mucosa and the superior constrictor. And once this lateral incision is made, we make a superior incision, and then we try and develop a flap between the tumor and the muscle. It's very important when you're doing parapharyngeal space tumors transorally to understand the tumor itself, understand that some 20% of tumors are cystic and have thin walls, and that there's a risk of perforating the cyst wall and having extravasation of tumor. Now, with robotics, because of the good magnified view that you get, even if you do have spillage, you can feel quite comfortable and confident that you can irrigate and suction out any tumor remnants. But generally speaking, if we do have a leakage, we tend to either seal the linkage with a suture or suck out as much of the contents of the cystic part of the tumor, and then continue removing the tumor, which is decompressed. So here you can see that the tumor is now being freed from its lateral components, and you can see that there's often some compressed fat, or you will see actually the deep lobe of the parotid gland. And because of the magnified view, you can quite safely dissect these tumors out. We actually have published a case of a deep lobe parotid tumor in a 15-year-old boy that we resected, where we did a combined approach. We did an external approach, identified the facial nerve externally, placed a piece of green plastic under the facial nerve main trunk, and then completed the resection transorally. So that meant that the child had almost no scar on the skin and had a safe removal of the tumor. So here you can see the posterior dissection now. And what you can see laterally here are the vessels of the parapharyngeal space. And these two-dimensional projected views don't give you the sort of confidence that we can get when we use the console, where we get a three-dimensional view and you get a very good depth perception, which was something we missed when we were doing transoral laser microsurgery. And here we can see removal of the final margins of this tumor, and now the inferior aspect of this tumor, and removal of this tumor. And as I said, what this gave us was great confidence in removing the superior aspect of these parapharyngeal space tumors, which usually, if we approached it transcervically or transcervically and transparotid, we would do the top end bluntly with a blunt finger. Here again is an example of vessel control with the clip applicators and the removal of the tumor. So finally, to address some controversies. So one of the controversies we have with managing P16 positive HPV-related carcinomas in the head neck is the carcinoma unknown primary. So patients who present with a node in the neck, which is P16 positive SCC, but no primary found on clinical examination or PET examination. And the dilemma is, how do we find the primary site? And here you can see the flex robot being used to perform a tonsillectomy. So this is not an oropharyngectomy. You can see how we're leaving the constrictor muscle behind and just taking the tonsil out. And we are doing a mucosectomy, just taking out the mucosa of the tonsillolingual sulcus and the vallecula. And our general approach that we've described and published is to perform this in search of an unknown primary. And we have found that in about 80% of cases, an unknown primary can be identified in the specimen. And in almost all of those cases, that the specimen is, that the primary is small and completely excised with resection. So our preference now is to perform this operation when we have patients who present with an unknown primary. So we perform an ipsilateral tonsillectomy and either an ipsilateral or bilateral tongue-based mucosectomy, and we do a staged contralateral tonsillectomy to prevent the risk, the possible risk of cicatrization. One of the other controversies is the issue of de-escalation or de-intensification, and there are a number of trials discussing this. And I think it's important to understand the importance of undertaking trials and trying to scientifically and objectively analyze one's results. And there was a great paper on this issue, which was discussing the issues of medical experimentation, published by Charles Fried, who was the Attorney General for Ronald Reagan. And he brought about this concept of equipoise, the state of uncertainty or lack of grounded preference concerning which of two treatments is preferable. And if this occurs, then really one needs to develop scientific bases to differentiate between the two. And really, this was based on some bad trials, bad research performed, and classically quoted is Chester Southern's work in the Jewish Chronic Disease Hospital, where he'd experimented on various chemotherapy agents and other agents without consent. Some of these patients actually suffered and died. And more infamously, the Tuskegee syphilis study, which was conducted by the United States Health Department, which conducted a trial on some 900 black crop share workers and who had, and they studied syphilis. And although by the 1940s there was treatment with for syphilis with penicillin, none of these black sharecroppers were given treatment for syphilis until a whistleblower reported the cruelty of this experiment, and several patients died, including spouses and even children of this group of observed black sharecroppers. But it's also important to understand that when one is trying to study in a double-blind fashion surgical technology, that this is difficult. And sometimes we are confounded by people who are trying to find policy-based evidence rather than evidence-based policy. And one must be mindful of the fact that despite great efforts, that there is still some opportunity to bias either in the process of undertaking a study or interpreting the study. And I think that it is important to understand that even if we do have evidence-based studies that tell us to perform particular treatments, that we need to tailor an individualized treatment. As the great Ashok Shah says, the punishment must fit the crime. And I quote Martha Solomon, who says that if you have an allegiance to objectivity and detachment, and this blinds us to other values, it produces neither humane behavior nor sound science. And I want to discuss now 4 studies on de-escalation, and we were fortunate enough to participate in Orator 1 and Orator 2, although we did have some concerns with the way the results were interpreted. For those not familiar, Orator 1 was an open-label phase 2 trial comparing radiotherapy and transoral robotic surgery for early oropharyngeal cancer. And unfortunately, the wording in the abstract is often thrown back, so that if you have medical oncologists or radiation oncologists who quote Orator 1 and say, patients treated with radiotherapy showed superior swallowing-related quality of life outcomes, I think it's important to understand this study a little bit in greater detail. And it requires going beyond the abstract and looking at the data. And these were 68 patients that were recruited and randomized. And if you look at the 34 patients who were allocated to the robotic surgery neck dissection group, it's important to understand that only 10 of that 34 had TORS and neck dissection alone. 24 of the 34 had adjuvant treatment, and 8 of the 34 had chemotherapy as well as radiotherapy. It's also important to understand that both groups had significant smoking populations. And I think these are factors that do influence swallowing outcomes. I think the good things that came out of the paper are the demonstration that in both the radiotherapy and TORS group, that the overall survival and the progression-free survival was almost identical. And again, the power of the P16 status, with P16 negative patients having bad prognosis compared to P16 positive patients in both groups. The other issue that's often quoted is the MDADI, the MD Anderson Dysphagia Inventory Scores. And if you look at all the various realms that are tested, I think just looking at these graphs, you can see that there wasn't great variation. And in fact, if you look at the scores, there was a less than 10-point difference between the two groups. And I think it's important to understand that if you look at the MD Anderson Dysphagia Inventory, it's a 20-year-old inventory looking at swallowing. And if you look at how this was validated, it was with 100 patients, 64 of whom were laryngeal patients, and only 8 oropharynx. So I think there's time for us to develop a new oropharyngeal dysphagia index to understand better the effects of surgery or radiotherapy or chemotherapy for oropharyngeal cancer. And I'll just be quick with this. As I said, if you look at MDADI, it really is useful if you're studying one patient and monitoring how one patient is improving over a period of time. And from this study, if you're trying to compare different groups, then you're looking for a 10% difference. And if you look at Kate Hutchinson's work, then you're looking for at least a 10-point difference between groups. And a 10-point difference between groups may give you a difference between those who are aspirating, those who can't swallow, and those who are dependent on enteric feeds. And if you look at the results from Orator compared to all those described by Kate Hutchinson, there really is no 10-point difference between the two groups. And over a period of time, it looks like the two groups are coming together. So that statement in the abstract that the swallowing results are superior in the radiotherapy group, I think has to be taken with a pinch of salt. And when you debate these patients in a multidisciplinary clinic, I think individualize your treatment, know your own, audit your own results, and argue in favor of what's best for your patients. I want to speak a little bit about the ECOG 3311 or ACRIN 3311 trial, which is a trial looking at patients who've undergone transoral robotic surgery and then divided into 4 groups. So these are patients who are HPV positive and have relatively early stage tumor and are divided into a low risk group. So these are T1, T2 tumors and N1 tumors. And these patients who are low risk just get observed and don't get any adjuvant treatment. In the intermediate group, where there are clear closed margins and with up to 4 metastatic nodes with perineural invasion and lymphovascular invasions, They're randomized into a group that gets low-dose radiotherapy and a group that gets high-dose radiotherapy of 60 gray. And finally, a high-risk patient where after transoral robotic resections, there's positive margins and more than 5 metastatic lymph nodes, and these patients go straight to have a combination of high-dose radiation and cisplatin at 40 milligrams per square meter weekly for 6 weeks. And these, they were wanting to accrue 377 patients. They in fact accrued 500 patients. 353 were eligible for the study. And the thing about this study is that they credentialed their 82 surgeons performed these 500 cases. They met regularly weekly to discuss margins, surgical techniques, and reviewed videos of resections. So they had a high degree of supervision of the surgical technique and the surgical resection for these patients. And what this showed was that TORS for P16 positive oropharyngeal cancer is safe and gives you good oncological outcomes. The 2-year progression-free survivals for all groups was better than 90%. The rate of distant recurrences, as might be expected, was worse with the advanced tumors that required chemoradiation. And what they said was this was a promising de-intensification approach for early oropharyngeal cancers. And a phase 3 trial was recommended. Now, some of you may meet colleagues who will discuss Orator 2. So this was the second trial out of Canada that, again, we were part of, and again, had quite a lot of to and fro regarding how we assess this study. So this was a trial randomizing early oropharyngeal cancer into a radiotherapy and chemotherapy arm and into a transoral surgery and adjuvant surgery on a risk factor basis. And the idea was to compare overall survival and to see if a de-intensified radiotherapy program was going to change survival. Now, this study was terminated because there were 2 deaths in the surgery arm. One was a patient who died after bleeding on day 4, and one who had a patient who had cervical discitis 1 month after radiation. Now, there was, as I said, quite a lot of discussion about how this was to be interpreted, and I draw your attention to how I think I interpret this. There have been studies as far as bleeding is concerned. The ones I like are one that comes out of Uma Maheshwar Duvuri's paper, together with Robert Ferris, looking at 224 consecutive resections in one institution, showing about a 9% bleed rate, none of whom were fatal. And then this paper published in 2020 by a group with Chris Holsinger, looking at a meta-analysis of several studies, some 5,748 TORS resection, showing about a 5% bleed rate, of whom 2% just required observation and 3% required going to theater, and a death rate of 0.17%. So I still believe that TORS is a safe surgical procedure from a bleeding point of view. As far as cervical discitis and spondylodiscitis is concerned, when I looked at the literature, there was the biggest series was 7 cases from the GETEC, the French study, and they looked at 1,084 cases and found 7 posterior pharyngeal wall cancers who developed spondylodiscitis, and 3 of those 7 had radiotherapy. So again, I think it is a risk that for cancers that involve the posterior hypopharyngeal wall. Most of our work is really lateral oropharyngeal wall or tongue-based, and there'd be only a very small number that would be subjected to this risk. But also recognize that this risk has been documented in open surgery by papers and also documented in chemoradiation. So again, I feel that transoral robotic surgery for lateral oropharyngeal wall tongue-based cancers is still a safe surgical option. We all, of course, are looking forward to this study, which is going to be about a 1,000-case study, a phase 3 trial coming out of the United Kingdom, led by Meredith Evans and Terry Jones, called the PATHOS trial. And here basically are 5 groups of patients, all patients undergoing TORS for P16 positive tumor. And if they have no pathological risk factors, no adjuvant treatment, if they have closed margins, then they're randomized to either 60 gray or 50 gray. And if they have positive margins, they're randomized to 60 gray and 60 gray with chemotherapy. So this will be exciting work when it eventually gets published. So in conclusion, thank you again for your patience, but I do think that transoral minimally invasive surgery, whether it's transoral laser microsurgery, transoral endoscopic video-assisted surgery, or transoral robotic surgery is an inevitable progress, particularly in the treatment of oropharyngeal cancer. It reduces the surgical and treatment morbidity and toxicity. This particular group of patients are young people who want to go back to work and go back to the families and enjoy their meals with the families. So we need to make sure that these patients have the lowest possible morbidity. The surgical procedure has better visual access. You can go around corners. You can have new instruments which follow the leader. You can have instrumentation for assistants at the table. There are better, finer instruments, and smart instruments are being developed. Instruments with haptics, image guidance, fluorescence to mark tumor margins and sentinel nodes, ultrasound probes, stapling devices, and electrosurgical devices, both for resection as well as hemostasis. There are some controversies, but I think that these controversies lend themselves to a surgical solution, and I encourage you all to participate in clinical trials and audit your work. Thank you very much again for your invitation. And Ravi, I hope that some of the audience is still awake, and I'm happy to take questions.
Thank you very much, Professor Suren Krishnan. So it's open for questions now.
Professor Krishnan, thank you very much for your elaborative presentation. I think we have to read a lot about it because it's so new to us. But I think the most benefit is the parapharyngeal tumors where we can remove them transorally. I think if audience has any questions, you can direct to Professor Krishnan.
Good afternoon, Professor Krishnan. I'm Bimanta Pereira speaking. This is probably a basic question, but when you do transoral surgery and you fall into trouble, basically you hit a major blood vessel, as you said, what is your approach? Do you convert it into an open surgery, or do you have any armamentarium to control it?
A very good question. I think you must be prepared. And so the first thing is, as I said, look at your CT scans before surgery and understand the relationship of your tumor to the deep vessels. More often than not, if you look for it, you will be able to identify branches of the lingual artery and branches from the ascending pharyngeal artery very close to your tumor. So one thing is to be prepared. The second thing is that the important thing is to control the bleeding, and so if it means you have to open your neck and get into the external carotid artery and its branches, that you be prepared to do so. In nearly 400 cases, we've only had to open the neck once, so it's not very common. Realize that if you're using a transoral technique, whether you use a telescope or a robot or a microscope, that you are working under magnification, so the bleeding always looks worse than it actually is. And the basic principles of control, so tamponade, get 2 suckers, have a good assistant, and use the standard techniques. Don't go grabbing without identifying where the bleeding is occurring. It is very rare to hit, say, the carotid artery unless you are actually dissecting the styloglossus of the carotid artery. So if you perform your surgery in a systematic, anatomical, compartmental technique, identify the medial pterygoid, and then at the bottom of the oral cavity, the oropharyngeal defect, identify the styloglossus. It is almost impossible to hit the external carotid artery. But it is very possible to hit branches of the lingual artery and branches of the ascending pharyngeal artery. And as I said, if you have two suckers and a good assistant and good vision, you can control it transorally. We have only once opened the neck in panic, and again, it was just a matter of putting a clip on the lingual artery because it was a branch of the lingual artery. I hope that was helpful, Bimanta.
Thank you. Thank you very much.
Are there any more questions from the audience? So it looks like we don't have any more questions. Thank you very much, Professor Suren Krishnan. We're looking forward to see you sometime in the future. Thank you very much.
Thank you, Ravi. Thank you very, Ravi, and thank you again for inviting me.
Welcome. You're welcome. We'll move on to the next session.
Thank you very much, Dr. Chandra Jayasuri and Dr. Ravindra Kirihen, for sharing that wonderful informative session. So ladies and gentlemen, let's wind up the third session and let's move on to the fourth session. The fourth session is free paper presentation session. So the session will be chaired by consultant ENT surgeons Dr. S.D. Indika and Dr. Akram Brahman. Shall I invite Dr. S.D. Indika and Dr. Akram Brahman to take their places at the head table. The judges for the session are consultant ENT surgeons, Professor Ramnadeep Work, Dr. Amal Priyantha, Dr. Ranjit Jayavira. Amal Fernando and Dr. Ranjit Jayavira. I would like to remind the presenters that each paper presentation will have 8 minutes for presentation and 2 minutes for the discussion. The first bell will be rung at 5 minutes, the second bell will be rung at 7 minutes, and the third bell, which is a double bell, will be rung at 8 minutes. I shall repeat that. The first bell will be rung at 5 minutes, the second bell will be rung at 7 minutes, and the third bell, which is a double bell, will be rung at 8 minutes. Points will be deducted for presentations exceeding the time allocation, and the best paper will be selected by the panel of judges and awarded the Dr. S.K.P. Harishchandra Memorial Award for the best scientific paper. So, over to you, sir, to conduct the session.
Thank you. Further to elaborate, instead of bells, we have decided to go for a bulb lighting system. So the first 2 bells will be indicated by a yellow light, and the final bell, when your time's up, will be indicated by a red light. So let's have the first oral presentation. Effectiveness of olfactory training and topical corticosteroids for treatment of post-COVID-19 anosmia and hyposmia, a pilot study. The presenter is Dialvis ASR. You may begin. No, sorry. We'll restart.
Effectiveness of olfactory training and topical corticosteroids for treatment of post-COVID-19 anosmia and hyposmia. So more than 434 million of people up to date are infected with COVID-19 virus. And the key symptoms are the cough, shortness of breathing, fever, chills and rigors, muscle pain, sore throat, and also the new loss of smell and taste. Luckily, the majority of these people will improve spontaneously. Hence, no treatment will be needed. But if impairment persists beyond more than 2 weeks, it is reasonable for some sort of treatment to be started. But the efficacy of these treatments for COVID-19 people are not, actually the efficacy of the available treatments are not yet validated, and although the treatments targeting the post-infectious viral infections may be potentially helpful for the COVID-19 patients as well. So according to the ENT UK guidelines on management of new onset anosmia in COVID pandemic, it is recommended to start either olfactory training or nasal corticosteroids if the symptoms are persisting beyond more than 2 weeks.
We can see your slides.
I also can't see.
Time is paused.
Okay. So this olfactory training involves repeated and deliberate sniffing of a set of odors which is commonly known as lemon, rose, cloves and eucalyptus for 20 seconds, each at least twice a day for at least 3 months. Okay, I would like to recap again because the slides were not there. So according to the ENT UK guidelines, if the anosmia or hyposmia persists beyond more than 2 weeks, we can go on starting either corticosteroids, that is nasal sprays or nasal drops, or we can start on olfactory training. So this is what I described earlier. And this therapy has low cost and negligible adverse effects for its credits. In Sri Lankan context, the incidence of anosmia and hyposmia is around 28.9%, mostly common with the other world because it is around 35 to 65% in the worldwide. And 0.13% had a persisting olfactory dysfunction after about 1 month, which was measured subjectively. But there is no published data on treatment of olfactory dysfunction. So our objective is to assess the effectiveness of olfactory training and topical corticosteroids in the treatment of post-COVID-19 anosmia, and also to assess the recovery rate and response of treatment methods tested with regard to the duration and recovery. So this was a pilot study which was carried out as a prospective randomized control trial conducted at Colombo South Teaching Hospital from 15th of August 2021 up to now, but we have analyzed the data until the 1st of January 2022. And the ethical clearance was taken by the Ethical Review Committee at the Colombo South Teaching Hospital. So all the patients with a history of COVID-19 infection and an olfactory disturbance following COVID-19 infection for more than 1 month were included into our study, that is allowing for the natural recovery to take place. And those who had any presence of olfactory disturbance prior to COVID-19 infection or any other nasal symptoms like nasal discharge, epistaxis, nasal obstruction, postnasal discharge or facial pain were excluded. And also those who have any other rhinological diseases. It can be benign or malignant nasal tumors, nasal polyposis, allergic rhinitis or any other neurological impairment or any other non-nasal pathology were all excluded, and any history of allergy as well. So this, we analyzed 49 patients. I would like to say there were 60 patients. We actually randomized into 4 groups in equal numbers, but some people got lost in follow-up. So 49 were analyzed in the end. So we have analyzed into 4 groups: olfactory training only, pro-beta, olfactory training and probita, and the control group, which was actually taken from those who didn't come for the follow-up. So we have inquired them whether they had anosmia or hyposmia following the COVID-19 infection, but they didn't, even though they had anosmia, they didn't come for the clinic visit until 3 months. And we got down these patients in the end, and we did the smell test, and then after that, who had persistent anosmia, we make sure that they are in the treatment groups. So the study instrument is according to the is an interview-based questionnaire, and also according to the ENT UK guidelines. It consists of demographic data, pre-olfactory status, impact on quality of life, and therapeutic outcomes. So smell assessment is carried out by the QSIT sense smell test for chocolate, banana, and smoke. So let's move on to results. We have compared the control group, that is the group that did not turn up for any treatment, with the other groups, and we found that there is significant improvement at the end of 1 month with a p-value of less than 0.5. And then we compared the smell scores after 1 month between the group 1, that is the olfactory training only group, and the group 2, which we instilled the probita only. So there was a statistical significance of smell scores between these two groups as well. Then what we did is that we compared the group with olfactory training, and which combined the probita as well. But there was no statistical significance between these two groups. And the recovery rate, which was to achieve the 3 out of 3 out of all these QSIT smell scores, also showed there was no statistical significance between those who had olfactory training and combination as well. And overall satisfaction was improved by 100% for those who achieved the score of 3 following the QSIT smell test. And we did not see any side effects, and around 784 rupees was the cost for a person, and probita nasal drops is 178. So our conclusions are that olfactory training and nasal corticosteroids are beneficial in treating post-COVID-19 anosmia, and there is a significant improvement on smell scores with regard to olfactory training. But the use of tropical nasal steroids offers no superior limit over the olfactory training regarding to the smell scores. So our limitations is, as I mentioned earlier, that randomization was done for 16 patients, but few got lost to follow-up. And it was difficult to perform this QSIT smell test during the COVID infection due to the infectious control methods. So the presence and absence of the olfactory disturbance was taken by telephone conversation and is subjective for the patient, and also unavailability of the QSITs in Sri Lanka. So we recommend the anosmia olfactory training for the following COVID-19 infection. Thank you.
The paper is now open to the floor for questions.
How did you introduce eucalyptus? Eucalyptus?
This is according to the ENT UK guidelines, madam.
So how did you, our patients, what is the eucalyptus you introduce?
We got the essential oils from internet, from online. So lemon, eucalyptus, rose, and citrus. Citrus. Yeah. All these 4 oils were taken through the via online, and we gave each 2 to 3 ml of each essential oil to these patients to take home, and we are reviewing after 1 month.
The smell before you lost this thing. Do you think you need anything and an alternative thing for the eucalyptus? I don't think I am familiar with eucalyptus smell.
Yes, sir, we neither. Not familiar, but we went according to the guidelines because actually there is no other validated guideline which is available for olfactory training. So maybe we can, because this is an ongoing study, so we can introduce something more relevant to Sri Lanka and we can validate it, sir. Hopefully, to see it. Exactly, sir. Thank you.
Okay, unfortunately the time is up. Thank you. And we will start the next presentation.
Next oral presentation is validation of whispered voice test as an accurate tool to screen hearing impairment among adults in Sri Lanka, a pilot study among healthcare assistants in National Hospital of Sri Lanka. Presenter Kumar AAS. You can start now.
Slideshow. Validation of whispered voice test as an accurate tool to screen hearing impairment among adults in Sri Lanka. This is a pilot study done among the healthcare assistants in National Hospital of Sri Lanka. So hearing impairment is a very common worldwide problem. It affects all age groups and it leads to marked disability and handicap. And according to the WHO 2021 publications, over 5% of the world population require rehabilitation to address their disabling hearing loss. It means 432 million adults. And the definition of hearing impairment is a person who is not able to hear as a normal person or otherwise hearing threshold greater than 20 decibel in both ears. And disabling hearing impairment refers as hearing loss greater than 4 decibel in better ear in adults. So unfortunately, the majority of people with disabling hearing impairment live in developing countries like Sri Lanka. So hearing problems that are ignored or untreated can get worse, and they have problems such as difficult to attend their occupation, then economic problems, and they may dementia and depression, social withdrawal, and poor social interaction. So early identification and prompt intervention is helpful to improve their quality of life. So to detect hearing impairment, the whispered voice test is a simple test and it can be used in primary care settings. The sensitivity is calculated as 90 to 100% and specificity is 70 to 87%. All the studies about whispered voice test have done in other countries. Sri Lanka is lacking such study. So our aim was to validate the whispered voice test as a screen tool and introduce international guidelines to detect hearing impairment among adults. So our objective was to validate whispered voice test to detect hearing impairment among healthcare assistants in National Hospital of Sri Lanka as a pilot study. We used a cross-sectional descriptive study and it carried out in the National Hospital of Sri Lanka, Colombo, among healthcare assistants from 1st of July 2020 to 31st of October 2021. We plan to take all the healthcare assistants employed at NHSL in above duration. And those who wish to refrain from the participation were excluded. And to carry out the study, we made a video in all 3 languages, Sinhala, English, and Tamil, and it distributed among healthcare assistants via WhatsApp and uploaded to the YouTube. And one of healthcare assistant from each unit was taken to the ENT auditorium and trained to perform the whispered voice test. Those videos are available in the YouTube. The links are shown as in the presentation. And the one who carried out the test fill this form, and it includes the age, sex, and whether the score of the whispered test in right and left ear from the 6. So we used the consonants with the S sound, which is from 21 to 59, and at least the participant can answer for 3 out of 6 took as pass, others 1 or 2 got as failed. Then test positive participants were tested with the audiometry to confirm the hearing impairment. We could take 1,478 participants for the study. It means 2,956 years. Among them, majority were female with 980, and rest of were male. It's 498. The majority were between the 40 to 50 years of 802 with a percentage of 44, and 322 between 30 to 40, and 287 between 50 to 60, and there were 67 between 20 to 30 years. 37 participants were test positive with the audiometry, with the 47 years affected. So there were 10 participants where they have both ears were with hearing impairment. The prevalence was 1.58 in our study population. Among 37, there were 19 participants were male and 18 were female. The majority of hearing impaired was between the 50 to 60 years, and it was 17. 12 were between 40 to 50 years, and 6 were between 30 to 40 years, and there were 2 between 20 to 30 years. So audiometry was positive for 42 years out of 47 years with sensitivity of 89.36, which is similar to other studies in the carried out in rest of the world. 5 years had normal hearing thresholds with a false positive rate of 10.64. In our study, the limitation, although we could take 1,478 participants, it is not ideally represent the Sri Lankan population. And we use inexperienced examiners, and their whispering may be too quiet or too loud. And there was a problem in reproducibility and reliability. It is always there, and test was not standardized. Other limitation was participants who passed the test ideally should be tested with audiometry to confirm the specificity, but in our setup, it is difficult to carry out with limited resources available. The conclusion is whispered voice test is a simple and accurate test for detecting hearing impairment with high sensitivity. Although whispered voice test can be used for screening of hearing impairment, it is not adequately evaluated with sensitivity, specificity, and the ability of utilization at primary care settings in Sri Lanka. So our future researches, with collaboration of the community physicians, will be conducted with purpose of validating the whispered voice test, and for the purpose of introduction of whispered voice test in national health guidelines, encouraging MOH officers, where medical officer of health and public health inspectors and general practitioners to screen adults for hearing impairment and do the proper referral to the ENT surgeon. These are my references. Thank you.
Now the paper is open for discussion.
Yeah, we took the healthcare assistants resting room as the testing place, but there may be sounds. So there's a problem with standardization, sir.
Now, any specific reasons now that this whispered voice test is a sort of a universally accepted form of testing, to do it in Sri Lanka again?
In the abroad also, sir, it is still going, researchers going to test the ability of using it primary care settings even in the UK with the problems they are having. So in Sri Lanka, there's no such way, because even pap smear like things was introduced to MOH and now they are doing it. So we want to test it, the ability of doing it at the primary care settings at GP level and MOH level. So that's the purpose.
The fingers and compare the 2 years, then you will find there's a hearing impairment. So how do you...
Sorry, sir.
Yeah, can you hear me?
Yes, sir.
Yeah, now you said you did the whispered test, but sometimes the whispered test can be at 2 feet, can be heard.
Yes, sir.
But hearing may be impaired, may not be detected by the whispered hearing test.
Yes, sir. It's in 2 feet. If it's not heard,
if it is heard, can
yeah.
you say they are normal?
Thank you, and time is up for you.
Thank you.
We will now have the next presenter. The next paper is on audit on the safety and effectiveness of the use of KTP laser in staphylectomy, 1 year experience in an ENT center at a tertiary care hospital in Sri Lanka. The presenter is Telikolara SM.
Good afternoon. I'm Sulakshi Telikoorala, a second-year registrar, presenting an audit over 1 year in an otolaryngology center at Teaching Hospital Anuradhapura on the safety and effectiveness of the use of KTP laser in staphylotomy. Otosclerosis is a localized disease of bone metabolism in the otic capsule, where the stapes footplate is fixed to the oval window, and it will cause conductive hearing impairment. Stapes surgery is performed, hence, for clinical diagnosis, which is a gold standard, and improve the conducting hearing impairment. Staphylotomy is a mode of stapes surgery, and today we discussed that it's moved from manual to non-manual with a skeeter drill, and now today to laser. So in the current setup, laser is used as a no-touch technique instead of the manual for the division of stapedius tendon, for the crookotomy and footplate perforation. And different types of lasers could be used, which we discussed today as carbon dioxide laser, KTP laser. And laser is recognized, or in literature, it's reported as it has better hearing less profile of complications such as sensorineural hearing impairment and vertigo, as well as better hearing. So the objectives which we have assessed are the effectiveness and the safety of KTP laser in staphylotomy in patients who are surgically confirmed with otosclerosis at the Teaching Hospital Anuradhapura. Background for this was that laser staphylotomy was introduced to Teaching Hospital Anuradhapura in late 2020. This was during COVID, and at that point, from that October 2020 to September 2021, we decided to audit on the patients who underwent laser staphylotomy with KTP laser, as currently there is no available data on laser staphylotomy for Sri Lanka, and we could use these data to offer laser staphylotomy to our patients by showing our own statistics. So the study design was a retrospective descriptive study conducted from October 2020 to September 2021 at the ENT unit, Teaching Hospital Anuradhapura, where our sample size was actually 8 patients with surgically confirmed otosclerosis. So looking at the inclusion criteria and exclusion criteria, I think I can explain why it was 8 patients, because in the inclusion criteria, we decided to select, we have actually decided to go ahead with KTP laser for primary stapes surgery only. The revision surgery was done manually, and one patient we had to convert from laser to open surgery. And during the COVID pandemic, as well as patients' compliance, some patients did not come for further evaluation for post-operative PTA. So we got informed consent from the patients for the audit, and our methodology was once we diagnosed the patients with autosclerosis from the clinical history, otoscopic findings, impedance audiometry, and pure tone audiometry results, we offered them laser surgery and took consent and proceeded with the surgery. So just recapping some points of the surgery itself, all the surgery was done under general anesthesia by the same consultant. Standard technique was used, either endural or permeatal approach was used, and the settings that we've used are on the right-hand side. For the stay-piece, these are the powers and the type of pulse which we use. We use several single pulses for all three procedures, and we did manual crimping. No self-crimping was done since we did not have thermal pistons. So the stapetotomy was done, making a rosette in the several pulses, subsequently using a perforator, and for manual perforation as well aided. And we used two piston sides, 0.6 to 0.4 millimeters, depending on the patient. 6 patients at 0.6 and 2 patients at 0.4 millimeters diameter. So coming back to our study, the study tool was a paper-based operator field questionnaire where the preoperative pure tone audiometry and tympanogram was performed before surgery. Intraoperative details were obtained from the medical records. Post-operatively, patients were reviewed in the clinic to assess complications, and after 3 months, we got a pure tone audiometry done post-operatively. All the audiograms were performed by the senior audiologist and the same person. So we had different set of variables, clinical variables as well as audiometric variables. The clinical variables were the intraoperative data, which we have included here, as well as intraoperative complications such as caudate tympani injury, facial nerve injury, dislocation of the incus, dislocation of stapes foot plate, perilymphatic fistula, and post-operative data, post-operative complications such as vertigo, chronic ear infection, dizziness, tinnitus, or facial nerve palsy. So the audiological variables we analyzed were at 500 kilohertz, 500 hertz, 1 kilohertz, 2 kilohertz, and 4 kilohertz. So the preoperative PTA, the air conduction and the bone conduction were compared with the post-operative PTA, air conduction and the bone conduction, which was done 3 months later. So we were actually getting our guidance from American College of Otorhinolaryngology, Head and Neck Surgery Committee on Hearing and Equilibrium, who have actually have given recommendation on how to assess the safety and effectiveness of stapes surgery. So the analysis was done on SPSS, where we used the preoperative and postoperative air conduction, bone conduction, as well as calculated the results, which I will discuss. And the paired t-test was used to compare the means, where the p-value we used of less than 0.05 for statistical significance. So I'm coming back to the results now. The age distribution was, we had patients from 33 years to 72 years, and most were females, accounting to 62%, and there was 37.5% of males. So 6 patients had surgery in the left ear and 2 patients had surgery in the right ear. So coming to the results, the aim of the surgery was actually to reduce the airborne conduction or to treat the conductive hearing loss. So in all patients at all 4 frequencies, the patients had airborne gap reduction. And the AB gap closure was found from ranging from 0 to everybody had reduction, and it went, some had bigger air gap reduction as well. And then we assessed the mean 4-frequency preoperative and postoperative airborne gap, which had a statistical significance. And we also assessed the postoperative airborne gap, so which we had very good results, as it's been shown at 1,000, 2,000, and 4,000 hertz. There was no significance in the ABG closure in different frequencies, and comparing the complications, we saw that there was no statistical significance in the sensorineural hearing loss. This is also showing that at 2 kilohertz and 4 kilohertz, there's no significant hearing loss. So there were not significant complications. 3 cases had transient dizziness, 1 patient had vertigo and tinnitus. So the limitations was we had small sample size because patient did not comply and there was COVID going on. And the other thing was we were at the beginning of the learning curve. So in concluding, it was the early experience in stapedectomy with KTP laser appears to be promising, and the results can be further improved with operating on further cases.
Okay, thank you. The paper is now open to the floor for questions.
So we did not, sir. We have data of patients with endoscopic stapes surgery done before, but the sample size is bigger. So once we get to that sample size, we plan to compare in the future, sir.
Yeah, this is more like an audit because its sample size is 8, which is very low. And the other thing is you have not compared the laser stapedectomy results with the other endoscopic stapedectomy results and the other open stapedectomy results. So how can you say that this is superior or this is inferior to the other things?
Okay, so due to the lack of time, we will close the question session from here. Thank you very much.
Next presentation is effectiveness of culturally modified cognitive behavioral therapy for patients with tinnitus in Sri Lanka. Preliminary findings. Presenter T. Abebandara Herath.
Good afternoon, everyone. I'm Thilini Abebandar Herath, and I'm working at the Department of Psychiatry, Faculty of Medicine, Ragama. I would like to thank you for providing me with the opportunity to present my study in this forum. The title of this research project is Effectiveness of Culturally Modified Cognitive Behavioral Therapy for Patients with Tinnitus in Sri Lanka, a randomized controlled trial. As you all know, tinnitus is a subjective phenomenon of persistent internal sound without an external source. It is colloquially known as ringing in the ears. Tinnitus can be heard either temporarily or permanently, and it affects between 10 to 20% of adult population during their lifetime. Abebandar Herath and Rodrigo found that 68% of tinnitus patients in Sri Lanka had a mental health issue. In that, 61.5% had depression. Just imagine ringing noise in your ears all the time or most of the time, and it is needless to say it is distressing and debilitating condition. Consequently, it is commonly associated with psychological problems, especially anxiety and depression. However, tinnitus is undertreated in Sri Lanka. Cognitive behavioral therapy, or CBT in short, is the most widely used psychotherapy in the world. In CBT, intricate connection between thoughts, behaviors, moods, and physiological sensation is highlighted. Thereby, if one of those domains were changed, it will change the other 3 domains. However, CBT is not practiced for tinnitus patients in Sri Lanka, at least in part due to no studies in Sri Lankan context. Though a number of treatments have been introduced for tinnitus, none of these treatments proven to be very effective for the patients with tinnitus in Sri Lanka. Further, some of available treatment is either too expensive or sophisticated for Sri Lanka. Therefore, effective yet easily deliverable and acceptable treatments such as CBT will be very useful in reducing burden of tinnitus in Sri Lanka. Rodrigo has shown modifications are necessary in CBT to make it more suitable for Sri Lanka, and modified CBT is 4 times more effective than unmodified therapy. This study focuses on reducing the distress and handicap with modified cognitive behavioral therapy for patients with tinnitus in Sri Lanka. When we say modified cognitive behavioral therapy, because original CBT was amended to make it more suitable for Sri Lankan context. It has been made shorter, briefer, less explorative, more behavioral than cognitive, and less homework based. So our main objective was evaluating the effectiveness of culturally modified cognitive behavioral therapy in reducing the distress among Sri Lankan patients with tinnitus. Apart from this main objective, we aim to assess feasibility of modified cognitive behavioral therapy to evaluate effectiveness of modified cognitive behavioral therapy in improving associated functional impairment and depression. Also, it aims to assess patients' and therapists' perception of modified cognitive behavioral therapy. This study is a single-blind randomized controlled trial which is conducted among the patients with tinnitus who are treated at ENT clinics in Colombo North Teaching Hospital, Ragama. Consenting adult patients who are complaining of chronic unilateral or bilateral tinnitus were included in the study, and people who are not conversant in Sinhala language or previously received psychological treatment or has a history of psychotic disorder dementia were excluded. Patients with otherwise treatable tinnitus were also excluded. We were recruited 53 patients with tinnitus and excluded 9 patients and included 44 patients for this study who met the inclusion criteria. These 44 patients were randomized using block randomization. 24 patients were included in the intervention group and 20 were control group. Randomization was done by using computer and random number generator according to 1-to-1 ratio. Participants was blocked into group of 5 according to age and gender. The participants, treating clinicians or researchers had no influence over randomization or allocation. Group 1 is the control group, and patients assigned to this control group received only standard care. Standard care involves otoscopic examination and brief education about tinnitus. Group 2 is the experimental group, which were received standard care, and they received 4 CBT individual sessions over 4 weeks. We were used 2 measurements. Tinnitus handicap inventory were used as the primary measurement, and general health questionnaire 12 were used as the secondary measurement. Tinnitus handicap inventory is a brief, easily administered way to evaluate the disabling consequences of tinnitus, and general health questionnaire 12 is a widely used instrument to detect non-psychotic psychological problems. Ethical clearance was granted from the Ethics Review Committee of the Faculty of Medicine, University of Kelaniya, Ragam. This study had also been registered at Sri Lanka Clinical Trial Registry. Further permission was sought from the hospital director at Colombo North Teaching Hospital, Ragama, to use the hospital ENT clinic for data collection. The total tinnitus handicap inventory score was used as the primary outcome variable. SPSS version 22 was used for the analysis. Descriptive parameters were established for the variables examined using the questionnaire outcomes. Relevant frequency and percentages were calculated for qualitative variables, whereas mean within standard deviation were calculated for quantitative variables. The mean difference of tinnitus handicap inventory and general health questionnaire 12 score change compared from the baseline to end of the treatment between the 2 groups used to evaluate the effectiveness of the treatment. Of 44 patients studied, 28 were female and 16 were male. The average age of participants was 52.25 years, and the average duration of tinnitus was 1.95 years. As for the location of tinnitus, 38 participants reported unilateral tinnitus, while 5 reported bilateral tinnitus and 1 through the head. A majority heard a roaring sound followed by a whistling type of sound. 18 participants reported perceived loudness of tinnitus as unbearable, while 11 patients compared the loudness was severe. Further, the majority of participants, 20 complained of hearing loss, followed by 17 participants reported vertigo. The vast majority of participants reported tinnitus to be much distressing and difficult to bear. Though there are relative the same mean, THI scores in both intervention and control group in an initial assessment respectively, the post-assessment indicated that there was a notable improvement of tinnitus handicap inventory scores in the intervention group. This graph shows the improvement of the intervention group. The orange color line shows the tinnitus handicap inventory score before the treatment, and brown line shows the after treatment scores. This graph shows the tinnitus handicap inventory scores in control group. Same as the first graph, orange color line shows the baseline scores and the brown line shows the scores after 4 weeks. According to the results we found, the patients who received CBT significantly benefited more than the patients who were in the control group. Therefore, CBT is an effective and easily deliverable treatment for patients with tinnitus in Sri Lanka. These are our references. And thank you. I'm happy to answer any of the questions you may have, any clarifications you may require.
Now, the paper is open for discussion.
What do you mean by culturally suitable CBT?
Because, madam, it is originally developed for the Western population, so we have to make some modification to use it for our cultures. Sorry? Actually, usually CBT is a longer sessions, which is 45 minutes. So we reduce the sessions and it is brief. And also, original CBT is much focusing on cognitive restructuring. That means it's based more in cognitive aspect, but in our CBT is more tailored into the behavioral part, and also it is more relaxation based. It's also based on mindfulness rather than cognitive restructuring. Yes, yes.
There are no other questions. We can finish. Thank you very much.
Our next paper, oral presentation number 5, the relationship of oropharyngeal dysphagia with COVID-19 and post-COVID-19 patients at Sri Jayawardhanapura General Hospital ENT Clinic. The presenter is Premaratna MSS.
Good afternoon, dear sirs, madam, and my dear colleagues. I would like to share my research experience with you all. I'm Suranga Premaratna from Sri Jayawardhanapura General Hospital. The relationship of oropharyngeal dysphagia with COVID-19 and post-COVID-19 patient at Sri Jayawardhanapura General Hospital ENT Clinic. Dysphagia. According to the American Speech and Hearing Association, dysphagia is a swallowing disorder involving the oral cavity, pharynx, esophagus, or gastroesophageal junction. As well as, according to the National Institute of Health, people with dysphagia have difficulty in swallowing and may even experience pain while swallowing, which is called odynophagia. Some people may be completely unable to swallow or may have trouble safely swallowing liquids, foods, or saliva. When that happens, eating becomes a challenge. Dysphagia associated with any disease will compromise patient outcome, including aspiration, pneumonia, increased length of hospitalization, malnutrition, and higher mortality. However, dysphagia as a result of COVID-19 is yet to be understood. In Sri Jayawardhanapura General Hospital, during the second wave of COVID-19 pandemic, 8 out of 64 were referred to ENT unit out of 5 complained of dysphagia. Objective of the study: to find out whether there is a significant relationship between patient with COVID-19 and oropharyngeal dysphagia. To find out whether there is a significant relationship between post-COVID-19 patient and oropharyngeal dysphagia. This is to build the knowledge base, better understand the dysphagia with COVID-19. We believe this will help other clinicians in the field to optimize dysphagia outcome for patient with COVID-19. Study design, observational study. Methodology, face-to-face swallowing assessment, which of each patient including oromotor examination and FEES, fiber optic endoscopic evaluation of swallowing, was done. And one thing I have to mention here, written consent was taken from all participants, including this the study. Results. All these participants presented with dysphagia. Out of 5 cases, 3 patients, 2 male and 1 female presented with dysphagia 5 to 7 days after discharge. Other 2 cases presented with dysphagia while being treated for COVID-19. These are the participants, 2 male patients and 3 female patients, and 3 post-COVID patients and 2 COVID patients. All 5 patients. Okay, patient managed for COVID-19. Case number 1, 67-year-old male patient, hypertension and diabetics are the comorbidities, presenting complaint was difficulty in swallowing. Case number 2, 91-year-old female patient, hypertension and diabetics are the comorbidities, presenting complaint was difficulty in swallowing. Patient managed post-COVID. Case number 1, age 72 male patient, comorbidities are the hypertension and diabetics, presenting complaint was difficulty in swallowing. Case number 2, 68-year-old male patient, same comorbidities, hypertension and diabetics, difficulty in swallowing is the presenting complaint. Now, case number 3, 77-year-old female patient, hypertension and diabetics are the comorbidities, presenting complaint was difficulty in swallowing. 3 post-COVID patients underwent the FEAST test and informal swallowing assessments. During the second wave, inward COVID patients were not subject to the FEAST examination. But oromotor examination and informal swallowing assessment showed pharyngeal phase dysphagia. FEAST test results. 2 patients showed pooling of secretions, all showed residue after swallowing, and none of them showed silent aspiration. And the special thing I have to mention here, after the diagnosing procedure, we will start that this 15-day block of therapy sessions for these patients, including oromotor exercises, dysphagia therapy, compensatory maneuvers, and food modifications. Conclusion of the study. Our study showed a relationship between the COVID-19 and dysphagia. However, since this was conducted during the second wave of COVID-19 pandemic in Sri Lanka, limited number of patients were admitted to the Sri Jayawardhanapura General Hospital. However, to find out whether there is a significant relationship, more cases need to be analyzed and presented. Thank you.
Thank you. The paper is now open to the floor for questions.
I would like to invite to Madam Darshika to give the answers to the question.
Oropharyngeal dysphagia is a very common complaint present to the ENT clinics. So what is the difference when you observe normal population and the COVID-19 patient? Is there any difference?
So this was
Because COVID-19 anyway is patients present with oropharyngeal odynophagia, sore throat, one of the complaint.
Yeah, this was conducted during the second wave of COVID-19, and our hospital was not a COVID center, sir. So we had a very limited number of patients. They were referred to us when they complained of dysphagia. Most of them would have had this complaint, but referred only who complained dysphagia and those who they found it difficult to pass the NG tube. Then only we got to see these patients, and those patients underwent this oropharyngeal examination and FEAST, especially post-COVID patients underwent FEAST examination.
How many days after COVID?
How many days after COVID?
5 and 7 days. after 5 and 7 days after COVID. They complain about the dysphagia. Then we did the FEAST test also. That FEAST test indicate the pharyngeal level dysphagia. And informal assessment also the done.
Unfortunately, we have run out of time.
During active COVID period, we
Okay,
didn't do
thank you.
examination, only oropharyngeal examination.
Next paper is evaluation of the knowledge on vertigo among medical practitioners at Sri Javadhanpura General Hospital. Presenter De Silva, WKTD.
Good afternoon, dear madam, sirs, and my dear colleagues. I'm Dr. Tilani from Sri Javadhanpura General Hospital. My topic is evaluation of the knowledge on vertigo among medical practitioners at Sri Javadhanpura General Hospital. As we all know, vertigo is a common complaint we come across in our clinical practice, which could be due to numerous etiologies apart from otological and central nervous system causes, such as cardiovascular, hematological, endocrine, and psychiatric causes, and even sinusitis. We all know management of vertigo especially relies on accurate diagnosis. Most of these patients present to many specialties with the complaint of disease spells, and this has led to confusion, erroneous diagnosis, and management difficulties. Our primary objective was to assess current knowledge on vertigo among medical practitioners at our hospital, which is a tertiary care teaching hospital. Secondary objectives were to create awareness and enhance knowledge on vertigo among medical practitioners, and thereby to improve the patient evaluation and patient referral system to relevant specialties. Our study was a cross-sectional study using purposive sampling method. We used a pre-tested questionnaire consisting of 20 multiple choice questions designed to assess knowledge on history, examination, investigations, and management of vertigo. Medical practitioners from all specialty units were included. Consultants and ENT unit were excluded. Moving on to the results of the study, we distributed 100 questionnaires and 84 responses were received. This is the unit-wise distribution of the responses. Majority of the responses were from MOs and SHOs. More number of responses were received from medical wards, followed by ETU and cardiothoracic unit. 95% of participants were knowledgeable about the correct meaning of vertigo. Majority were aware that the pathology behind true vertigo could be involving not only inner ear but also cerebrovascular system or cervical spine. 68% were able to detect a case scenario of a probable Meniere's disease. Only 7% were able to suspect BPPV when given a suggestive history. %91 knew BPPV can be diagnosed using simple Dix-Hallpike test. Majority were not aware beta histine may result in falsely negative Dix-Hallpike test in a patient with BPPV. Since labyrinthitis with sudden sensorineural hearing loss requires prompt attention, we wanted to know their knowledge on this. Unfortunately, only 34% got the correct answer. Missing sensorineural hearing loss during initial assessment can lead to permanent hearing loss. Unfortunately, majority, that is 76% of the participants, did not know about this. Posterior cerebral artery infarction is a life-threatening condition where patients may present with vertigo, confusion, severe headache and visual impairment, mostly to the ETU. I'm happy to say 73% of the participants got this right, including most of the ETU doctors. It's happy to see majority of the participants got the case scenarios of non-true vertigo correct. That is hypoglycemic attacks, panic attacks, and postural hypertension. 86% of participants knew about vestibular toxicity associated with the prolonged use of gentamicin. Unfortunately, most participants were unable to identify the most essential set of basic investigations when investigating a patient with vertigo. 61% knew that vestibular rehabilitation is the mainstay of management of true vertigo. 77% were aware that BPPV, which is a common cause of vertigo, can be successfully treated with Epley's maneuver. Majority did not know prolonged use of cinnarizine may delay recovery from vertigo. When we see patients referred to us in our vertigo clinic at our hospital, we have noticed most patients are already started on 8 mg TDS of beta-histine, which is a suboptimal dose in treating vertigo. As we predicted, majority were not aware of this. In conclusion, most of the participants were knowledgeable about the causes of non-true vertigo such as endocrine, hematological, cardiovascular and psychiatric causes. Majority had an average knowledge on causes of true vertigo. Marked deficits in knowledge were noted, especially concerning the management of vertigo and complications. Awareness should be raised regarding the need of early diagnosis and timely treatment of sudden onset sensory neural hearing loss associated with vertigo. In order to achieve our secondary objectives, we provided a quick feedback to the participants for the questionnaire to help brush up their knowledge. We plan to organize a webinar to educate and brush up knowledge on basics and important areas of vertigo management for non-ENT medical practitioners. And we hope to develop a protocol on how to assess patients with vertigo, investigate and refer to the relevant specialties. These are my references. Thank you.
Thank you. The paper is now open to the floor for questions.
That is, vertigo is the sensation of rotation of oneself or the surrounding. So, true vertigo, we consider that. Yes.
In this, you said that the vertigo may lead to permanent hearing loss. What do you mean by that?
Sorry?
The vertigo may lead to permanent hearing loss. What was the? In one of the slides, you said that the vertigo may lead to permanent hearing loss. What did
patients with labyrinthitis, they may present with vertigo with sudden onset of hearing loss, and delay in treating labyrinthitis may result in permanent hearing loss.
Yeah, you said the vertigo may lead to permanent hearing loss. What is that condition?
I didn't mean not just vertigo, but vertigo with sudden onset sensory neural hearing loss.
What were the investigations you did? What were the investigations you used?
We do a full blood count, fasting blood sugar, lipid profile, and thyroid profile, PTA, and as such.
Okay, thank you. Due to the lack of time, we have to progress to the final oral presentation. Our next presentation is the impact of COVID-19 pandemic on the ENT clinical practice and healthcare workers of the ENT unit of Sri Jayawardenepura General Hospital. Presenter is Boteju WPR.
Good afternoon, distinguished judges, sirs, madams, and colleagues. My topic today is the impact of the COVID-19 pandemic on the ENT clinical practice and its healthcare workers at Sri Jayawardenepura General Hospital. As you know, the ENT unit is a very high-risk group during this COVID-19 pandemic because they are particularly exposed to viral transmission directly through mucus and aerosolized particle during our examinations and procedures involving the head and neck region. The objective of this study was to find out the impact on ENT practice due to this COVID-19 pandemic at Sri Jayawardenepura General Hospital, specifically to find out the changes that took place in the ENT clinical practice with regards to personal safety measures, protocols of the healthcare workers attached to it. Also, to find out the overall outcome, whether it is negative or positive, as a result of the very specific changes made in personal safety measures, protocols taken at different clinical settings. Finally, also to find out how these changes affected the healthcare workers in the aspects of professional work environment, social well-being, and safety. This was a qualitative research framework using convenience sampling, and the data was gathered using a structured questionnaire distributed amongst 50 participants attached to the ENT unit. 3 questionnaires were prepared, sectored into medical officers, nursing staff, and supportive staff. Firstly, we addressed the duty roster. Around 37.5% medical officers agreed that the duty roster was not structured according to the workload and attention to healthcare worker safety. But following the pandemic, 100% of medical officers are very happy with the structured and streamlined duty roster. Unfortunately, nursing officers and supportive staff agreed otherwise, mostly due to the fact that their rotations were also implemented with the COVID-19 ward activities. Triage is the next thing that we address. 90% of medical officers and 74% nursing officers agreed that prior to the pandemic, there were no proper triage system while arriving of patients to the clinic and ward setup, but over 80% agreed that now it is properly implemented. Telemedicine is something new we introduced in our clinical practice. Earlier, to reduce the overcrowding in our clinics, and also to call and interpret our pre-surgical patients if they have a history of COVID-19 infection. 20% and 50% of medical officers agreed that it did not happen earlier, and 100% agreed that it is happening effectively now. Also, I should mention that handling the patient care via telemedicine had a declined effect in the effective and systematic management of our routine patients. Hand washing and sanitizing was almost only 40% of medical officers agreed that they used routine hand washing and sanitization in their practice, while 100% agreed that it is an established practice now. Surprisingly, nursing staff, 90%, already practice proper hand hygiene while attending to patients, but 100% of supportive staff agreed that now they are established and using proper routine hand washing and sanitization techniques. Work attire, as expected, all medical officers, nursing staff, and supportive staff agreed that scrubs were seen as more work-friendly attire. Masks were not worn by over 90% of medical officers prior to the pandemic, but nursing staff, 48%, and supportive staff, 69%, agreed that when needed, they had access to masks. Gloves, over 60% of medical officers did not use gloves in their routine practice prior to the pandemic, but 78% of nursing staff and 75% of supportive staff agreed that they used gloves when needed when they were involved in routine practices. Access to PPE was almost non-existent to the medical staff, but nursing staff, 78%, and 31% of supportive staff agreed that they had routine access to PPE when needed. PPE also consists of distress when carrying out procedures during the pandemic. 70% of medical staff agreed to this, 35% of nursing staff and 31% of supportive staff agreed to this statement. Video endoscopy and screening was also something new we implemented in our practice following the COVID-19 pandemic, and these examinations were done 50% of medical officers agreed that it was a good way to protect themselves during this pandemic. Isolation and separation facilities, although existed previously, it was not efficiently utilized until this pandemic, and 100% of medical officers and 77% of nursing staff agreed that it is implemented correctly now. Single-use aprons access was almost non-existent to medical officers prior to the pandemic, but 34% of nursing staff and 68% of supportive staff agreed that they had a stock available for emergency usages. But right now, it is available universally to all three sectors. Donning and doffing. We assessed the knowledge of donning and discarding PPE prior to the pandemic, and I'm sad to say 50% of medical officers did not have proper knowledge and guidance prior to the pandemic on donning and doffing of PPE, while 74% of nursing staff and 57% of supportive staff knew proper donning and doffing techniques. Distance to patient was something we implemented following the pandemic, where there was adequate social distance maintaining while attending to patients, and 90% of medical officers agreed that it was not a practice prior to the pandemic. But the current practice of distance did not give the same sense of satisfaction of care as prior to the pandemic, and 50% of medical officers agreed to it. Visitors. Since the restriction of visitors to the clinics and wards due to the pandemic, there was a hindrance in patient communication, which led to the decline in patient care, and 70% of medical officers, 70% of nursing staff, and 82% of supportive staff agreed to this statement. Waiting and visitors areas were already designed but not designated and utilized properly prior to the pandemic, and 39% of nursing staff and 69% of supportive staff agreed that it is being utilized properly now. Sterilization and disinfection methods. Although specified sterilization containers and disinfection methods already existed, following the pandemic, 96% of nursing staff and 94% of supportive staff agreed that they have gained knowledge on specific methods of disinfection and sterilization. Instrument usage. Nursing staff agreed that allocated instruments were already used and was in current practice even prior to the pandemic. Sanitization methods. General sanitization methods were used prior to the pandemic, but post-pandemic specific sanitization methods were used by nursing staff and supportive staff. Patient rotation was specially specific to the supportive staff, and they complained of a hindrance of trying to control the patient's traffic, maintaining social distancing during our clinic setup. Assisting patients were also a role of the supportive staff, but they said they had adequate knowledge on how to safeguard themselves from infectious diseases when attending to them. Break rooms were a designated place utilized for tea breaks shared by all staff in our unit, but right now 70% of medical officers, 74% of nursing staff, and 50% of supportive staff agreed that they are utilizing and using their breaks individually following the pandemic. Happiness criteria. We asked two questions. Are you happy working in the ENT unit prior to the pandemic, or are you happy working in the ENT unit presently? And I'm happy to say that medical officers and nursing staff agreed that they were happy to work in the unit prior to the pandemic, but supportive staff agreed that they are happy now. The findings of this study show that there is a noticeable change in the ENT practice with regard to personal safety measures and protocols of the healthcare workers attached to our unit. The overall findings show positive as well as negative outcomes. But the impact on professional work environment, social well-being, and safety during the pandemic shows an overall declined effect. Thank you.
The paper is now open to the audience for questioning. Okay, since we don't have any questions, that concludes the oral presentation component of this free paper presentation. The winners of the oral and post presentation will be announced after the panel discussion. Thank you very much.
Thank you, Dr. Indika and Dr. Akram, for that wonderful session. That winds up the free paper presentation session. Ladies and gentlemen, now you can have a short break for tea and gather for the panel discussion. So you can pay visit to outside stalls along the Orchid extension. Thank you.
Yeah. Timer එකක් යනවද මෙතන? හොඳයිද? Ranjit, shall we start? Okay, good evening, ladies and gentlemen. So we have come to the last item of the annual academic sessions. That's the panel discussion on the topic precision tools in otorhinolaryngology, the way forward. So I would like to invite the illustrious panelists, that is Professor Prathamesh Pai, Dr. Chandrasri Narampanawa. Can you please come to the stage, Dr. Narampanawa? Professor Ramandeep and Professor Suren Krishnan.
and Dr. Daminda Domingo Arachi. Thank you very much. So we will be covering a few topics that was discussed yesterday and today. So the field of ENT has moved from headlight and torch to a very high standard at the moment. So we will be starting with a basic ENT complaint that we see, that is enlarged tonsils. And this child presented with history of snoring, mouth breathing, and obstructive sleep apnea. And on examination, the patient had large tonsils. So, and in fact, you know that the tonsillectomies have been reported in the Hindu literature 1,000 years before Christ, and it has been an evolving surgery. So, given this millennium and the decade, how would you go about this patient? Dr. Narampanav? The method of tonsillectomy that you would use.
Yes, problems again.
Snoring, mouth breathing, and obstructive sleep apnea, and the patient has been posted for tonsillectomy.
What about the adenoids?
Yeah, I'll come to it later. We'll start with the tonsils first. The investigations are all done, so the method of dissection.
Yeah. What,
your method, what would you prefer?
What I have is only the bipolar dissection and the cold steel technique.
Right.
So I prefer bipolar technique.
Bipolar technique. Dr. Ramandeep, your preferred technique for this patient?
I would go with the coblation tonsillectomy, since we routinely do that with coblation.
Right.
And we're using the EZ View wand, which we demonstrated yesterday.
All right, that's the one that you use.
Yes.
Okay. And Professor Prathamesh Pa, you have any preferences? Excused, okay. Right. Professor Suren, are you there with us?
Yes, I am here.
Yes. What would be your method of dissection for this patient?
Can I just ask what the age of the child is?
The child is 4 years.
4 years.
Yes.
So generally, as a rule, I assess the child's weight, and also the child's ability to gargle. So as a general rule, if a child can gargle, because the main issue we all have here is what is the operation that will provide the least risk of bleeding, and if the child bleeds, how the child can cope with bleeding. So if I have a child, 4 years is a bit of a cutoff. Certainly if they were 5, I would use a hot technique, and my preference nowadays is the Bizac technique. But in a child who can't gargle and can't, safely, if I don't feel that they can safely protect their airway if they have a bleed, then I would use cold steel and ties for hemostasis. So I use a non-hot technique for young children who have an anxiety about the ability to protect their airway.
Okay. So coming back to Ramandeep, would you use coblation or cold steel in this age group as a preferred method?
We still use coblation. I am not very comfortable with using cold steel instrumentation.
Okay.
And so I wouldn't use that just because of my comfort level.
Right. Thank you. So we've started dissecting the tonsil and we have gone to the lower pole. So how would you manage the lower pole in your routine tonsillectomy cases? Okay, now let's cut off the age limit. Say it's on a 10-year-old, doesn't matter. So Daminda, is there any specific way you manage the lower pole?
No, standard way, ligature or bipolar, sometimes combined.
You use bipolar and ligate, or?
Yes, normally bipolar and then
ligate.
Yeah.
Right.
If
Okay.
bipolar is enough, I just stop from there.
Fine. From Ramandeep, yes?
When we use the coblation also has a built-in coagulation, which is like a bipolar coagulation. I routinely use the plasma ablation on the upper part. Once we reach the lower part, like we demonstrated yesterday, we make sure we use the coagulation mode of the coablator.
Okay.
And to make it work, you have to keep the wand pressed onto the tissue and count till 5, because it won't coagulate if you just do a hit and go. You have to keep the wand pressed on the tissue, and once the coagulation takes place, you can use the ablation to remove the lower pole.
That's right. So you wait for that 5 seconds.
Yes,
That's
and
right. Yeah. So
that's
the
why I was
message,
making
yeah.
sure I was telling everyone that count till 5 in your mind.
Right. Yes. Prof. Suren, how do you manage the lower pole routinely in your tonsillectomies?
So with the bisect, you can manage the lower pole without too much difficulties. But as I said, in some hospitals, I don't have the bisect, and I use the coablator in a 10-year-old. In a 4-year-old, I would usually try and tie off the inferior pole. So when I get to the inferior pole, I use something like a curved negus.
Yes.
And then I transect the inferior pole and put in a 2-vicryl tie to ligate the stump adjacent to the tongue base.
Yeah, that makes perfect sense. So for the benefit of the trainees, yes, this is the method. So at the lower pole, got to be very careful. Right. So then once you have done that, and still there is a bleeder on the tonsillar bed, yes, Prof. Suren, over to you again. What do you do? Do you routinely either coablate or cauterize the paratonsillar veins, or only if there is a problem? What do you do?
Yes, I only deal with it if there is bleeding, and again, a tie for someone 4 and under, and bisect generally works well for the paratonsillar veins. I think I showed in my video yesterday, some may not have seen it today, but you can pick up the bleeder just with a pair of forceps, and then the 5mm jaws of the bisect will easily clamp onto the bleeding vein, and the current will seal the bleeder.
What about you, Ramandeep?
So the key here is, whenever there is a ooze after you have removed the tonsil, don't go about blindly doing bipolar or cautery left and right. The key is to identify where the bleed is coming from. So like yesterday we demonstrated, you can use a stamp size, cottonoid or gauze. Press, clean the area, and then move the cottonoid gently, identify the bleeder, and then just zap that bleeder. That will save you a lot of heartache later on, because if you blindly cauterize tons of area of a tonsillar fossa, there is going to be slough formation, there's going to be pain. So the key here is identifying it, and then you can go ahead and seal it, whether it's with a bipolar cautery or with a coablator or with a bisect, as Dr. Suren is saying. The key is to identify and then coagulate it.
Don't rush through it, wait, take your time, and then handle the area. Okay, so these are some of the methods that they use on bleeders, coablators, which we agreed upon. Right. So
can I ask a question?
Yep.
I would like to ask a question from Dr. Narampanawa. Now, most of us are having don't have coablator or this bisect. Why did you choose bipolar method rather than having the cold steel and ligature for this child?
One thing, it's easy and quicker. So I have done both. Nowadays I use the bipolar technique. My cases, I have never had second bleeder, post-operative bleeder so far. And they are usually okay. Almost all of them I discharge just after 24 hours I discharge them. And though whatever the method I use, bipolar or the cold steel, the lower pole I always put a ligature. I always do that. Lower pole I tie. And so in my practice I have seen bipolar is easier and convenient out of the things we have. And they don't get much pain if we don't burn too much.
That's right. So they talk about mucosal preservation, isn't it?
If you are on the tonsil when you are using the bipolar, the flow is all right. If you are on the floor, If you burn on the floor, then you get a lot of tissue damage.
Ramandeep, you have to anything to say about the mucosal preservation in tonsillectomy?
Yes.
Where do you start dissecting? Is it you start from medial to lateral? How do you start the plane?
So regarding the bipolar, I think the bipolar is a great tool. Why I was not always happy with the cold steel, even when you are teaching, when you want to teach your younger colleagues and your students, you want them to see an absolutely clear field of what exactly a tissue plane is, which was not always possible with cold steel. I mean, there are surgeons who would perform that surgery with cold steel to the T, like excellent, but unfortunately I was not one of them. If I give an incision, the mucosa used to start bleeding. Once the mucosa is bleeding, you enter the wrong plane, there is more bleeding. So let alone teaching, I mean, you can barely understand the plane yourself. So with the bipolar, I learned bipolar when I was in England. There was an audit going on at that time comparing cold steel with bipolar instrumentation. So with the time and practice, look, everything has a learning curve.
Yep.
Right? So with time and practice, a bipolar forceps can be used as a dissector also. We do it under microscope. We were seeing, even with coblation yesterday, we were only coagulating when we were seeing a blood vessel. And otherwise, you can just, with a bipolar forceps, you can keep on dissecting the tissue plane. As long as you're in the right plane, the human planes, they give away very easily. So identify the vessels and then use blunt dissection wherever necessary, and you will limit the collateral thermal damage.
So talking about the post-operative pain and bleeding, is it a myth or is it a reality?
Can I add a little? About the mucosa, I do not completely cut the mucosa with the bipolar diatomy. I just mark the place mucosal line where I want to cut, and then I mark it along with the bipolar, and then I use the scissor to divide the mucosa.
Yeah. So about the post-operative pain and bleeding with the diathermy, the coblator and the other techniques, still people, there are more literature to say that the bleeding and the pain is more post-op. So is it still valid or is it a myth?
I think it was not proven, it wasn't statistically significant, it was marginally higher, the post-operative hemorrhage that does takes place. But then that can also be because of the learning curve, because any new tool, people have been doing with bipolar and cold instrumentation since years, and they have perfected that art. When the studies with the coblator came, I mean, we were hardly into 30 or 40 cases of coblation tonsillectomy. So maybe if now we do a study, the outcomes might be different.
Yeah. Professor Suren, you have any thoughts on that?
I think those are all valid points that are made, but I think most studies do show that the primary hemorrhage rate is negligible, whatever technique you use. Cold steel or hot techniques. But I think the secondary hemorrhage rates are higher with the hot techniques. And certainly our data shows that with our own experience, and we are senior surgeons, the two surgeons that were operating, we did have a higher secondary hemorrhage rate. I think the important thing is that to recognize that the return to theater rate, though, was the same as cold steel. So I think we are being a bit more obsessive when you're doing a clinical trial to document the secondary bleed rate, and that might artificially inflate the clinical significant bleed rate, if you can understand what I'm saying.
Yeah.
The return to theater rate, I would agree with Professor, is probably identical between the hot and cold techniques. The unfortunate problem is that, the way I look at this is tonsillectomy is performed, and you're performing it on well kids, and you're making well kids weller. You know what I mean? You're making kids. This is not a fatal illness. I know that sleep disordered breathing is a serious illness, but you're trying to make good well kids weller. And so I think that it behooves us to make sure that we make every effort that we don't get an untidy outcome. And it is that makes me use cold techniques for younger children, because if you have a bad outcome, it's hard for parents to forgive you, but it's hard for a surgeon to forgive himself or herself. So for that reason, I have those principles that I alluded, that for younger children whom I'm anxious may not be able to protect their airway if they have a secondary bleed, that I use a cold technique. But I think statistically and realistically, probably the return to theater rate bleeding is probably the same.
Okay, thank you. going back to laser. Yes, laser tonsillectomy. Anyone? it was in vogue, so it's all gone. Yep. So yes, coming back to the adenoids, same child, large adenoids. The preferred technique. Start with Professor Suren for adenoidectomy. On the same child, adenoidectomy.
Yes. So I'm still using an adenoid curette. I still find that you can do certainly an adequate adenoidectomy with an adenoid curette.
You use the blind technique?
Yes,
with the
I do a
curette, or
blind
do you have a look with an endoscope prior?
No, I do not. I do not do an X-ray. I do not do an endoscope. My technique is to, when I begin the operation and I put the gag in, is I palpate the palate and make sure that there isn't a cleft in the palate and that there isn't any submucosal cleft in the palate. Then put my finger between the palate and the adenoid tissue and make sure that this is not an unusual neoplasm, such as a nasopharyngeal angiofibroma or anything like that. And I also at that time, using my fingers, free the adenoid from its lateral reaches, so that when I engage my curette, that it will remove the adenoid as one pad. So I usually have maybe 2, maybe 3 actions of using the curette, and I try and remove the adenoid as a single pad.
Right, thank you. Yes, Dr. Narampanav?
As Suren said, I also don't do X-rays in adenoid. If the patient is symptomatic, I treat medically, and then I'm not getting better, I prepare the patient for adenoidectomy anyway.
How long is your medical treatment usually?
Usually about 2 or 3 months.
2 or 3
see the
months.
response.
Yep.
And if no response, then I prepare them, tell them might need surgery, and get them ready for adenoidectomy if necessary. And if the child is small, usually they are small, so we have to do assessment under general anesthesia. So I do a nasal endoscopy and palpation, like Suren says. And if the adenoids are big, I take the adenoid out by the curette.
Yeah, coming to the medical treatment, Daminder, do you give the topical steroid sprays plus Montelukast, or what's your management, medical management line before we go in?
Yeah, we tend to give, I don't think there's any proven evidence, but we tend to give topical steroids and antihistamines, and we see that it works.
Yeah, what's the experience from India on medical treatment on these patients?
The Cochrane review does agree that medical treatment is to be given before you go for surgical management. Yep. And again, like it said, Dr. Daminda and Sir said that it has to be for a minimum of 2 to 3 months. Now, for medical treatment, intranasal steroids are the ones that are given, and if the child is very young, we give mometazone furoate because of its low bioavailability. For bigger children, you can use fluticasone also.
Okay.
And between fluticasone propionate and fluticasone furoate, fluticasone propionate is better accepted because of its less bitter aftertaste in children. We do not use Montelukast routinely because that drug is on the FDA radar currently for causing sleep disturbances in children. So if you absolutely have to use Montelukast, warn the parents that your child might experience sleep disturbances, and they report seeing things at night when they are having bad dreams. So the parents should be aware of that. If that doesn't happen, then we plan the child for a adenoidectomy.
Okay. Anyone in the panel uses the microdebrider for adenoidectomy?
I used to use the microdebrider before. Even now, like me and Dr. Daminda were discussing, if the adenoid is very, very large, that is grade 4 as you call it, coming into the choana, reaching up to the upper limit of the choana, we can rapidly debulk with a microdebrider. Right. But that is purely to save your wand for multiple uses.
It's okay. Yeah, so here you go. I know you can appreciate the, so initial microdebrider for rapid debulking, followed by the co-ablator. So, and then what yesterday I think you were discussing about the perimysium, isn't it? How to identify, and then, so this is what, do you want to elaborate anything on this perimysium?
So perimysium is more of a to demonstrate the limit that do not cross that. Like I was saying yesterday, you actually don't really need to expose the perimysium in all adenoid surgery. If you give a 70-80% open airway, that is adequate for a child to breathe.
Right. Okay.
Because if you expose the perimysium, after that, if you go through it, you are going to expose the muscle, then complications, postoperative pain in the neck and all those things. And of course, retropharyngeal abscess have been reported when you have gone through those muscles in the literature.
Right. So we're coming to the neck dissections. Harmonic scalpel versus conventional hemostasis in neck dissection. Daminda?
I have no experience in using harmonic
scalpel. But we do use ligature at the moment, isn't it, in our hospitals? So they do work. So they help with reduced operating time as well as and the intraoperative duration plus the post-op bleeding. Professor Suren, you have any experience with harmonic scalpel ligature, and your thoughts on conventional hemostasis, the comparison?
Yeah, so I generally use ligature for my neck dissections. I think I explained, I really only use it for patients with a lot of adiposity. So I wouldn't use it as a standard part of my neck dissection, but I would use it if there was a patient with a lot of fat. I find that it is quicker because, as you know, when you transect fat, there's a lot of bleeding. I also use a bipolar technique. Someone yesterday talked about a neurosurgical technique using bipolar and wet sponges and dissecting. And sometimes in thin patients, it's a nice technique to develop a plane, and you can do a very effective neck dissection with hemostasis just with bipolar diathermy. I have used harmonic scalpel, and I'm afraid I don't like that technique. I found that too hot. I had one patient whom I'm sure got a facial nerve weakness because of the heat from the top end of the dissection associated with the harmonic scalpel. And on a number of occasions, I found that it was not as slick in my hands as the the ligature device. I think I explained there is a new device called Exact, which is ligature with a finer nose, which helps you dissect, so you can dissect along the accessory nerve, create a tunnel, and then de-roof the tunnel using the Exact device. And finally, I have also used co-ablator to try and do a neck dissection, and again found it a little bit slower and less fluid than ligature when I've had to seek a hot device. But generally speaking, I use a knife and bipolar diathermy.
Okay, so these techniques are devised to reduce the operative time, intraoperative blood loss, the drainage volume, as well as the post-op pain and the hospital stays. Right. Okay, coming to the larynx. This lesion was found on a smoker. He gives a history of hoarseness of voice of 3 months. Vocal cord mobility is normal. How would you proceed, Dr. Daminda? Would you do a fiber optic laryngoscopy and take a biopsy then and there, or after a FONL, do you post him for MLN biopsy, or what's your way? How do you follow these patients?
we would always do fiber optic laryngoscopy, and we will assess the vocal cord movements.
Yeah.
And
Do you try a biopsy at that point?
No, really, we could, but I think I normally take the patient to operating room and do a microlaryngoscopy and do a biopsy, because at the time of ML, in fact, we do endoscopic laryngoscopy, we do suspension laryngoscopy,
Yeah.
and use the endoscope 0 degree and 30 degree to have a good look at the undersurface of the vocal cords and the laryngeal ventricle and all parts of the line to make sure that we haven't missed anything, and we can assess a proper assessment, especially the anterior commission and all. And we take a biopsy then.
Is it only a biopsy, or you go for a full excision of the lesion at that point?
No, because we haven't
to cut?
proven. Now, if you are resecting it, we'll have to. If you are resecting a cancer, we'll have to resect with a good margin.
Yeah.
So if it's a benign thing, we don't have to do that.
That's
so
right.
we don't
Yes.
resect at that point. We take a biopsy,
Yeah.
and at the same time, if you have the suspicion, of course, we go for the CT scan and very good high resolution CT scan of the larynx.
Yep.
Along with the neck and chest we do,
That's
but
right.
the larynx high resolution to make sure that there's no paraglottic or pre-epiglottic involvement, and then we decide whether if we are to go for laser resection. That's how we decide.
Right. Ramandeep, what's your institutional protocol in this?
I can tell the institutional protocol, yes, but if you ask my personal parents,
Okay, we'll go with you.
I don't do head and neck, so I can barely identify what this picture is showing, let alone be able to answer your questions. Yes, so we in the outdoor, we have a fiber optic with a working channel. And many times because of the patient load, we usually give a spirolaryngeal nerve block, spray the, throat nicely, and use the fiber optic and send a biopsy right from the OPD.
Okay. You do
that saves us operating, OR time, which is very vital because of the amount of patients, patient load we have.
Professor Suren, how do you go about this patient?
Yeah. So I think, again, it's very important for the junior doctors that, you've got to take a good history. So if you've got a patient whom you know is a smoker, then there's a high risk that this is a neoplastic lesion and most likely an invasive malignancy. And you need to know the patient's occupation and how important voice is for the patient. If you've established that this is a patient that wants definitive treatment and understands the consequences to voice, our preoperative assessment includes both NBI to try and document as much of the mucosa that's involved, and stroboscopy. On video stroboscopy, you can identify transverse and longitudinal waves that the lesion sits on, and identify that this lesion is loosely sitting on the mucosa and not extending beyond the lamina propria to involve the vocal ligament and vocal musculature. And on that basis, we would do definitive treatment. Like doctor said, we do a technique called telemicrolaryngoscopy. So it's suspension laryngoscopy, and then use a telescope. We use an anesthetic technique known as Thrive, which is transnasal humidified rapid insufflation ventilatory exchange. It's a sort of an apneic anesthetic technique, which has been well proven. It was written up actually by an Indian doctor working in the United Kingdom, and we can get sometimes 40 minutes of anesthetics with this technique. And we would use a CO2 laser excision technique. We use a low power CO2, maybe even just 1 or 2 or 3 watts. When you're using Thrive with the CO2 laser, you have to stop the rapid ventilatory exchange when you are firing the laser, of course, because if you have char and a moving train of gas, oxygen, then you can have a fire. So you have to be very mindful of fire if you're using the CO2 laser in any oxygenated environment. It's not so much oxygen, but moving oxygen, that's the problem. So that's what we would do.
Okay.
NBI, video stroboscopy, and then probably we would do an excision biopsy, and then decide a future treatment after the histology.
Okay. So, in a center where laser or coablation is not available, what would we do for those lesions? Daminder?
Yes, it depends on your workload and all. Now, in our setup, I think we have been sending most of these patients for radiotherapy.
That's right.
But one might try resecting with cold instruments if you have expertise and if you have equipment.
Ramandeep, your thoughts on that? Cold dissection?
Again, there will be only thoughts because
yeah.
I've never, really operated head and neck malignancies. Like Dr. Daminda was saying, depending on your experience, I've seen some very fine laryngeal surgeons who give a brilliant demonstration just with a fine left or a right cutting scissor and a retractor. So yes, it can be possible. Radio frequency, many people, put it on a thin suction tape and, just cut off the tumor.
Okay.
Purely depends on what your setup is
Thank you.
having.
Right, we'll move on then. This is a T3N0 lesion. Professor Suren, what's your preferred method of operation for this patient?
Yes, I think, so this is a patient we would definitely perform a CT scan.
Yep.
Whereas in the first case, if the lesion wasn't extending into the anterior commissure, we probably wouldn't do a CT scan. In this case, we would definitely do a CT scan. Now, if there is paraglottic involvement and involvement of the through the cricoarytenoid junction into the preepiglottic space, then this patient would get a total laryngectomy as the surgical option. There would be a group of patients who would ask for a non-surgical option and would then go for a trial of chemoradiation. But our experience with T3 tumors and chemoradiation organ preservation protocols is not very good, with a high percentage being converted to total laryngectomy.
Okay, thank you for answering that question. I wanted to ask you about organ preservation laryngeal surgery. So you have answered that. Thank you. Okay, so this patient with supraglottic carcinoma with positive cervical lymph nodes, anyway, you're going to, what are you going to do about the neck nodes? Are you going to go for an endolaryngeal surgery, or is it going to be an open surgery, Professor Rain?
Supraglottic carcinoma patients will have to have their neck addressed. And, you can decide whether you're going to do this endolaryngeally and radiate the neck nodes. That is an option that some people would consider. It wouldn't be our preference. Our preference would be to do the endolaryngeal resection and stage bilateral 2, 3, 4 neck dissections.
Right. Okay, we have a case here. So this patient had squamous cell carcinoma of the vocal cords, and it was treated with radiotherapy. It was a T2 lesion. So he presented with this finding after a year of treatment. Right. So what would be the treatment? Professor Suren, once again. It's a radio recurrence.
So I'm afraid I can't exactly see the recurrence, but I presume it's involving just the anterior third or so. Yeah. I think that if you have a limited recurrence, so if it's involving the anterior 2/3 of the vocal cord, even if it involves the anterior commissure, then we would probably look at some sort of laryngeal preservation surgical option, especially since this patient's already had radiotherapy. And the two options are either a vertical partial laryngectomy or an extended vertical partial laryngectomy or a supracricoid laryngectomy. And this would depend on a number of factors. One of the main factors would be the lung reserve of the patient. We find that patients who have a supracricoid laryngectomy, they really need to have good lung function. If they don't have a good lung function, certainly a vertical partial laryngectomy is a fairly straightforward operation with good outcomes, even in previously radiated patients.
Dr. Narampana, your thoughts on laser on this patient?
No, I don't think, because it looks like involving the anterior commissure. We don't know how far it has gone anteriorly.
Okay, it's interesting. I'll
I have to do a CT and see whether it has gone
Yes, So this is what was done. Laser cordectomy, type 5. And this is the post-op appearance, and patient is doing well. Daminder, can you elaborate on this?
Yes, this is one of our patients. I think Dr. Shelby sent, I can't remember whether through oncologist. So he had a limited lesion in the anterior commissure and right vocal cord. So we assessed with the CT scan, didn't have any extension into the preapical space or paraglottic space. We offered options, obviously, and obviously the patient decided the laser treatment, and we went ahead. Surprisingly, patients, it is a biopsy-proven recurrence, I should say, and then didn't have anything on the resected tumor or the tissue.
So yes, so we need to keep a close eye on this patient. So these are the options. Thank you.
Can I add few things now?
Yeah.
Now this is one problem. I think there are this is a recurrent case, but when it comes to primary cases also, there are several studies showing that early laryngeal cancers, when they go for these resections, in about 10 to maybe 30% of the time you find no
That's
cancers.
right, yes. So
which
sometimes
is an important finding and important fact, and in contrast, like in other words, that we are perhaps treating with radiotherapy about 30 to
a lesion that is not existing.
Yes.
Yes. So these are very interesting thoughts. So most of the time, 20 to 30% of the times, the biopsy will come as negative because you already excised the lesion. Right, so we have only limited time. We'll just go for one more topic, bilateral abductor palsy of the vocal cords and the extent of surgery. What would you like to offer, Dr. Narampana, for this patient? A cordotomy, arytenoidectomy, or both?
Can you put the picture again?
Yep, here you go. This is the patient?
Yeah. How is the patient's clinical situation? Can the
Patient
patient
has-
manage with this
No.
airway or not?
No, patient is finding it difficult to manage activities of daily living.
I might extend the cordotomy a little.
Right.
Might take a little bit of the cord out.
Right.
The CO2.
Okay. First you go for the cordotomy and then wait and see what the patient is, and then you might extend in the second sitting. Yes, I think yesterday, Ramandeep, you came up with some good points about doing, on an incremental fashion. So
Right.
how would you do this?
So number one is patient's expectations. What does the patient want? Like if it's a young patient, it's an athlete, you would want more space because that is their profession, they have to do it. But if it's an older lady like we had yesterday, then we can start, like I said in airway, it's better to underdo, you will still get another chance. If you overdo, there is no going back. So after that is decided, we counsel the patient that this treatment might require multiple sittings because different patients respond differently. And then we can start with the simplest, which is the posterior transverse cordotomy, or the classic Kashima's procedure as it's called. And we already discussed yesterday how would we choose the side, which side are we going to operate on. So number one, fiber optic examination. If we see a flicker in one of the cords, we leave that out. We handle the other cord. If both cords are behaving the same, then if laryngeal EMG is available, you can study the potentials, etc. But if it is not available, then we take the patient to the OR. Once the patient is in the OR, we use a stout instrument and we study the recoil of the arytenoid. If there is any fixity, go for that side first. If it's not, then it comes down to surgeon preference. I'm a right-handed surgeon. I find it easier to operate on the left vocal cord. And that's how I usually go about it. The other thing we discussed yesterday is that many times posterior glottic stenosis will also present like a bilateral abductor palsy of the vocal cords. Now, that being said, the treatments more or less can also be the same, but the outcomes are different. Bilateral abductor palsy has a better outcome than posterior glottic stenosis, because that's a little tricky to treat with all the mucosal flap elevation techniques that are described. Then I start with an incision, either with a laser or a coblator like we demonstrated yesterday. We separate the vocalis from the vocal process and we move to the wall of the subglottis. That forms the initial extent. If it was a revision surgery like it was yesterday, we also remove part of the false cord. And then we just follow up the patient. And mitomycin C is applied at a concentration of 0.4 milligram per ml, 3 applications of 2 minutes each.
3 applications,
yeah.
That's right, okay. I'm afraid I think we are short of time, so we have so much to discuss, but due to the time constraints, we need to close this session. So I would like to thank once again our panelists for being here the last 2 days and sharing your knowledge with us and the expertise and of course the way forward in this field. So there will be new technologies that will come to the market, so we need to be up to date with it and then learn through experience with the people who are doing it. So go for more courses and learn what is being done. So that's the purpose of this whole 2 days of annual academic sessions, the 17 sessions of this council. And I thank the panelists once again for being with us, especially Professor Surain and Ramandeep and Professor Prathamesh Pai, Dr. Naram Panava and Dr. Daminda. So please join me in applauding our panelists. Thank you very much.
Ladies and gentlemen, we will now announce the results of the Best Poster and Best Paper presentation at the College of Otorhinolaryngologists and Head and Neck Surgeons of Sri Lanka Annual Academic Session 17. I would like to call upon the President of the College, Dr. Yasat Veerakkodi, to deliver the awards to the winners and the participants. Dr. S.K.P. Harishchandra Memorial Award for the Best Scientific Paper goes to T. Abhay Bandara Herath on effectiveness on culturally modified cognitive behavioral therapy for patients with tinnitus in Sri Lanka, preliminary findings. Dr. S.K.P. Harishchandra Memorial Award for the Best Poster goes to W.P.L. Veerakkodi, a study of quality of life and complications following close reduction of nasal bone fracture under anesthesia. I would like to name all the participants so that they can come up and collect their certificates. Oral, we will be starting with the oral presentations. Dialvis ASR. Kumara AAS. Terikoral SM. T. Abhay Bandara Herath. Premaratna MSS. De Silva WKTD. Boteju WPR. Moving on to poster presentations, Varnasuriya WAN. Terry Coral SM. And also she has presented 2 posters. Virakudi WPL. And Jayasena KDNUD. Okay. Yes. Thank you, Yasatsu. There is a raffle draw carried out by the Marks Health HLC, which was carried out during our annual academic sessions. I would like to call upon one of their representatives to come up on the stage for them. I would like to call upon our college president, Dr. Yasat Virakudi, again for the raffle draw. You all want to do this? Okay, I will give you. Are you okay? Right. So the winner of the raffle draw will be having a 1-day stay with their family at Villa 14 Bolgoda. So I would like to give Dr. Yasat Virakudi to announce the winner.
If the winner is not here, we'll be taking. If the winner is not here, we'll draw it again. Asanka. Dr. Asanka Dharmavardhan. You're giving some? Okay. You will be getting the...
Yeah, okay, thank you. Sir, keep contact. Okay, thank you.
Actually, Dr. Yasat Virakudi, I would like to call upon again to distribute the certificates for our panelists. Dr. M.W. Zavarullah. Yasasvi, will you be able to help us with this? Dr. D. Domingo Arache. And to Dr. C. Narampanavar. And to Professor Ramandeep Work. Ladies and gentlemen, that concludes the 17th annual academic sessions of the College of Otorhinolaryngologists and Head and Neck Surgeons of Sri Lanka. The Secretary of the College, Dr. S.D. Indika, will be now giving the vote of thanks.
Good evening, ladies and gentlemen. It's with great pleasure I deliver this vote of thanks at the conclusion of 17th annual academic sessions of College of Otorhinolaryngologists and Head and Neck Surgeons of Sri Lanka. First and foremost, let me pay my sincere gratitude to Professor Nilmal Kumar, President ENT UK and Consultant ENT Surgeon at Wrightington, Wigan and Leigh Teaching Foundation Trust UK, and Honorary Fellow of CORLHNS. We had an elaborative session with you. On behalf of the college, I thank you for the great support extended to the upliftment of the training and expansion of ENT services in Sri Lanka. I extend my heartfelt gratitude to Professor Prathamesh S. Pai from Department of Head and Neck Surgical Oncology, Tata Memorial Center, Mumbai, India. Unfortunately, we couldn't host you in Sri Lanka this time. Dear Professor Pai, thank you very much for the informative presentation. Listening to you on both days gave us immense knowledge, which will definitely enhance the ENT services in the country. Professor Amandeep Work, Professor of Department of Otolaryngology, Postgraduate Institute of Medical Education and Research, Chandigarh, Punjab, India. I repeat once more, physical presence here added more glamour to the event. We experienced elaborative presentations and live surgeries with you. Thank you for additional presentations done today. Thank you very much, Professor Work. My special thanks goes to Professor Suren Krishnan, Head of the Department of Otorhinolaryngology and Head and Neck Surgery, Royal Adelaide Hospital, Adelaide, Australia. Your immense contribution to enlighten us during pre-congress workshop and annual academic sessions greatly appreciated. I extend my gratitude to Dr. C. Narampanawa, Consultant ENT Surgeon at National Hospital, Kandy. Your informative presentation would definitely help ENT surgeons and the trainees. And we enjoyed your knowledge of physics a lot. My colleague, Dr. Daminda Domingo Arachi, Consultant ENT and Head and Neck Surgeon at Tapeksha Hospital, Maharagama. Your contribution in organizing surgical workshop and presentations today is highly appreciated. Thank you, Daminda. Dr. M.W. Safrullah, Consultant ENT Surgeon at District General Hospital, Matale, did a wonderful job while moderating the panel discussion. Thank you very much, dear Dr. Safrullah. Annual Journal of the College, CJOL, was published parallel to the sessions, and every one of you has received a copy of it. May I take this opportunity to thank our editors, Dr. M.W. Safrullah, Dr. Akram Rahman, and Dr. Bimanta Pereira, for your great service. Same time, I would like to thank all the authors of the articles, poster presenters, and those who presented their free papers during sessions. A special thanks goes to Dr. Pragati Veerakkodi and Dr. Shashnika Alvis for comparing the event today. President Dr. Asat Veerakkodi was the guiding force behind everything, and the Council equal raised to the occasion to make this event a success. My sincere thanks to all of you. I should especially mention Dr. Ranjit Jaivira, who held the responsibility of scientific secretary when our scientific secretary is away. Thank you very much, Dr. Jaivira. Special thanks goes to the team of the Galdari Hotel, led by Mr. Tariq Nizamuddin, the banquet manager, who helped us many ways to make this event this grand. My gratitude to all our partners, starting from Mr. Piyushan Somarathan and his team for their audio visuals, and Mr. Vimukti Vidanachi at Varandana Graphics for printing, Mr. Samita Kalna for photography, Mr. Kalum Chamara at SK Enterprises for stalls, and Manisha at Gene Workers for conference bags. And special thanks goes to the staff of the college office, Ms. Yasasri De Silva, who was busy in getting things together for us during last
couple of months. Ms. Sanjani Disanayaka and Ms. Nishada Nasir also helped us. And Mr. Asanka at Ward 8 NHSL, he is with us from the beginning. Thank you, Asanka. I take this opportunity to thank our sponsors. Without your generous sponsorship, event in this caliber is unrealistic. We hope you will extend your continuous support to the college. Our platinum sponsor is Mervyn Sons Private Limited. Gold sponsors are Medtronic, Vision Care, Abbott Division of CIC, Vikramachi Hearing Care Solutions, and Technomedics. Silver sponsors for the event are Dimo Lanka, Torrent Private Limited, Sanofi, Sidus Sunshine, Imagen, Beximco Pharma, Calbe, GlaxoSmithKline, Sioka, and Sun Pharma. Other sponsors are ProHealth Private Limited, Avenue Pharma, Sunshine Health, Bago Laboratories, Marks Healthcare, Vision Care, and Morrisons. DS Jayasinghe, Imakimi, and Akbar Pharmaceuticals. Whatever said and done, without you, this would never be this success. All the attendees who to the event, including those who joined online, are the most important. Thank you all. On personal note, I thank my wife Shama and 3 kids. I conclude this with this. Success is no accident. It is hard work, perseverance, studying, sacrifice, and most of all, love what you are doing or learning to do. Thank you very much, and good night.